1, 2.
1, 2.
Good morning, everybody. How's everybody feeling today? How we doing? Good? Thumbs up, thumbs down, lots of thumbs up. Very good. Anybody hit the tables last night, do any gambling? Anyone? Anyone? Little bit? Okay. The better question, the more important question. Anybody win anything? Some's better than none. Sir, you had your hand up. What'd you win? Oh, okay, you played. Did you just break even? No. That's okay. That's when we say, well, it was all for fun. It's okay. Anybody else win anything more or like over $5? No. Okay. Well, beginner's luck is real sometimes. Maybe give another shot later today. Maybe you'll get lucky. Welcome back, guys, to day 2 of our Health 2.0 conference. We're so glad that you're here. And we have another just great fun and educationally packed day for you, full of keynotes and panels and networking. So we're just so glad to be here with you. Want to remind you, any pictures that you are going to be taking, please make sure to do the hashtag health, the number 2, CONF. Very important to help us help you maximize the networking that you're doing here the next few days. It's also going to be a great way for us to share your posts and your content to help share your personal brand and business as well. So before beginning our exciting and interactive sessions for day 2, also want to remind you that if you haven't done so yet, to follow the Health 2.0 conference on social media. I'm going to give you 1 minute. I know we all have our phones next to us. If you guys haven't checked in yet to LinkedIn, make sure you find the page. You're just going to type in Health 2.0 conference, and you can share that you're here. Make everybody jealous back home that you're in Vegas and you're learning a ton. Doesn't get any better than that, right? Except for maybe hitting a buffet. That'll be the cherry on top. Well, with that, let's get this party started. I'd like to first extend my gratitude to our gold sponsors, Analytic and Outcome MD, for supporting us throughout. Whoop, whoop. Outcome, Analytic, are you guys here at the moment? Not yet. Okay, sending all our love to them. And guys, they do both have booths inside of the exhibitors area, so please make sure you stop by, see what they're all about, and see how they can best support you and your business and your team as well. Now we have a fireside chat lined up for you. Automating immunizations, the easy way to improve public health reporting. In this fireside chat, we'll be learning about some new challenges with each passing day. Our speakers will throw light on how to track and boost immunization rates by automating the process. We have Dr. Ebony Dotson, founder and CEO of Healthcare Strategic Consultants, LLC. And we also have, we've gone from 3 to 2, Anmol Gotra, product leader for Nomad Health. I would now like to bring them both up. Come on up, guys. They're going to have a great conversation.
Good morning, everyone. How's everybody?
Morning, everyone.
All right, so we're gonna just jump right in. We anticipate this to be an informal chat between Anmol and myself. As Melissa mentioned, we're down 1 team member. Tyler could not be here, she's ill. So we're just gonna talk very informally about automating immunizations.
Right.
So wanna just jump right in. Anmol, tell us a little bit about what does it really mean to automate immunizations?
Yeah, so before I jump into that, I just want to quickly give my background. So I'm a product manager that's been in the health tech industry for 9 years. I've worked extensively for a very long time with a very major EMR brand, and I might have upset some doctors in here just now by saying that. But I've also worked in the clinical pharmacy setting as well, developing processes around prescription management. And then more recently, I'm with a company called Nomad, where we help healthcare professionals basically, find travel jobs. So I'm taking a break from the clinical side. Going back to the question around what does it mean to automate immunizations, what I think is it's actually developing a process. A process basically, to me is that involves people and tools. So if you think about people that are involved in the immunization process, you have the patient, you have the caregiver, you have institutions, both the health system organizations and governing bodies. So I think it's a process that, and then obviously the tools, right? So whether it's your technical tools or the actual physical syringes, right? So all these things sort of come together to basically give the patient the care that they need in terms of administering the immunization. With that being said, I think what we need to do is, or what my definition is, that you need to put people and tools together, where we develop a habit of bringing people together to really get the immunization to the patient as and when they need it on a frequent basis, if it's one of those recurring vaccines, and have a robust reporting to the appropriate bodies so we can track the efficiency of it and then better make informed decisions around it.
Right. So I heard a couple of things in that, and Mal, that you highlighted. You mentioned process, but you also talked about people. And so I want to kind of flesh that out a little bit more to understand how important is buy-in when you think about implementing new processes, particularly in healthcare.
Yeah, I think it's absolutely important, again, at all levels. And when I say all levels, I go back to, the people that are involved, right? So you need to have uh, buy-in from the governing bodies, the health institutes, and obviously the clinicians as well. I would even make the argument you need buy-in from the patient as well, right? Because we live in a world where information is now dependent on what your source is, could be clouded, or so I think what we as a group, as everybody who's involved in the process, need to come together, make the process a little bit more clear for the patient to understand. And what we need to do is give people the right tools to administer these immunizations as and when it's needed.
Absolutely.
Yeah.
So I know we have obviously a recent example that we can
Yeah.
point to in COVID. We were tasked with, as healthcare workers, um, making sure that we were able to immunize as many individuals as possible with the COVID vaccine. Uh, Talk about that process a little bit. What was your experience? Were
Yeah.
you involved at all in
Yeah.
that?
I'd say, I was working in a hospital care setting when COVID hit in March of 2020. We basically had to change a lot of our protocols around how not only we delivered care for these COVID patients, but what would be the follow-up, care would be for these patients. So, one of the things we did was that of all the patients we discharged, what we did is, when the vaccine was rolled out in early 2021, because we had information, contact information of all these patients, what we did is we reached out to them and we said, hey, uh, you were in the hospital for, COVID. There's a vaccine available here, so, some reference information around it, how you can get it, and really sort of set them up where they can either find their local place, whether it's a pharmacy or a hospital where they can get it, and really what options they have, depending on which route they wanted to go with. So I think I can speak for New York State. I think New York State had a pretty good rollout plan for the most part. Being from New York City, we used our stadiums as a way to basically schedule your appointment and go get the immunization. So we did include reference information like that. And then we also, said what are some of the known side effects for, your doses, right? So that was also sort of included in the information packet that we sent out. This basically kind of, going back to earning the trust of the patient, kind of said like, hey, you can't expect, feverish or chills. So, but that's okay because that's expected from, from some people on the doses.
Okay.
Yeah.
Um, so you mentioned, again, I'm kind of
Yeah.
going back to your original response and digging a little bit,
Yeah.
but you mentioned reporting. Um, Talk to me a little bit about maybe universal reporting or documentation
Mhm.
and how that might be used to improve workflow.
Yeah, I think what we did was, again, I'm going to use New York State as an example because I think that's what I'm most familiar with, and that's where I work. So with New York State, the way it was handled was that depending on where you got the vaccine, it was reported up to the state. So you did get the official, COVID vaccine paper card, and then New York State was keeping track of pretty much everyone who got the vaccine, whether it was one dose or two dose, depending on the type you got. The other thing was that it kind of helped people keep track of their immunization records too, because when people went out, to bars, clubs, and things, they were able to show the New York State app which was the official app as the only trusted source that was one of the trusted sources that was used in New York State to show that, hey, you did in fact get the vaccine. So it made, the reporting of it made it easier for other institutes to say, okay, this person in fact is, immunized, and we can sort of, accept them into our facility or wherever that is. So I think it was beneficial in that format.
It sounds like New York was sort of maybe a good example
Yeah.
of what to do. Are there examples that are maybe not as good in terms of reporting or standardization of the vaccine and
Yeah.
how that impacts maybe patients?
Yeah, I can use myself as an example. When I was younger, and then I was getting my vaccines, it was a way different experience. I think we have come a long way from there, where we everything was tracked on paper, and then if you lost that paper, it was basically, you had to basically go through the entire process, or depending on what age you are, you had to get some of those vaccines again. And I know we now have tools like EMRs and EHRs that basically track a lot of these. And then some of the challenges around, that the EMRs present is, going back to yesterday's discussion, right? You have all this data that kind of lives in siloed systems. Now, if I were to change states to, let's say, Jersey or Pennsylvania, or somewhere further out, where they don't share data with the same system that has all my immunizations, like, how do we sort of get that, right? And I'm sure the data is retrievable, but how easy it is and how accessible it is I think a discussion that sort of extends from yesterday.
Absolutely. So
Yeah.
that brings into the equation sort of the accessibility of the information, but also the efficiency of the process for the patient. So if I'm a patient and my information isn't accessible, it sounds like I'm going to have to redo maybe.
Hopefully not. Yeah.
Okay. Well, I would hope not, but it definitely sounds like there are ways to use automation to our benefit as opposed to paper. You also highlighted, you talked about, you kind of like blurred over this word a little bit, and I want to highlight it because I think it's important. Trust. How critical is trust when we talk about moving from paper to more automated systems and processes relative to how patients interact with the systems?
Yeah. I think trust starts from the clinicians, right? We we have clinicians that are basically, want to give the best care to the patient, right? And then there are, and considering the world we live in, there are instances out there where people may not trust the person, right? So I think what we have to do is we have to become more, sort of like a widespread group around multiple sources, and then thinking we have to get more consistent around these multiple sources, sharing, the efficacy and the benefits that immunizations provide. So a lot of people, are skeptical sometimes. Well, we had the COVID vaccine most recently, and a clear example there. So I think what we could have done better in that example is that more sources coming out saying, hey, this is something that works. This is something that's been tested. Pfizer vaccine, I remember the original reporting was tested on well over 60,000 patients across multiple age groups, right? So fairly safe vaccine. I think the original number was somewhere around 94% efficacy. So, but we had, one or two sources that were saying this, and because we live in a digital world where people can reach other people in so many different ways, I think that's what we need to do, is that find more ways to reach our patients to say, hey, and have deliver a consistent message saying, hey, this is the right thing to do, or this is in fact the right thing to move forward with.
So I work a lot with community organizations, healthcare practitioners, and professionals throughout the state of Georgia. But I know when I'm doing that work, one of the things that comes up often is the lack of opportunity for the community to weigh in on the development of these processes, or be able to just talk to what their experiences would be. I know James mentioned yesterday, he said the answer is always
In the clinical
in the
workflow.
clinical workflow.
Yeah.
But for me, the answer is always in the community, right? Why aren't we involving the patients and the communities in some of these discussions to understand what their needs are and how we might create systems and processes that would actually be beneficial to the patients and or be systems or processes that they would want to use. Any thoughts on that?
Yeah, I think, again, living in New York City, I personally observed, areas of New York City where you have certain communities where we saw when we looked into the data, they would visit a hospital or a PCP when something, would go wrong, right? So either they got sick or something, some chronic illness that they faced. So those were the only touch points that they had in a given, medical facility with a healthcare provider. What we saw in some of the other areas were that you had, more consistent touch points in a healthcare setting, right? So you had people that went to their doctor, twice a year for their annual physical or, a follow-up. You had people with, that have chronic conditions that were having, these quarterly or bi-monthly meetings, and then they also had basically, fewer visits around hospitals when they actually needed it, right? So I think a lot of it also around giving people the resources and the education. So what I mean by that is that, we were so busy with our, our day jobs where we don't, and some of these communities don't unfortunately have the time to get involved in those methods of, becoming aware that, health is important and I should be able to keep track of where I am and what I need to do to keep my health in good condition. So I think some of it also has to be around education and just again, I think sometimes language barriers also come into play. So coming up with community programs which promote keeping your health in check, going for that annual physical, getting that annual blood test is going to be one of the ways how we can improve community input.
Okay.
Yeah.
Are there any tech solutions available that you, I mean, I don't want to say personally recommend, but maybe that you could speak to here that maybe the people in the audience would love to hear about?
Yeah, this is my favorite part about building solutions for large-scale population health. So one of the solutions that we built out in the hospital EMR that was one we did for the inpatient and emergency care setting, and one we did for outpatient PCP. So one of the best ways we can do is, again, I'm gonna kind of reference our friend James from yesterday. Is like the answer sometimes does live in the clinical workflow. So the way we did is like pretty much everyone that's getting discharged from a hospital goes home with discharge paperwork, right? Your discharge instructions. Usually it's a pretty in-depth summary of, hey, here's what you came in with, here's what we treated you for, here's some of the medications you're going home with. Nurses and doctors are both pretty prominent part of this process. So what we did is that during the discharge paperwork, again, everyone's using an EMR. We basically prompted the nurse to ask the patient, hey, would you be interested in getting a flu vaccine, right? And we only enabled this question when the flu season is actually active, right? If they said yes, go ahead, great. That creates an order for a vaccine. A nurse comes in, gives the vaccine, and the patient goes home. And now we have a proof of vaccine administration in the EMR that gets reported out to the state and other governing bodies. If they say, oh, no, and then if they say I refuse it, that's fine too. We track that. We respect everyone's decisions, and then we also say, hey, I did get it, but I got it from my PCP. So we basically took that answer as well, and then again, saved it for our records. Um, Fast forward, what happens is that next year, when let's just say if they came into the hospital again, we can go back to the data and see what they had. They say, oh, we saw that you got a vaccine from us last year. Did you get one again this year, right? And then basically the process gets repeated itself. So um, this is a clear example of EMR being used as a tool to assist our clinicians in helping deliver better care.
Mhm. And so I'm thinking, because I know that many times EMRs don't talk across states or
Yeah.
across facilities or across care settings, how do we fix that? Do you have
Yeah.
any thoughts?
Yeah, I think that's the $1 million question. I can personally attest to this issue because I had somebody in my family who had surgery recently, and they had to get all this pre-surgical testing done. Their PCP was using a different EMR. The hospital where he was supposed to get surgery was using a different EMR. So you can imagine all the hoops we had to jump through. Um, I, you know, I want to go back about 10 years when the ACA bill was approved, and what it really did was it really helped, it's actually incentivized hospitals to move towards from a paper chart to, and what that did was basically propelled the revolution of healthcare data, right? I think most people here would agree that about 20 years ago we didn't have a lot of healthcare data, especially population health data. But if we look back about 10 years when EMRs really became the sort of the center, we have all this non-clinical data. So now I think the challenge is that how do we get these companies with their proprietary policies to share their data? And I think we might have to look to another either incentive or some form of regulation where it promotes the sharing of the data across systems while maintaining PHI standards, of course, where it's easy for a patient, whether they're going next door to a doctor or across the country, to be able to see that data, from one computer screen to another.
Okay. I have one last question,
Yeah.
and it's a selfish question before we open it up to the audience to see if they have any questions or would like to contribute to this discussion. But one of the many hats that I wear is teaching. And I teach at Morehouse School of Medicine in the Health Informatics program. And so as I'm training this next wave of thinkers and problem solvers, what are some of the things that we need to embed sort of in the training and the curriculum for those individuals to know that when they enter the workforce, there are problems that need to be solved, such as automating immunizations or creating EMR systems that do talk across lines, whether that's the care setting line or a state line or what have you. Any thoughts?
Yeah.
Any recommendations?
I have two thoughts around this personally. I think technology should be there to assist a clinician in helping deliver the care. Um, and I say this because we're moving towards, just taking healthcare out of the picture. Anything else you look at, right? Finance, marketing, or anything else, they're more heavily reliant on technology because they have set certain rules on how business or workflow is. That's unfortunately not the case when it comes to healthcare. And every patient, and I think every doctor sitting in here can attest to this, right? Every patient can react differently to a medication, or whatever disease they have could be treated a little bit differently compared to a different patient, right? So I would tell them that, hey, use this tool to assist you, but you still should be making the decision at the end of the day. And the second thing is, and this is what I think is part of the problem with the digitization of healthcare, is that we have more people spending time in front of the screen than with the actual patient. So I would tell them is like, just turn this way and actually talk to the patient while you're, because that's what they're there for. patient doesn't know what's going on the computer screen, right? But you do. So I think it's a level of communication that needs to be improved when interacting with the patient. So, come on. Yeah. Okay.
I think you have to
All right.
turn your
Yeah, I
head.
think I might have to turn this way.
Okay. I think that's good advice.
Yeah.
I do think many times we talk about patient care, we forget that the patient is the part of the care.
Right.
So having conversations with them is critical. So I'm going to stop there and open it up for questions. Do we have any questions from anyone in the audience? It's a race.
All
The
right.
mic. Oh,
No.
well, there are two behind you who made their way to the mic, so we'll come back.
So I got a couple quick questions. The first one is that when you're looking at this as sort of a tool, the first thing that popped into my head is, would this type of system replace something like VAERS? And VAERS is the Vaccine Injury Reporting System, which, according to the 2017 Pilgrim Harvard study, was reported at only 1% of estimated total vaccine adverse reactions. And the reason is it's too darn hard to go through that system. So if you want to automate an element of vaccines, the whole issue of adverse reactions is becoming very important. There's got to be a way, and I'm thinking that's what I'm hearing from you, to streamline a process where a doctor or a clinician can go in, and instead of spending 3 hours trying to figure out how VAERS works, you've got a system that you can plug and play in 10 minutes. Am I correct in?
Yeah, I think my thoughts around that is that I think reporting is a key piece to this. So you have, let's just play this out, right? So you have a patient that goes to a doctor or a hospital, they get their immunization, that gets recorded and sent, that information gets sent to a governing body, right? Let's say if that patient also, experiences some adverse effects, I believe that's also should be reported, and I don't think we're there yet, or I think that, at least as far as I am aware, that the effects or the follow-up effects are not being reported, to those appropriate governing bodies.
Right. VAERS is, from what I understand,
Yeah.
VAERS is a very, very, very difficult system to
Right.
navigate if you're
Yeah.
a nurse or a clinician. So hopefully you're going to streamline that process. And the second thing you talked about was trust. And this whole COVID issue has really, I think, put a nail in the coffin of a lot of people in terms of trusting the whole issue, where they're
Yeah.
only doing vaccines versus, I mean, the Joe Rogan experience with his ivermectin just created this national fury. And there's a group of doctors in Detroit, Michigan that published very early on the effects of vitamin D and vitamin C, and their paper was retracted. So
Right.
when you're talking about the whole trust in the system, is your algorithms or whatever going to be something where people will find it just much easier to sort of navigate the system in general?
I think so. There's two thoughts around this. Is I think we have to make it easy for people to access this information, and I think what we don't do enough a good job is the CDC. I think there's some things that did great during the COVID era, and then there's some things that didn't do great. I think it was being more consistent around how we deliver that message, right? So what I would do is that I would say is that we need more sources that are verified to say, hey, and then again, these sources need to reach all types of populations, right? To say, okay, whether you're in the Northeast or whether in the South, whoever the audience is, they need to reach them and with a consistent message, right? So someone that's in the Northeast or someone that's on the West Coast, I believe, should be getting the same message. The second thing I like to say is like, well, if you, God forbid, if you get a heart attack, right, or something bad happens to you, you're going to go to a hospital, right, to get care taken for you. These are the same people that are telling you, hey, get the vaccine. So if you trust them with a heart attack, why would you not trust them with a vaccine, right? So that's the argument I like to use. So I feel like we had opportunities to be more consistent in delivering the message. And the second thing, and I think this is the most important thing, is that science and vaccine development, it's based on data. And in the beginning, we didn't have data, right? And we didn't have and as we were treating patients, the treatment plans evolved over time, and we adapted, right? Because we figured out what worked and what didn't work for the patients. And I think that also needs to be a message where you can say, okay, in January, this is what we knew, and this is how. In March, we learned this, so we're going to update our treatment plan or our data to reflect that. And I think that's another key part of the equation to helping.
I want to just jump in on the last gentleman's question just slightly on the trust piece. Because again, I think something even more fundamental than that is understanding the communities that don't trust. Why don't they trust? We have a lot of undoing that needs to occur in the healthcare and medical space that I don't think we talk enough about. I think Dr. Nguyen, who was up here yesterday, kind of alluded to addressing racism, addressing bias, addressing how we train AI systems and the things that we're talking about implementing in these communities. And I think until we're willing to have those conversations, until we're willing to actually be in those communities and engage with those stakeholders to say, what is it that you need and how can we build this system to support your needs? I think we're gonna kind of always be going backwards in a sense when we think about the systems that we've created.
So a lot of what you're really talking about is how you make it easier for people to do the right thing, both providers and the patients, the clients that we're serving. And again, I call back yesterday, I mentioned the book Nudge. That's really taught me a lot and got me thinking a lot about things that we had done. So during COVID, we did church events. And the minister would get up, talk about an influence and say, it's your duty as a Christian to get your to protect your family. By the way, the Parkland van is sitting outside. You can get it at church today. We did those. We helped providers create alert systems. In one of our systems, not immunization related, but asthma vaccines, we put an alert in for high-risk asthmatics that said, remember to prescribe the inhaled steroid. We increased the prescribing in 2 practice settings by 50%, but only 10%, one of them, the amount of fills only had 10%. In the other one, it increased 75%. What was the difference? The one where it increased by 75%, they've actually filled the prescription on the site. In the other place, the patients had to wait 2 hours to get their prescription. Nobody waits 2 hours. There's just a couple of them. I got a whole bunch of ones that we tried where we got our immunization rates up. And in Texas, I would point out that the Medicaid population has better rates on the Medicaid managed care organizations have better rates on half of the HEDIS measures than the commercial population. We've addressed the disparity issue in a creative way, and that I think is not highlighted when we talk about all the other disasters we have in Texas in politics. So thank you.
Agreed.
Thank you.
Yep. Thank you.
Okay. Yeah. All right. I think this lady right here. No time. Sorry. You can just
Discuss
see us
offline, yeah, if you want.
offline, and we'll answer your question.
Great.
Thank you guys for your
Thanks,
time
everyone.
and attention today.
Yeah.
If you'd like to connect with us or have additional conversation, Amal and I are sitting in the back. Thank you so much.
Thank you so much, guys, for sharing that insight and for all of your questions. Yes, please be sure to go see them during the break to continue the conversation. Next, moving right along, we have Justin Salomon, our gold sponsor, whoop whoop, CEO of Outcome MD and keynote speaker of the day, who will be sharing his thoughts on the future of health outcomes, not opinions. Justin will shed light on what the future holds for the healthcare ecosystem. The session will center on the idea that healthcare should be more individualized based on the person's requirements rather than being a one-size-fits-all, and more preventative than reactionary. Join me in welcoming Justin up on stage with a huge round of applause.
I think they're queuing up the slide deck here. I am Justin Salomon. I'm an orthopedic surgeon by training. After fellowship, I pretty much just started companies, several of them, some in the surgical device world, OutcomeMDs in the SaaS world, and PaaS world, platform as a service. And so I'm going to just talk a little bit about why it's just so critical that we shift the way we're thinking about what we're doing and focus on what really matters. We need to measure what matters, and that is a patient's symptoms and quality of life and how they change as a result of our treatments. So you say, well, how do you do that? The medical literature actually has this all figured out for us. We just follow what they do. Enroll every single patient into a clinical study without consenting them for research. And you can do that because there are these things called patient-reported outcome measures that already exist. They've been built over the last 130 years by specialists in every specialty in medicine, because everything's been studied. And they came up with question sets and scoring formulas for how to measure a patient's symptoms and quality of life burden over time and see how they change. It's decision support from day one to score their symptoms and decision support throughout the journey to keep track of how they change. This is objective. And the reason it's objective is because these question sets have been validated and compared against other ways to determine an outcome. How has the MRI changed? How the lab values changed? How has the physical exam changed? And if they don't statistically significantly correlate with how these things change over time, then they're thrown out and they write new ones. So they're validated is the point, and they're objective. And I argue that they are the most, and it's not just me, they're probably the most important measure of how someone does over time. And the reason, I'll give you an example. So I'm an orthopedic surgeon by training, but OutcomeMD works across every specialty. But I give orthopedic examples. So imagine you have hand surgery, and on X-ray and MRI, it looks perfect. Complete healing, no edema in the bone, really good result. On physical exam, patient has full range of motion. Seems like a pretty good outcome. But let's say that every single time they touch something and every time they move their hand, they have searing, burning pain. Actually a pretty lousy outcome. So how have the patient's symptoms and quality of life burden changed as a result of their treatment is the most important outcome. Look around, there are people everywhere. There's results everywhere. We just don't keep track of any of them. And I'm going to show you throughout this presentation how if we just make this shift to keeping track of this stuff, yeah, sure, value-based care is, of course, completely hinges on knowing what works and what doesn't work. But you'll also see how the fee-for-service world also benefits from this kind of a technique. So a couple of other background things. We should be doing this, like you use a stethoscope on every single patient, maybe, or you do a physical exam on every patient. How is it possible that we don't measure a patient's symptoms and quality of life burden since there's a way to objectively do it? The patient walks into a room, the average doctor interrupts that patient after 11 seconds. Okay, this is from Journal of General Internal Medicine a couple of years ago. 11 seconds, and at first it's like, are you kidding me? That's horrible. And then I thought about it. No, we really do. The patients will go off on this crazy story about how their dog and this thing, and like, it's not helping you make a medical decision. You try to bring them back into the lane where you need to document in order to get paid for this visit, and also try and make an efficient decision so you're not spending 2 hours with the patient, right? So we really don't have time to fully assess the patients. And the truth is, we haven't memorized the perfect questions to ask a patient. We ask whatever random 3 or 4 questions we think of to assess their symptoms, even though the validated perfect questions are there in the medical literature. But it's ridiculous to think that we should be memorizing them. We certainly can't memorize the scoring formulas and do that quickly in our head, right? So we just don't do it. It's more Gestalt-based, right? But we really should be doing this on every patient. And the data that comes from this is jaw-dropping. So if you look at electronic medical records, we built these things 35, 40 years ago because One, because it's a good billing system, but two, because we thought the big data, it's going to cure disease, right? And it's done nothing but really piss doctors off. And then about 10 years later, correlation algorithms started to come out, and IBM makes Watson, and that too did nothing but piss doctors off. Epic made a decision support tool, and they had to pull it from the market. It was actually hurting people. And the question is why? Why have electronic medical records and correlation algorithms not cured disease? And the answer is that there's no outcome data. There's no outcome data anywhere in the electronic medical record system or our system at all. Yes, you can mine infection rates, rehospitalization rates, length of stay, number of procedures done, but that's all sort of inferred metrics. And star ratings are the worst thing to possibly go by. It is tearing down our healthcare system, turning every doctor-patient interaction into an era of blackmail, right? We patient cater, we don't patient care, because my business model is dependent on making you satisfied. If we have this data, though, everything changes. Oop, I just want to, let me go back. I want to play this piece of audio because this is interesting. So this is a NPR gentleman who's interviewing a Kaiser executive and asking her, why have electronic medical records and correlation algorithms not cured disease? And her answer is very interesting.
That's pretty bare bones information. Ideally, these medical records would provide a much fuller picture of a patient's emotional state. But Lou says that would require more work for the patients.
Your patient, and someone says, "Gee, we'd like you to fill out this 30-item survey on a routine basis." You're going to say, "Why? What will this get me? How will it help my care?"
That's one of the many problems researchers will have to solve in order to make these electronic medical records deeply useful in the world of strategy research and practical information.
So basically, what she's saying is that patients don't want surveys. Of course they don't, right? And especially if there's no meaning behind them. Patients will do things for two reasons. One, it's interesting to them, so you got to figure out how to do that. And two, the doctor is saying, I need this information in order to figure out how best to treat you. Those two things added together, and they will do it, and we've proven that, okay? So what we've done is turn these patient-reported outcome measures from the medical literature into a fitness tracker-like experience for the patient, and then created a billion incentives around it for the doctor to the point where they really want the patient to do this because they're making more money as a result. So the first part of this looks like this. So the patient gets a text message. There's no app to put on the phone. There's no username or password. They just click a link, right? And when they click the link, they just put in their date of birth. It shows a little animation so the patient has a sense for what's going on and that this is going to help them keep track of how they improve over time. And then it just asks for their date of birth. It's all white labeled. This is API based, or you can use the software as a service either way. So it can really feel like your own user interface. And the patient quickly measures their symptoms either with your existing survey engine or with our survey engine. And then we do some cool stuff around the scoring so that if you want the patient to see their result, turn it into fitness tracker-like experience, we can take that raw data and turn it into a scorecard for them. It takes about 3 or 4 minutes for a patient to complete this. 97% of patients that start an assessment finish an assessment, okay? And they get to see their score. And then there's a timeline on this page, there's all sorts of cool stuff. When they are doing better, it animates like the, oh, I'm sorry, so let me go back. So this is their starting point score, all right? Now, 3 months later, or whatever it is, after they've taken their medicine for a little bit that you prescribed, they've done the therapy that you suggested, or they've had surgery, whatever the treatment, or benign neglect, whatever the decision that was made was a treatment decision or a non-treatment decision, right? But a decision of how to handle this person's medical problems. 3 months later, they're sitting on their couch. And they get a text, and it says your previous score is a 30. Let's see how you're doing now. They just have to be curious. You know, when you go for a jog, you're curious about how many steps you took. How far did you run, and what was your heart rate, right? So we're just playing on that curiosity. They remember that it was easy. There's no app, there's no username or password, and it took just a few minutes. So they click the link, and they answer the questions again after they put in their date of birth, and they get to see how their scores improved, right? And thinking how a patient thinks, of the improvable range, how much have I achieved, right? So their score was a 30 in February. Now they've improved to a 73, and of the range they could get better, they've achieved 61% of it. This engages the patients and makes it interesting to them, okay? And the doctor wants them to do it for all sorts of reasons I'll show you in a second. If the patient's getting worse, it animates like this. And they're not surprised. They feel worse, right? And 1 second later, after this animates, their phone rings. Well, who's on the phone? That's the doctor's office calling to check in on them, right? So now this is true connected care. Now, how does that work? Well, as soon as they answer the last question, the math is done very quickly on the servers, and we instantly text and email whomever on your team you want at different thresholds, okay? For example, we empathize with the providers all the way through. So I never want to be notified for an eczema patient who's doing poorly and getting worse, right? Because who really cares? But for an angina patient who is post-MI, is on these 3 medicines, is in this age range, I want to be notified if they're doing poorly and getting worse below a 10. And I want my PA to be notified if they're doing poorly and getting worse below a 50. So it's really easy to set that stuff up within the software, okay? So as soon as the patient sees this animation and they're within the bad threshold, right? They're doing poorly and getting worse. The PA or MA or doctor themselves gets this message text to them. There's no PHI in it, but it gives you a sense for who, it's this age patient, and they were assessed for this problem, and this is what their score is doing. And when you click the link, you Face ID into our iOS app. So now you can, in a HIPAA compliant manner, see this patient's information and what's going on with them, okay? And you can call them with caller ID blocked, the way I like to call my patients, right? So they're not texting you a minute later. This is true connected care. Now, if patients are doing great, they love you. If patients are doing crappy, they love you because you care enough to check in on them and to intervene, right? And this has been shown to reduce readmissions. It's been shown to reduce complications. Here's a study in the Journal of General Oncology. Journal of Clinical Oncology. They basically, there's 2 cohorts of cancer patients, identical in every single way. The only difference between the 2 cohorts is that in one cohort, they actually tracked 12 symptoms of cancer complications, basically, and the other they didn't. So they had a PRO of 12 questions, a validated PRO, and when someone was doing poorly and getting worse, a nurse was notified and intervened. Those patients, the only difference was that they were sent PROs, and a nurse got notified if they were doing poorly and called them. They lived 5 months longer. It was a big sample size. So there's lots of studies like this. So beyond the fact that the data is the most valuable data in the world and can really cure disease and really cure the American healthcare crisis, it also has applications to clinical care right now that are pretty profound. We also give this timeline visualization of care. When you think about it, every single thing you need to know about a patient can be shown on one timeline. Their entire past, every single endpoint from the EHR dropped on a timeline as a flag. All the medications, procedures, diagnoses that they've been through are in the EHR. They're plotted out. And then everything that's in the future is also plotted out, right? But what a patient really cares about is what are the things that I've been through that have resulted in my improvement in symptoms or worsening in symptoms. So this adds to the fitness tracker-like experience. It's integrated with the medical record system to the point where it pulls in the endpoints, and the patients can add things that they'd like to track. Oh, I'm starting a keto diet. Boom, shows up on the doctor side and the patient side. The right side is the patient, the left side is the doctor. And they build this timeline together, unified as one with a united goal of getting improvement in symptoms. Every time, it's even possible to be able to click a V icon on the bottom of the graph, which is a visit, and see a PDF of the note from that day, and there's your physical exam. So pretty much everything you care about is here. The other thing we track are confounding factors. These also plot out here. So when you see lost and changed jobs on this timeline, that's an example of a confounding factor. We track adverse life events and stresses, social determinants of health, new injuries. I'll explain new injuries in a second. Patient compliance. With every follow-up, we ask patients, how closely did you follow your doctor's treatment plan? And we ask that, and then they rate it out of 10. And since it's their own fitness tracker-like experience, we're seeing people rate 4 all the time. If they didn't take the medicine, they're not going to get a good result. If they weren't non-weight bearing, maybe they're not going to get a good result. Like if they weren't compliant with the doctor's treatment plan. And then on the example that I like to give is if I replace your right hip, and 6 months later you break your right ankle, your function is down and your pain is up. It's not because I didn't do a good hip replacement, it's because you broke your ankle, right? And so we need to be able to create an inclusion and an exclusion criteria around all of the things that make this feel fair. And if it doesn't feel fair, a doctor's not going to use it. Inclusion and exclusion criteria are what you do in an FDA study or clinical trial. So is it ethical to think about it that way? Yes, that's the right way to think about it. And then there's also a dashboard where you can dial in best practices to know what works and what doesn't work. It's filterable all the way from the top. Let me just, on the dashboard, this kind of thing is where you really can figure out what protocol works best, which medication works best in your hands. And it shows you in real time your outcomes. And it's not just those that you enrolled in research, it's every single patient that walks through the door. The key to value-based care, by the way, is being able to dial in the best practices. And the key to being able to dial in best practices is having outcome data, and none of us are doing it. It's crazy. Okay, so that's everything I've shown you so far is elevate. We say you should elevate and celebrate your outcomes. Don't just elevate. That means tracking outcomes actually improves outcomes. I think we've talked about that enough. Now I'm going to talk about how you can celebrate your outcomes, right? This is shifting the doctor's business model from patient catering to patient care. Every great outcome, we should be celebrated. And so the way this works, we did a lot of studying, and we found that patients who achieve at least 50% of their improvable range love their doctors. They're bringing you a box of chocolates and a bottle of scotch, right? And so when we see a patient has achieved 50% of their improvable range, then and only then they see a pop-up that allows them to endorse their doctor by posting their great results on their own social media or on the doctor's review sites. When it goes on their own social media, it looks like this. The average Facebook user has 338 friends. When one of their friends sees this post and click it, it goes to the doctor's website. This is also a cathartic event for patients. We have use across every specialty, but the one that I'm shocked by is the ketamine clinics. Their patients are posting left and right that their PTSD and anxiety and depression are better. If you think about it, their network, their friends, they know that they're struggling with these problems. And this is a moment for the patient to say, hey, I'm better, you know? And it also celebrates the doctor at the same time. So that's lead generation, and then we also copy into the clipboard. If the patient chooses to not post on social media and they'd rather post on their own review site, on the doctor's review sites, we copy into the clipboard a summary of how the scores changed, and we take them to that doctor's review site to post it. And so this is a real one on Yelp. My knee symptom score was 20 before, and my score's improved to 91 so far. Thank you so much, Dr. Kabai. Pushing objective score data into a subjective review site for the first time in the history of medicine, and this is a more impactful post. And there are a bunch of other ways that I'm not going to get into today where we drive value, marketing value, from these posts. Celebrate your outcomes. Outcome marketing is what we should be focused on. Get great outcomes, and that generates more business. If you think about the data, you know, you're enrolling every patient in a clinical trial, but you're doing it for clinical care. You're doing it for decision support from day one, decision support throughout the patient journey. You're doing it for a timeline visualization of care. You're doing it to be notified when someone's doing poorly and getting worse. For all these reasons, it's for clinical care. So this is a normal IRB process when you're trying to prove something works or write a study. And this is the process when you're tracking outcomes for clinical care. The IRB views it as a chart review. So you can actually look in the dashboard and see what's working and what's not working. Turn on inclusion and exclusion criteria around all of the medical record data, all of the confounding factor data, and the patient-reported outcome data. Figure out what's working and write a paper on it by clicking one button, export, done. Send it to the IRB. They say, oh, approved, chart review. You don't have to consent patients for research, and the sample size is huge because everyone's enrolled. What are the things that are missing? Two things are stuck in the patient's brain. How have their symptoms changed over time and quality of life, and confounding factors? Got to structure data around both of those things, and we change the game in healthcare. This is a cool thing that's coming. So decision support tools, I said before, didn't work. Watson's BS. But if you have outcome data, all of a sudden, it's incredible. So the EHR, electronic medical records, health records, they know the patient's phenotype. That's the one thing an EHR is pretty good at, is what's this patient's phenotype? What's their age, gender, body mass index, race, medical comorbidities, zip code? Like, you know, who is this patient, right? And then Outcome Warehouse, like what we have, has results from patients similar to this one all over the world, right? So normally, before a software like this, maybe you put them on drug B because for whatever reason, you know, they have a nicer drug rep, or for whatever stupid reason we make decisions, right? But now in front of the patient, you can flip around your screen and say, look, drug A or drug B, let's figure this out together, right? And click a button in the EHR and plot it out. Each dot is a different de-identified patient somewhere else in the world who's phenotypically similar to the one sitting in front of you. Full wellness is 100, right? Full function, no pain is 100. So I'm going to put this patient on the blue on the purple drug, right? Drug A. And the network effect here is crazy. What is this? This is an instant, prospective, multi-center, randomized controlled trial done on phenotypically similar patients at the point of care with enormous power. It's not what 30 patients did they study in Kansas. It's 30,000 patients from all over the world who are phenotypically similar to the one sitting in front of you, right? I mean, this is what we should be doing. It's only an art of medicine because there's not enough science, right? And then finally, here's how we cure disease. And this is the future of medicine. So, you know, at first I thought it was cool. We're gonna know which implant works better, which drug works better, which technique works better. If you look at it, you'd say, well, we should drop implant A because implant A doesn't do as well as B or C, but not so fast. First, we should ask a very smart AI or correlation algorithm or computer or robot, show me all the cures. What do they have in common? So it goes through and it looks for every patient that had 99 or 100 on their PROs, patient-reported outcome measures. And as it turns out, 2% of the people who had implant A were cured. What do they have in common? Maybe it's that you need to receive implant A and be on vitamin B12. That's the cure. The human brain can't figure this out. We cannot sift through enough data fast enough to be able to tell this. But a computer that is actually fed outcome data plus the electronic medical record data and compounding factor data can figure this out. You talk to any oncologist, they'll tell you they don't know why one patient's cured and the next one's not. They'll also tell you that they believe if they could pool their knowledge with every other oncologist who does the same types of treatments, that they could cure their diseases. And that's it. So I can take questions.
Hey, you know I'm a fan of your software, and I'm glad that you actually talked about clinical chart review. So my question is kind of a big one. Based on what you just talked about, are we seeing the death of randomized controlled trials in this country?
Yeah, no. So
because what you talk about seems to be so much more robust just based on that last sample.
it is more robust and it's more real time. But if you think about this, so I'm a doctor and I'm getting crappy outcomes and I can now see it for the first time. You'd be shocked. And am I a good orthopedic surgeon? I don't know, first of all. If I don't track my results, I really don't know. If I mess up your knee, you'll go see someone else and I'll think you did great, right? So now for the first time, and maybe I'm good at ACLs and I'm terrible at rotator cuff repair. So am I good? I don't know. So you come to see me and I can see now that I'm terrible at rotator cuff repair. So I want to get better at rotator cuff repair. So I need to read some other doctor's description of what they're doing, and I need to believe that that doctor is getting good outcomes, right? So now if there's a way for me to know that this other doctor got good outcomes measured the same way that these things are measuring them, and by a third party like OutcomeMD, this company, right? Now for the first time, I'm gonna read that doctor's study, and I'm gonna do exactly what they did because I believe their outcome, and I know that mine isn't good. So what's important in the medical literature is that we're describing what techniques we did and sharing it with the world so that, and then we can objectively say, here's our outcomes, and we didn't even track it. We had this third-party software. So this is all is legitimate. Because right now, Neil Elatraj is a shoulder surgeon down the street, and if I read a study, I'll throw it out. And I'm like, he's paid by Arthrex, right? But if I see that I stink, and I see that Neil's using OutcomeMD, I'm like, I'm gonna do exactly what he's doing because he's figured out how to get good outcomes. So the medical literature still has a very significant place in doctors explaining what they're doing differently that's getting them the best outcome so that we can all elevate our game.
So, and quickly, from a patient perspective, and one of the things that when you and I met years ago that I liked about your software is that it doesn't do percentages or whatever algorithms. It looks at like a credit score. I went from 50 to 78, and people understand that because they understand what their credit score is. Do you think that's why your thing has such good value?
Yeah, I mean, I just think that prior attempts at outcome tracking have not engaged the patient or the provider. We still calculate the raw data, so it's all right there and you can use it for your clinical studies, but the promise is an example of a patient-reported outcome system, and they use theta values. So a negative 0.562 theta value is useful to nobody but a researcher. So we just basically take it and normalize an average and do a little bit of math, but it's still a representation of the raw score. And now all of a sudden it's interesting and understandable to a patient. And we do what the International Consortium of Health Outcome Measures does, in that we create these sets and bundles, because sometimes it takes more than one patient-reported outcome measure to get a condition score. We're their only technology partner of ISHCOM. Go ahead.
Have you seen or done any work in comparative effectiveness, particularly? It seems to me that what we have in a lot of, particularly the specialty drug areas, enlarging pipelines. And so you have, 20 different psoriasis products. If I'm looking at that as a practitioner, I have no idea what to use. And of course, this is one of to me, the biggest failing of the Affordable Care Act is that they removed the comparative effectiveness requirement because the drug companies are not going to do the studies they can't afford to lose.
Yeah.
So have you done any of that sort of stuff?
Well, so the providers are going to be able to, the provider now wants to get a good outcome. So they're going to try to figure out which one is the best and then use that one, right? And before this, you don't really care about getting a great outcome. You need to get a good outcome and tell good jokes, right? And if you tell good jokes and you're on time and you waive copays and the lighting in the office is good and the parking is great, you're going to get good reviews and you have a sound business. You don't need to get great results. You just need to get pretty good. Patients don't know. They figure anyone would have given me a 70% good shoulder. The guy's so great, go to him, So I do think the best is going to rise to the top in the end as we really start to measure this stuff.
But
and
the
then
insurance companies are going to make decisions based on the data, and that will drive some of the utilization by providers.
insurance companies have a big part in this, for sure. But in the end, the insurance company is aligned with the patient to some extent, and that is, if the patient gets the best treatment the first time, right? They get that treatment for psoriasis and it's the right one. They don't buy 3 other drugs. They don't have to buy stuff for their skin. They're not seeing 12 doctors. They saw one doctor, got the best of the best. It's working well, they move on, right? So, this data is just as valuable to them and they want this to work as much as anyone.
Hi, great talk. Yeah, your software is pretty amazing. And so Barry and I will be on the health equity panel, and we'll talk about data sharing. I think you have awesome machine learning data, as you showed earlier, right? The 30,000 patients. If you would de-identify it and archive it on Kaggle, right? You'd give that access to scientists around the world, and it'd be good branding for your company because your technology is pretty amazing.
Yeah, I mean, the future is going to be about figuring out ways to cure disease and shift our models into something that makes more sense. And eventually, like I said, it's only an art of medicine because there's not enough data. So let's be scientific.
Thank you so much, Justin, for sharing your thought-provoking ideas with us. And of course, guys, be sure to stop by the Outcome MD booth and check them out. Keeping up in the theme of outcomes. Next up, we have a panel discussion on the topic, Boost Your Patients' Outcomes by Connecting Their Mental and Physical Health. There has always been a relationship between mental illness and physical well-being, of course, but few studies have analyzed how they affect each other, really. This session will explore past mental health's direct and indirect effects on present physical health and what causes changes in current psychological and physical well-being through lifestyle choices and, of course, social ties. Let's hear it for our moderator, Mark Pugh, from Provost and co-founder of WorkCompCollege.com, who will introduce us to our panelists. Come on up.
Thank you. Good morning. Excited to be here in Vegas. Last time I was here at Mandalay Bay was the Workers' Compensation National Conference. It's a little bit different here. I know everybody at that conference. I don't know anybody here, but really excited to have Vanessa, Abe, and Winnie on our panel, and we'll have them kind of discuss kind of their background and start. There is one person that was going to be with us, Tyler, but she became ill earlier today, and so she's not going to be able to join us, so that just means a little bit more airtime for everybody here. But we decided, rather than me standing up and kind of pontificating and asking awkward questions, that I would just sit down here with them and be just a panelist along with them. So I'm going to join you guys here. And the first question that I want to lay out here is all of y'all are high achievers. We've got two people who are very focused on trauma. And we've got one person who could run a 5K while she's doing this, doing this panel. So was there a moment in time that precipitated your path towards this? So everybody has kind of their own history of how they get there. Winnie, in our initial discussion, you're talking about everybody has kind of a health password. You have to figure out what that password is to kind of unlock their health. I thought it in terms of a career password where I had to figure out what I wanted to be when I grew up, and eventually I got the right combination. So Vanessa, I'll start with you. What was the moment in time? Was there a particular thing that came to you and explained to you that this was going to be your password for what you do? And oh, by the way, go ahead and explain what you do, just in case they didn't read the program.
Sure. I am Vanessa Bovenholm. I own a 32,000 square foot gym in Fort Worth, Texas. I have an app, Fitness 23, that I help mostly senior citizens and people who are somehow disabled or 100 pounds overweight, not used to exercise, actually get fit. So I do it through live Zoom calls with them, plus a program they can follow. I wrote an Amazon bestseller in fitness called It's Your Body, Move It, Love It, Live, which is the story of how my clients got better physically and mentally. And I have a nonprofit called Exercise in the Streets, which gives running shoes and clothes to foster children and incarcerated youth, and we help them with exercise. We go into jail systems. So that's my entire life, actually. So I'm exhausted already just talking about it. But no, I was 13 years old. I was a little over 200 pounds, and somebody convinced me I should probably get fit before high school. Frank Shorter was my hero. I wanted the character of Frank Shorter. I did not want to be an athlete. I did not think I had the possibility of it. But I discovered when I started to run and drop 60 pounds over the summer that I now became a reader. I now became social, and it changed me mentally, not just physically. So anytime in life that I feel sad or things are going wrong, I take a run, because somehow the endorphins go off in my brain and I can think better and move better.
I actually have a friend of mine who was involved. She's actually an injured worker, but she was involved in a car accident and broke her neck, and she's an incomplete quadriplegic. She did take drugs for a bit in time, but she doesn't now. And her antidote, her anti-anxiety drug, her pain medication is exercise. So this incomplete quadriplegic who can't really move the left side of her body and has constant tingling pain, when she feels like you felt, she gets out and exercise. And I hiked with her in Tahoe one time, and she was amazing to think about that. So the mental health is tied to what's happening physically in your body when you're exercising. Absolutely. Abe, what about you? Tell us a little bit about you, and then kind of what was your moment in time? It's like, okay, now I'm going to be Abe 2.0, right, to borrow a phrase.
Yeah, so I'm Abe Reichlin. I currently own and operate the Trauma Academy Northwest in Salem, Oregon, and that we do education, consultation, and training in the area of trauma, as well as have a group practice outpatient clinic that specializes in body-oriented treatments. So that's sensory motor psychotherapy, eye movement desensitization and reprocessing, Reiki, labyrinth, and some other things that I don't need to go into right now. In very short, my moment was well, I should say that when I was raised in a household that was surrounded by mental health. And so I was around it my whole life. And so it had always been an option for me. I'd learned a lot about it. And when I got into high school, I looked into social work, and I thought, yeah, that's the field that I want to go into. first, before I wanted to go into social work, I wanted to get a degree in German. So I studied abroad twice and learned German. And then I decided to go to my graduate program in social work in Boston. And so it was in that program that I took a trauma class that blew my mind away. I had read a book by Dr. Bruce Perry. The boy was raised as a dog, or something to that effect. The boy who was raised as a dog, that's what it was. And I actually, after I read that book, I contacted Dr. Bruce Perry and told him that I want to come work for him in Houston, Texas. And he actually responded to my letter, and I was grateful, and I met him, and you know, it goes on from there. But that was the moment that I thought, okay, I could do this for a living.
So you grew up understanding the importance of mental health. Both of your parents are psychiatrists, so you kind of understood that. But it was until you had that one course in college that is like, okay, this is how I can direct and kind of pay it forward and help other people, right?
Yeah.
Absolutely. And it was interesting when when we asked that question, you immediately went to that. So it was like, Vanessa, the same thing. I mean, you knew immediately when you hit that. Winnie, interesting story. We had some time during breakfast to kind of share what your background is, from the ones and zeros that you started with to the pins and needles that you're in with right now.
Yeah, so I am a trauma-informed licensed acupuncturist with 4 science degrees. The first 2 degrees were from MIT in computer science, electrical engineering, and in finance. And I must give everybody a confession, which is I was in school during the dot-com era when everybody was beginning to make Amazon, Google, Facebook. So everybody said, okay, let's major in computer science because we want to make money. So what did? I follow everybody. And so all this talk about data and AI, it's really exciting. However, I am a non-traditional person. I don't really consider myself an expert. I'm a hacker. So my philosophy with life is I'm an engineer. I am here to solve problems. I'm here to solve my clients' problems. And whatever it took, I went the extra mile to solve their problem. So what happened was in 2009, I was in a spinal injury. And because of this injury, my coccyx was curved, and my neck started compensating. And all my organs were sitting at the wrong place. Can you imagine? Your intestines are in the wrong place. Your bladder is in the wrong place. Every inch of you is hurting, like neck pain, shoulder pain, knee pain, ankle pain, hip pain. And so I was like, well, in the beginning, some days I spent 3 hours a day crying in my depression with this chronic illness, physical handicap. I can't play tennis anymore. I can't dance. I can't hike. I felt like a total loser. And then I was like, well, maybe I can go to acupuncture school and reinvent myself, right? So I did go to acupuncture school, and 2 years into the program, I had a near-death car accident where, well, of course I'm here, so I didn't die. But up until that point, I really was terrified of talk therapy. And I know I'm on the panel of mind body, and it's very interesting to get into the psyche of the patients, right? Because why don't people go to the gym and exercise? They know it's good for them. Why don't people, heal the trauma? Of course, everybody wants to be healed. And the reason is because they're terrified of giving up their victim card, right? They're terrified. This is true. I spent so many years avoiding exercise, avoiding talk therapy, and all these other things because, I'll give you an example, right? If my spouse comes home and I'm like, oh my God, I'm killing it at work, and I just bought a new Prada bag, I'm going to get drinks with my girlfriends, and I'm gonna get a massage later, can you please wash dishes? Versus if I said, oh my God, I've had this lower back pain for 10 years, and today is the worst flare-up. I'm so tired. COVID is hurting my business. I don't know how I'm gonna pay rent this month. can you please wash dishes? Right? So because there is power in holding on to our pain, right? Because if I'm a victim, I get to manipulate everybody. Here's my trump card, guys. I'm in pain. You got to do what I say because I was the queen of pain. And so literally, I was holding grudges, you know, just so angry at everybody, the government and, you know, the doctors and everybody, you know, was pissing me off. And that moment when I was in this car accident was when I realized, you know, I could have died. So I don't want to waste my life being right, being angry. I just want to be well. And I think that's when I actually started talk therapy for the first time. And that's when I started meditating and exercise for the first time because, you know, I thought I deserve better than screwing myself. Yeah, so that's kind of like where I became a hacker of my life and my client's life.
Thank you. It's interesting when you start teasing out personal experience, and I would encourage you guys to think, all of you are here because you're high achievers. I would encourage you to think, what was that moment in time? Because sometimes if that moment in time was 10 years ago, you may have lost some of the vim and vigor, you know, some of that passion, because over time, you know, you start to lose that. I cut my teeth on recognizing the issue of overprescribing opioids back in 2003 in workers' comp, and we had a significant problem with that. But I recognized at the time that if you just took away the pills, they were left with nothing. And so I embarked upon a journey. It's like, okay, what is different? And so I started, you mentioned talking therapy. I started talking about cognitive behavioral therapy back in 2010 to the property and casualty insurance industry, workers' compensation. So you know that if you know insurance, you know that we're very adaptable, we're very resilient, we lean into change, we don't. So when I started talking about cognitive behavioral therapy, nobody could spell CBT if they started with the C and B, right? They just didn't understand, and they didn't want to pay for it because their concern was if they paid for cognitive behavioral therapy, that was going to open up a psych diagnosis, and then they own everything from childbirth forward as opposed to just a meniscal tear that was occupationally related. And there was an epiphany over time, and I was working with behavioral psychologists that said, no, this is more of a behavioral thing. This is not a diagnostic tool. If you bill it right with the proper CPT codes, it can become a behavioral therapy, and they started to embrace it. And so if the insurance industry can embrace the combination of mental health and physical health, I think we all should. Vanessa, when you talked about kind of the exercise, what are some stories of some people that you've seen kind of that light switch that came in very lethargic, were feeling kind of the secondary gain, Winnie, that you were talking about? They almost become, their middle name became pain. They had that trump card that they were, you know, they were used to being served, and they were used to being, you know, parking at the front. So they've come into your facility, I'm sure you've seen that, you've seen the long faces. What were some tips and tricks? Because really what we want to do is to leave these folks with some ideas, not just to relay our stories, but to leave them with some tips and tricks on how to. So what were some stories of people that came in that you saw, this is a train wreck, and how did you help them through that to connect the fact that their attitude was having a deleterious effect on their actual physical health?
So when I first started my business as a personal trainer, I had the joy, and I didn't think it was going to be joy then, of going into a very high-end residential treatment facility for senior citizens. And the senior citizens, they were paying between $9,000 and $12,000 a month after putting $200,000 down to live there. And most of them were in motorized wheelchairs. And I was hired by a family to go in and work with a father who was 84 years old. His name was Jack. I dedicated my book to him. Jack was the first guy I got out of a wheelchair and saw walk down a hallway on a walker. The man was angry at life. It was everybody's fault. His wife had died. His kids weren't around. Nobody liked him. He had no friends. He sat in front of his TV and watched Fox News all day. And his son, who introduced me to him, said, "Thanks for trying. I know this isn't going to work." And I go, "I got it. I could talk to a wall." And I didn't say to Jack, "Hey, I'm getting you out of the wheelchair. We're going to dance down the hallway and you're going to make 100 friends." I said, "Hey, why don't we play basketball?" And he goes, "I'm in a wheelchair." I go, "I don't care." And so I would bounce a basketball to him. He either caught it or what? It hit his face. So all of a sudden, he started to play basketball with me and throw a Frisbee with me. And now we were going outside and doing it. And With him not knowing it, all of a sudden we were doing exercise and he was laughing. He was not in front of the TV. He said hi to people in the hallway. The social connection happened. I saw him 5 days a week. In 9 months, he got off the wheelchair and was walking down the hall on his walker. So it changed his life. He started a poker club at the senior center. He got a girlfriend. It was kind of crazy. But yeah, I think it was just the fact that I didn't make it seem like work. So often people think of exercise or like I'm being mandated to do it. I, with my clients, try to figure out what they think is fun, whether it's playing basketball, whether it's running, whether it's gardening. What does it do? What can you physically do that you find fun that gets you where you want to be in life? If I can figure out that, I can get you there, and then it can change your whole mentality.
So what did that do for you? Because I got to imagine, I mean, you were set up for failure,
Yes,
right?
yes.
Going into this facility
Yes.
and the son going, okay, you know, thanks, but no thanks.
Yeah.
You know, what did that do for you when it showed that what you did actually had that effect? Because it had to have a positive effect on you and your ability to deliver that care to other people, right?
Well, I thought it was fascinating. This was really my first time seeing how we take care of seniors. I never had grandparents or older people in my life at that point. And I now saw that we looked at these older people as castaways. We keep them cast away. We keep them in motorized wheelchairs because they're safer. They're not going to fall down and get hurt. And I thought it was tragic. These are human beings. We treat our dogs better in the United States than we treat humans. If there was a dog right now—
Especially older people,
right,
yeah. Mm-hmm.
Dog running down the hall right now with a broken leg, all of us would fight over who was going to pay that $7,000 vet bill. When there's a homeless human walking down the street, we look the other way.
Mm-hmm.
So I don't know how we got this with our loved ones when they're older, but I think it's very, very wrong, and we give them drugs and we put them in these care facilities because we don't want to take care of them. And people become angry and, you know, morbidly obese, sitting still. It's all of these things, they happen from not moving. So if I can convince people just to move a little bit— but Jack didn't just change himself in this senior care facility. He got everybody out walking. He got everybody playing poker and drinking wine and laughing during dinner. And I mean, I think it was just, you know, you get one person to change, you have one family member that gets fit, even if everyone else is angry, everyone else all of a sudden gets fit. You just can't help it. So, and you can't do it by telling people to do it. I can't tell you, hey, if you do this exercise with me 3 times a week, you're gonna feel great. No, it's not gonna happen. I have to convince you that you're going to want to see me every week and want to like to do the exercise. Mm-hmm. And then you have to come to the realization that your mentality changes. I am not going to tell you that up front.
Negativity breeds negativity, but positivity also breeds positivity, right?
Correct.
Absolutely. So trauma, you chose to lean into trauma as a social worker, as someone who came from a family of people who helped deal with trauma. You know, the CDC, one of the things that I recognized early on when I was looking at the prescription painkiller problem was the CDC was documenting adverse childhood experiences, or ACEs. And ACEs are significant comorbidity associated with negative repercussions, and that's you know, childhood trauma, anything like that, and it affects your ability to have resilience. It predisposes you to addictive behaviors, all sorts of stuff, and we don't ask those questions. It was interesting, the keynote before us was talking about caring, and literally just asking people to invite themselves into, okay, here's where I'm at, and so forth. So when you're dealing with trauma, how do you help them understand that maybe the physical repercussions of that trauma is actually being negatively impacted by them holding on to that trauma, and how do you get them to connect the physical component to the mental component that they may not necessarily recognize?
Yeah, no, that's a great question. And so I should say that the company specializes in working with the Medicaid population. So in Oregon, that would be Oregon Health Plan. And about 70% of our population that comes in as clients is on the Oregon Health Plan of some level and variety. And so we manage and work with a lot of patients who come in with that sort of negative attitude of, I've been the victim, I like the victim role, I want to stay in the victim role, but also want to live a healthier lifestyle, want to be healthier, want to be more active, want to be more positive, want to have better friendships, want to have better relationships with family, friends, and coworkers if they're working. But that being said, we've worked with the homeless, we've worked with people with full-time jobs, I've worked with people who've been in prison for 10 years, and so it comes from all different varieties and shapes. And what I will say is that the unique thing that binds them all together is the physical symptoms they have. Almost every single one of my clients on the Oregon Health Plan come in with back pain, shoulder pain, neck pain, headaches. leg pain. I mean, almost to a T, every single one of them. Many of them are diagnosed with fibromyalgia, and they struggle with movement. They struggle with all those things. And so I have to sit with them and be present with them in their pain, physical and mental. And I try to remind every single one of them it's not an overnight process. This is going to take time. It's going to take time to recognize where the pain is coming from, what traumas have occurred that have caused those pains, and you're not going to know today when we leave the session. You're not. And in the first 3 to 6 months, I always work with them on grounding, on understanding their body better. How do they touch the floor? How do they hold their bodies? Posture. How do they manage their symptoms when they're stressed, overwhelmed, upset, tired, hungry, you know? And so it's a matter of just helping them understand step by step what little steps can they take in the first 3 to 6 months of treatment that will help them in the next 3 to 6 years of their lives. And so oftentimes that's grounding, orienting to the room that they're in, helping them understand that the more present they feel, the better they're going to feel emotionally and physically. And that's important for them to understand, oh my gosh, this is a tool that I can use every day. This is a tool that I can use when I go to the grocery store and I'm too panicked to get out of my car to go into the grocery store because I don't know what's going to happen, or I'm going to get trapped, or I'm going to get hurt, or I'm going to get, you know, kidnapped, or whatever the fear is that they have. And so I try to teach very basic tools that help them in the moment at that time to help them stay more present. And that's where we start. I mean, that's the goal. And then from there, we step up from there. Once they're able to ground and orient, once they're able to have some sort of foundation for understanding what can I do when I start feeling anxious or overwhelmed, then we can start looking at, okay, where is the pain actually taking place when you talk about your father having gotten in a car accident? Okay, it's in your shoulder, so let's identify that pain. Let's just stay with that pain. And so the work is to be present with it, to be mindful of it. And that's really hard for a lot of these clients of mine. They don't do that ever. They run from the pain. They use drugs. They use coping skills that are maladaptive. They go to the casino. They do things that are just not healthy or wise from a mental health perspective.
But we love Mandalay Bay. Just to put it
That's right. Yeah. So, but I also help them with psychoeducation, understanding this is how you've used this to cope with that, and that's okay. We just need to find new coping skills that are more adaptive to your positive mental health in the future, going forward. But they've used those coping skills and they've worked for them doing something. They get through life doing those things, and so I try to honor that as well. But then we get into the deeper stuff later on.
I love all of that, and we're going to come back to the education component, but I think being transparent and real with them, setting reality up front. You know, Jack didn't start, you know, you didn't say this is going to be overnight and, you know, you're going to get up and walk. For some of these people, this trauma is so deep-seated that it is going to take a while. And we could set them up for failure by saying, hey, we've got a magic pill, we've got a magic needle, we've got a magic surgery, we don't have any magic associated with it. It's going to take hard work. I'm going to be alongside with you and be present through that. Winnie, it was very interesting. You used this concept of healthcare, or your personal health being kind of protected by a password. And you only know the password as the person, but you don't even, you're not sure what the password, and providers don't know the password. So kind of tease that out about how we can help people figure out what that password is to unlock better health, both physical and mental.
Yeah, I'm gonna first shine a light on and give some love to all my panelists, because sitting here having this privilege to be in your presence, I discover I am like you and you and you. You know, Mark, you have this education about worker comp, helping people be empowered, you know, and you make exercise fun. And that's, you know, a lot of people don't exercise because they think they have to exercise as opposed to, oh, it's so fun. And then with you, you're teaching awareness. right? Let's come back to the body. Let's be grounded. What does the body say? Is it the shoulder pain? Is it the hip pain, right? So because as my confession, I'm a body hacker, I look at everyone like a computer. And you know, computers, they're coded in ones and zeros, right? So the body is the data. Actually, I would love if we turned everybody into a self-body hacker, because when we have the awareness, okay, how does my shoulder feel? How do my hips feel? When we start self-awareness, where is the pain? And that is the beginning of how we can find the right exercise. Okay, hip flexor stretch, and how we can apply to worker comp and get the appropriate, whether it's CBT help, etc. And so, you know, because of my background in computer science and electrical engineering, I want to briefly explain how acupuncture can help as a modality healing the body and the mind, and really the beauty of the connection between the body and the mind. So most people know that acupuncture is good for lower back pain. And you know, indeed, I think Medicaid, the Veterans Affairs, and even every Army unit has an acupuncturist on their team, because they know that acupuncture is really good for healing lower back pain and also meniscus tears. But what they don't know is acupuncture is really good for mental health. Actually, we have the 5 elements. And for example, anger is stored in the liver, and liver opens in the eyes. And literally one time somebody found me on Yelp and they said, okay, can acupuncture restore my eyesight? Of course, legally, I'm not allowed to say yes. I'm not allowed to say acupuncture can treat COVID. I can't say acupuncture treat cancer. I lose my license right away. So I was like, okay, girlfriend, here's the deal. I can't say I treat anything, but just show up. Trust me, I can help you. And thankfully, she did come. And then I asked her, how long has it been? And she told me 3 months. So I explained to her the connection between anger, liver, eyes. So I said, okay, 3 months ago, rewind the tape. What was the thing that pissed you off the most? And then she looked at me and she said, you know, Winnie, 3 months ago, I had a fight with my sister, and she decided to set boundaries and cut me off, and I felt abandoned and I'm pissed off because who is she that she gets to decide to set boundaries with me? I said, girlfriend, here's your choice. Either A, you stay mad at your sister and eventually you're gonna deteriorate your eyesight, or B, forgive your sister and forgive yourself because you must have said something that pissed your sister off so that she set boundary with you. And then you can have your eyes back. Which one you're gonna choose? And she said, I want my eyes back. I said, good choice, good choice. And so in addition to acupuncture, we did a forgiveness practice, and you know, letting go. Yeah. Letting go of that victim story that my sister cut me off, I was abandoned and rejected, and that sense of hopelessness. I really want to connect to my sister, but every time I send her a text message, she doesn't reply. And in one session, her eyesight fully recovered. And of course, again, I can't say I can treat anything because I don't want to lose my acupuncture license, but that is the power of the mind-body connection. It started with anger and it manifested in eyesight problem.
Let me ask her a question. Okay, so you have someone come to see you. They are hesitant. Their husband or their wife sent them. They don't believe in acupuncture. Okay, so it's not going to work, right? If I have this wall up and I say it's not going to work. You can do whatever you want. Put all those needles in me. I don't care, and it just doesn't work. Is that? I mean, so if I believe in the acupuncture, it works. So that person believed in you. So just as, you know, if someone says, okay, I know where I'm standing, why do I need to stand here? Okay, I know where my feet are. Don't be ridiculous. Don't you understand what a damaged life I've had? So if we can't find that starting point, right, of mentality of where they need to be to go forward.
Yeah, I got you. Thank you for asking that question. And indeed, I spent 42 years holding onto my victim label and victim identity. And I'm like, ooh, I like it. I don't want to give it up. So a lot of patients, they had good results with me and they want to send their mom, their dad with cancer and all these other things. I'm like, dude, if they're not willing to give up their victim card, you're just wasting money and throwing it into ocean, okay? Don't even bother coming to see me, because until that moment when they're ready to give up the victim card, it's just throwing money into the system.
Yeah, so there's a lot of biases that patients come into encounters with, certainly. And this is the Health 2.0 conference, so, you know, we're talking about that. How can you educate them against that bias? Because that bias may be something that, you know, they've been trained in, maybe they've read the wrong stuff, maybe they haven't read the right stuff. You know, maybe a family member or a friend had a bad experience, and so they kind of rule that out. Back to kind of the education that Abe was talking about, how do you educate people to kind of open their mind? Because to your point, if they don't believe acupuncture is going to work, Winnie's already got a tremendous uphill battle to convince them that it does. So how can you break down some of those barriers? And again, focusing on tips and tricks that everybody can walk away here with. What are some ways that you can help educate and open their mind and reduce the barriers where they're willing to accept a treatment plan or a suggestion or just talk through their own problems? One of the things, beauties of cognitive behavioral therapy is that oftentimes people solve their own problems by just stating it out loud and having a listener that's actively, intently listening to them and responding and reflection back to them. They understand, so they feel like they're heard and acknowledged and understood, and so they kind of solve their own problem. So Vanessa, in your mind, how do you get people to get past that bias, those obstacles, in order to embrace something that they wouldn't ordinarily not do?
I ignore them. I mean, I just, you know, I had a husband who's worked out with me, been very fit, wanted his wife to be fit. And, you know, he said, you gotta go see Vanessa. Don't see the rest of the trainers. Don't just go to the gym. Go see Vanessa. I'll pay for it. And it'll be great. And I ignored her. So everything that you talk about, I just ignored it. I pretended it didn't happen. And what she said, I don't like to do that. I don't like to sweat. Oh, well, I just ignored it. I just talked about the weather or my dog or whatever and told her to do things and do things with me. I always work out with my clients, a very different kind of personal trainer. I don't just stand there. So she was just like, oh, the hour's over? Oh, that wasn't so bad. And I even ignored, when she has a little positivity, I ignore that also. So it didn't seem like I was ignoring just the bad. I was ignoring everything. And just, oh, great, it was good to see you next week, or whatever I say. But I try not to give it importance.
Okay. Yeah, so it's almost like a distraction kind of a thing, is not let them dwell on what maybe they may come into the encounter with.
Right.
Absolutely. Abe, thoughts on how you educate people to get beyond their self-defeating biases?
Yeah, I mean, I think I'm in a unique position because I think in particular, out of all the clinicians at the group practice, I specialize in treating and working with patients who have tried therapy for 20, 30, 40, 50 years. And so they're coming to me with this idea that this is my last attempt, this is my last idea, this is a new type of treatment, it's got to work. So they're some of them, I would say many of them are very, very hopeful that something out of this is going to work. Or they've maybe heard something from the past or heard something from a website that's like, okay, well, this is more in line with what they're looking for than maybe traditional talk therapy. And so some of that I don't have to battle against. But what I do is I very clearly explain what sensory motor psychotherapy is, which when I say body-oriented approaches, nobody knows what that means, and understandably so. So, I mean, I go through the spiel about, well, we're going to work with your sensations in the body. So all of the sensations you have in your body hold these memories, and the memories got stuck during that trauma that you were a part of. So maybe it was a car accident where you were trying to turn out of the way and you didn't complete the turn back. So you have to work through that turn back in the therapy office. That's the work that we're going to be doing together 6 months, a year, 2, 4, 6 years down the road, however long it takes to get there. And so what I do is I try to help them understand what sensory motor psychotherapy is and EMDR, but I also help them understand that sometimes they come to me with fear of, is this going to help me? Is this going to improve? Is this going to do this? Is this going to do that? I'm scared to address my trauma. Like I've been avoiding it for 30, 40, 50 years, knowing that it's there. I don't want to talk about it. I had one client a couple of years ago come to me, and she had been working with me for 6 months to a year. And she had gotten through all of the grounding, all of the orienting, all of the exercises to kind of come back to herself when she was upset in the grocery store, at home, or wherever she was. And then for about 6 sessions in a row, we got to this place in the session where it was either time to dive into the trauma and do some deeper sensory motor work or bail. And because we do no harm, I always let them lead. I always say, okay, are we going there? So each week I would say, okay, Susan, that's not her real name, but Susan, we're here again. This is the moment where if we go further, she's crying and crying and crying, we can go further into the trauma and into the work, or we can bail. 5 weeks in a row, she bailed. She's like, I can't do it, I can't do it, I don't want to do it. Okay, no problems. Let's reorient, let's ground, let's find mindfulness before the end of the session, so you'd leave here feeling okay. The 6th week, I said, okay, we're here again. What are we going to do? Crying again? Same, and the trauma keeps coming up in the room. The trauma keeps coming up in the room, and she's 6th week in a row. She says, okay, if I don't do it, we're going to keep coming back here, right? And I said, yeah, we are. We're going to keep coming back to this point as long as you want to. We can keep going out and we can ground again, but we're going to keep coming back here. She said, let's do it. Let's do it. So we did it. We did deeper mindfulness, went into the sensations, followed the sensations, felt warmth or cold in her body, followed the energy, felt the anxiety, and went with the movements that she desired. And I helped her with physical boundaries and pressure where she needed it. And she actually had a transformation in that session. She transformed her experience of trauma to triumph, which is not my phrase, that's Pat Ogden's phrase, so don't take it from me. The sensory motor psychotherapy founder is Pat Ogden. And so she went from to triumph, and every session thereafter, she's like, oh my gosh, I feel so much better. This is unbelievable. So you have to walk with them, at least with my clients, to help them understand that, yes, I'm going to take you there, but I'm not going to lead you. I'm not going to force you, I should say, to get into the water. And until she was ready, I just stood with her. She was fearful of facing that fear of the trauma and of the experiences she had when she was, 10, 15, 20 years old. And so that's a big part of my work, is just helping them and walking with them.
Great, thank you. We're coming down to the question, but I do want to give Winnie the opportunity. So we've gone from ignoring their bias and kind of distracting them from that so that they get into it, and to education, to being fully transparent as far as what they're getting themselves into and what they may be leaving on the table. Winnie, any additional thoughts that you want to add before we open for questions?
Absolutely. I just want to say what a pleasure it is, because I actually do a combination of what Vanessa do, which is do the workout with them, right? So when you're with them, it's more powerful because they don't feel alone, which is why I wrote a book on shadow work where I dive into the trauma. And so even if somebody can't afford my private session, just by reading my book on healing trauma and the shadow work, they can do the workbook and the exercises at home. And I also do what you do, which is being patient and meeting the client where they are. Because if the client is not ready for the first 5 or 6 times, they're not ready, right? It's kind of like, I think about therapy, it's kind of like sex. It needs to be the woman is ready before we get together, right? It's like, okay, I'm ready, but if my client's not ready, I gotta wait till they're ready, and that is when the magic happens. Let's go to questions.
Gotcha. I bet you didn't see sex coming on this
I
particular
know.
panel.
Well, also,
Visual.
one of the things that I really think is we gotta make healthcare fun, right? When we tell jokes, people want to come listen. They want to go into center. They want to work out, and they want to work with me. So a lot of my energy is motivating people because it's like, don't you want to have a lot of fun? And so, yes, I do tell a lot of jokes in my office.
That's okay. Well, you know, if you're into Western medicine, probably a lot of what you've heard just gives you the heebie-jeebies, right? It's like, that's just way too, that squishy stuff, is that, but hopefully what you have heard is there is a direct connection. There is a direct correlation between what happens between your ears. I coined this phrase several years ago. What happens between your ears and what happens at home has as much to do with your willingness and ability to get better as what's physically wrong with you. That is, in synopsis, a biopsychosocial spiritual treatment model, the whole person. And that's something in work comp we've worked through. That's something that you guys have worked through. But we're down to about 7.5 minutes. We did want to offer the opportunity for any questions. So feel free to come up to the microphone. Got some really educated people. We've seen you before. You were a frequent flyer at the microphone.
Yeah, I got a lot of opinions. The connections you're drawing are, you know, as somebody who's in the so-called hard sciences and having been a managed care medical director for a managed care organization, the stuff that you're saying is not, you know, you were talking about really is not as far-fetched as, you know, your last comment. And here's a good example. So I'm combing through my abstracts one morning, and I run across an abstract on elevated norepinephrine levels and preterm labor. And I go to see my friend who is the editor of the major textbook, and I say, what about this? We can't explain, you told me that we can't explain 70% of preterm births based on the available data. When we treat depression, we're treating norepinephrine levels. We're also treating serotonin levels. That's the pharmacologic treatment. Is it possible that depression is the driver of preterm labor we're not recognizing? And he said, you know, that's funny. There's a serotonin study too. And so we began some discussions, and Parkland Hospital began screening for depression in pregnancy about 3 years before ACOG, the organization, the governance came out and recommended all OBs. The point is that women with preterm labor have, women with depression have twice the prevalence of preterm birth. So here is a physiologic link from their depression to the levels of the chemicals that predispose to preterm labor. When and if we look hard enough, we're going to find the same connections on the same types of things you're doing.
Absolutely. Thank you for sharing that. Yes, sir.
Can I address
Yes.
it?
Mm-hmm.
Okay, so because I am a hacker, so what are the 4 feel-good hormones, right? We have dopamine, serotonin, endorphin, and oxytocin. So I'm sure everybody have an iPhone and everybody can Google how to increase each of those. So, you know, and I'm just gonna give a very quick example because you can go home and with all of your patients immediately implement this body hacking. So for example, dopamine gets rewarded when we accomplish small tasks. So for example, I might be washing dishes and I tell myself, after I wash dishes, I'll feel really good and I'm gonna get a hit of dopamine, yes. And what we set our intention, I can actually multiply the dopamine by recognizing I'm generating the dopamine. And for example, serotonin, right? Meditation and being out in nature. Oxytocin, that's even easier. You can give hugs, you can hold hands, but even if you're in COVID and in lockdown and you can't touch nobody, giving compliments. As simple as leaving somebody a positive Yelp review give yourself, you know, it's like you're sending this kind of connecting hormones, and you can generate oxytocin, right? And endorphin, go exercise, right? Exercise, you're gonna generate endorphin. So I encourage everybody's homework, get off the panel and Google oxytocin, dopamine, endorphin, and serotonin, yes. Find out what is and I think one of the ways is telling jokes, eating dark chocolate. I'm all about that. So we can all hack our body and teach our clients how to be a hacker.
Great, thank you, Winnie. Yes.
Nice. We're talking about the connection between mental health and physical health. So I'm kind of curious, how would you differentiate between those things that may have a physiological origin and those things that may have a mental health origin? Is there a way to tell really where the symptoms are coming from?
I can take it, but you guys go ahead. So this is the chicken or egg thing. Did the chicken come first or the egg come first? You know, in the hacker's opinion, I don't care if the chicken or the egg come first. I treat them all at once, right? So I would probably send them to his clinic where you can try anything: hypnotherapy, Reiki, acupuncture, exercise.
I have a question.
Yeah.
Wait a minute. So let's say I am Joe and I got hurt on the job. I think my back hurts. How to get my workman's compensation to admit that it's my brain and not my back?
Good luck with that. Yeah.
Here we go.
Well, and that is the complication, but you know, I think that requires 2.0 type thinking, right? And recognizing we've had a conversation in workers' compensation about social determinants of health in the last 5 years that never would have ever been talked about. The concept of medical literacy, the supportive community, you know, all the things that are negatives draws to that, and recognizing that impacts that person, their ability to resolve. So I agree, kind of the chicken or the egg. Is it physiological? Is it psychological? They're probably tied together. You know, did the injury cause a depression? Were you depressed and then drove off a cliff? I mean, you know, there are a variety of ways to look at that, but none of us are doctors, so maybe someone else in the audience might be able to answer that question a little bit better. If that helps a little bit anyway.
Thank you.
Yeah, thank you.
Unfortunately, that's all the time we have, guys, for questions. Huge round of applause for our panel. That was so interesting. Thank you so much, guys, for sharing your knowledge. I really enjoyed that. Guys, so we have one more panel coming up. Then we are going to do our recognition and award ceremony and then lunch. So if you have family, friends, colleagues who you'd like to invite to watch you accept your award, you are able to share this information with them. Tell them just to log on to YouTube from phone, computer, and they can just type in, of course, the name of our conference, Health 2.0 Conference, and they'll just click play. There's going to be a live stream, and they'll be able to watch you right down to the minute. Let's move on to our next panel discussion of the day. When people hear about mental illness, they often have several different ideas about what it means. Mental illnesses are often stigmatized, resulting in those living with one being judged, discriminated against, and isolated even from society and those who care for them. Take a look at the most common myths surrounding mental health care and learn from these experts to better understand the concept. They're going to kind of help us navigate through those too. To act as a moderator of this, we have Isaiah Coles, Chief Operating Officer and Integrator of Outreach Recovery. Please take the stage and introduce us to our panel of experts. Come on up. Round of applause. Thank you for your patience, guys. They're just wrapping up, getting mic'd up. Friendly reminder, guys, we are going to be bringing Health 2.0 Conference to Dubai, May 1st to the 3rd, 2023. We are looking for sponsors, delegates, exhibitors. We would love to have you there. So if you have any interest at all, even a little, please come see me during the break, and I would love to give you the information for that. And if you're like, I would love to continue the journey and learning and the networking, but you want to stay a little bit closer to home, we understand. We're also bringing the conference back to Las Vegas in July of next year.
We're all going to go up together.
Round of applause now for our panelists. Give them some good energy and all your love and support.
Well, hello, Healthcare 2.0. This is actually my second conference, and I've enjoyed my experience every time that I've attended this, this organization's conference. My name is Isaiah Coles. I am the Chief Operating Officer at Outreach Recovery. We are located in 6 states, 23 clinics, encompassing primary care, all types of behavioral health, and counseling services. I will be the moderator today for mental health fact or fiction, and I will allow my panel to introduce themselves.
Hi, I'm Dr. Tanisha Ranger. I'm a clinical psychologist practicing here in Las Vegas. My main focus tends to be working with Black people in the diaspora, so not just African American, but Black people from everywhere, and working with them on maintaining mental health in a world that is determined for you not to have that.
Hi, my name is Jesse Lyon. I'm the Chief Dream Scientist at DreamApp. We're a mental health platform that interprets people's dreams and then uses that as a diagnostic and therapeutic tool to help them with their mental health. My personal background is as a licensed mental health counselor in Central Florida, Orlando, with a couple offices there. And during COVID, things were getting a little hairy, scary. So I turned to social media and started trying to help people as much as I can to outreach in that way. And I really landed into the dream field and helping people understand and really look into their dreams to understand what they meant. And so that quickly grew. And so I currently have a following of 1.6 million on TikTok and just creating a community around destigmatizing and accepting understanding mental health there.
My name is Azmat Hussain. I'm an emergency medicine physician by training. I'm the Chief Medical Officer and co-founder of Personic Healthcare. We're a multi-specialty healthcare organization located in the Northeast, headquartered in Northern Virginia. We also, similarly to Isaiah's organization, provide in outpatient operations, advanced wound care, but heavily also in behavioral health. We operate several mental health treatment facilities, which include advanced modalities such as transcranial magnetic stimulation, TMS, Spravato, and other counseling therapies. So excited to be here.
Hi, everybody. I'm Dr. Benjamin Keys. I am a professor and the director of the Center for Trauma Studies at Divine Mercy University, also in Northern Virginia. At the center, we operate from a immersion model where we train people in aspects of both first response trauma and long-term trauma. And then we immerse the students into a culture, usually overseas, but we immerse them into a culture where they get to work with their skills and work alongside of social workers and counselors from these other countries, working with their clients actually on very serious, deep, traumatic issues.
Okay, thank you guys. Well, when we say mental health, behavioral health, there are so many misconceptions, misunderstandings, labeling that we see. As a somatic provider for 25 years, when somebody would tear an ACL and we would do the surgery and we do the rehab, it was very, very objective. We had protocols that we followed. You can measure, an angle, how much the knee can bend or how much extension you can get. And when it comes to mental health, it's a little different. The way we measure success is different. The way we treat a ACL patient compared to somebody with depression. If somebody tears an ACL on a ski slope, oh man, you tore your knee on the ski slope. How courageous of you. But if somebody says, I have depression, from either from trauma or an experience they may have, the sense of understanding and recognition automatically changes. So what we're going to do today is we're going to go down our panel, and they're going to share with you some of the myths that they find in dealing and in working with these population of patients.
Should I start? Yeah. Okay, I'll start. So I had a little bit of trouble narrowing it down because when it comes to Black mental health, there are a lot of myths that fly around and get in the way of Black people actually getting the help that they need. So I will narrow it all down to one big myth, which is the myth of Black strength. Assuming that, Black people are strong and they're able to endure and they can deal with all kinds of things and thus don't need help or don't want help, or all of these things that are both prevalent within the Black community, but also outside of the Black community, leading clinicians and practitioners to not take Black pain seriously and not to treat it with the same urgency and curiosity even as they would treat any other person. And so that comes up in a lot of different ways. It comes up in Black people feeling like, if I admit that I need help, if I admit that I want to go see someone for mental health treatment, then that's a sign of weakness, and I can't let anybody know. There's the outside of people who steadfastly believe that Black people don't want therapy. They're not interested. They don't think that's going to work. They're going to go to church, they're going to pray, and they're not interested in mental health treatment, which could not be further from the truth. The fact of the matter is, it's hard for Black people to find culturally competent mental health treatment. And given what has happened in this country since its inception, it is not out of the question for a Black person to not necessarily trust the medical field or the psychiatric field, given how, as a group, we have been victimized by both. And so that is always a barrier to break through for myself as a clinician and myself just as a person. I had to work on that myself as I was coming up in my profession. So that myth of that strength that doesn't need any help, that can trudge through, that is built for struggle, is nonsense, and we have to get rid of that.
So I'm curious, other folks on the panel, what has been your experience in some of the myths you may have seen regarding, racial disparities in mental health, racial outcomes, or the perception that you may have when you're dealing with, folks from, other minorities that in your patient population?
Sure, I'd like to chime in on that. Previous to joining Personic, I was the chairman of the emergency medicine at Howard University in DC, and also served as the CEO at Hahnemann University in St. Christopher, all urban setting environments. And I think one major myth that we have about whether it's the urban community, whether it's the Black community or other minority communities, is that they lack the interest in access in getting care, and that they're looking for the most, they just flood the emergency departments, or they're not looking. And I think that myth, what we don't realize is their actual access to care is so limited in what we're actually providing them in avenues for outlet. And we get upset in the public health settings in regards to the urban environment, emergency departments being overrun. Oh, they're not accessing the FQHC, but we don't realize that the FQHC is located in the suburbs or so far outside the common modes of transportation for them to access. Or there's not bilingual providers sitting in our FQHCs or other access points that we have. So I think that I've seen is a major myth, where we have suburban expectations for an urban community at many times, and it completely is, we're missing the boat on how to actually provide care to these communities.
I know for me, coming up in the field, I ended up working for a number of state agencies, including the Department of Corrections, and it's not just in healthcare, because it sort of swings its way into the pipeline that leads from prison to the community and back again. It has to do with access, I think, to support and help, and it's not just a single prong kind of issue, because it has multiple prongs.
Yeah, I would agree with that. I think it's not only just a racial sometimes disparity, but also socioeconomic, very much socioeconomic. And that's why, things like SAMHSA are starting to expand telemedicine for OTPs for buprenorphine out into rural areas because there's not enough providers, so, okay, thanks, guys.
I might jump in there too. I think one of the things that we experience a lot in my personal practice is with trauma. Trauma has to be so understood inside of context, and especially cultural context, because you can't just assume that one thing that traumatizes one individual is going to have the same reaction and effect on another individual from a different community. And so one of the things that we really try and do is make sure that when we're talking with people and users about their dreams and about their mental health experience, is that it's contextualized for them, that we're understanding the way that they interact with the world, their family, and their obstacles, because you can't just apply the same type of routine to everybody. It has to be contextual.
And part of what happens is that Black people are not often included in studies, but then you use those studies to generalize amongst them as if, well, if it works for these people, it'll definitely work for you. But when it doesn't work for you, it's because you're non-compliant.
Right.
And so,
and they blame that.
right. And so there just gets into a cycle of victim blaming that doesn't leave anybody getting the care that they need.
Very good. So Jesse, why don't you share with us one of your myths that you come across?
Sure. Oh my gosh. I feel like dreams, when their relationship to mental health, get myths on both sides of the spectrum. So being prominent on social media, I get a lot of feedback. Some of that is very encouraging, and some of that is very discouraging. And there's no shortage of people willing to share that discouraging comment. I think the two that I get the most, right, are dreams are totally meaningless. They don't mean anything. They're just nonsense. They're kind of the throw up of your mind and your emotions. And then on the other side, I get some people who are very into dreams, thinking that we can connect with other people, we can transcend to an astral plane and metaphysical kind of expressions. Both kind of miss the mark. When it comes to dreams being meaningless, we know that that's not true. We know that the brain, when it's dreaming, it's accomplishing two processes. It's encoding that information that you've experienced through the day and giving meaning. So creating new neural networks and deepening existing neural networks. And so the process of dreaming is the experience of that happening in your brain. So it's very meaningful, and we can understand and even predict a lot of diagnoses and a lot of things that are happening inside a person's mental health based on looking into their dreams and really taking that into consideration. But then on the other side, there's really no scientific research or evidence to say that, you're transcending planes or you're dream hopping into someone else's brain while they're sleeping. Maybe we'll get more into that research, but I think it's really important not to make some claims that are outlandish, but to really stick with, okay, how can I make this impactful for this patient today? How can I make this really impactful for their life and improve their mental health? That's got to be the focus.
So Jesse, tell us, when it comes to obviously gathering data and using the information that you're getting from dream, how does the app and the technology you're using come into play with the dream data that you're getting?
Yeah, it's huge, and that's one of the things I'm so proud of with Dream App and the company is we really started on the commercial side. And so we really focused on making an application and a platform that was enticing to users. And so we've got just an incredible base of users. And to this point, we're currently the largest collection of dream data in the world with 2.5 million entries. And so we use a combination of artificial intelligence and dream experts to comb through that data. And we're looking for indicators of what's going on with their mental health. And we can filter that data based on geographic location, sex, relationship status, cultural influences. And so we can actually get some really good information about how this population is interacting with their mental health, what the implications are, and how we can help them individually. And so it's just been a wonderful opportunity because of this vast amount of data that we've collected.
Great. So Dr. Hussain, myths that you come across.
I'd say it's really hard to follow dreams, right? So that's pretty cool stuff, pretty interesting things that everybody here on the panel, everybody here in the conference is doing. So it's been really interesting stuff. So one of the myths that I think, although I think the people in this room would probably all recognize, but I think as a physician, it's important to say that in mental health, I think a large myth is that our standard pharmacological therapies are the mainstay of mental health treatment. And I think that's something that here goes without saying, but I think it's important to reemphasize. And I think one thing that's showing a lot of promise, and I think we've all alluded to, especially in the session before this and the various modalities, is this concept of neuroplasticity. And it's growing quite a bit. There's been a lot of research on this and a growing understanding of how our brains are such dynamic, ever-changing objects, where multiple different inputs coming into our brains can regulate not just the chemical aspects that were talked about earlier with the serotonin, the dopamine, the norepinephrine, but even our synaptic impulses that are going between our axons and dendrites. And there have been so many studies on modalities such as the ones we offer, TMS, transcranial magnetic stimulation, working on the neuroplasticity and enabling a positive changes in the actual physical, chemical, neurologic makeup of our brain to positively impact behavioral health. Therapies such as psychedelics and psilocybin, working on the same concept of significantly expediting and advancing the positive changes to the neuroplastic environment that is involved in behavioral health and mental health challenges. So I think one of the things that provides me a lot of hope and optimism about the future of mental health treatment is that we are going to start to, and have already started to expand the what's in our tool belt to offer to patients. We're monitoring their dreams. Now we're having a lot more emphasis on culturally competent care. And I think all this goes to recognize the vast degree of inputs that our brains take and how that customized treatment regimen can have significant impact. The last thing I'll just say on this introductory aspect of that is that I think really recognizing that there are significant treatment successes that we're having. Johns Hopkins is the one that really kind of created all the noise about psilocybin and psychedelics when they released that up to 70% of their patients 1 year out went from severe depression to less than mild depression on depression severity scale. Right? That's 12 months out. Now again, I'm not here kind of to promote one therapy or another, but I think my point is that similarly, whether it's TMS, psilocybin, all the various new therapies that are coming out, we're seeing some really, really impressive remission rates for depression and anxiety when we never talked about remission before. We talked about managing it as a chronic illness. So really exciting future, and I think these kind of forums where we're talking about innovative models of therapy and treatment are going to be more and more mainstream, so to speak, moving forward.
Well, I know in our practice, older, phobias about recreational drugs like psilocybin, cannabis, now are starting to change. We actually are finding that there are actually medicinal uses for these things, and so we're going to have to break the stigma. I know within our practice, in our states, we have DC, Maryland, New Jersey, New York, that are all we have cannabis states that are recreational and medicinal for use, and we are constantly battling our patients who want to use street cannabis compared to medicinal cannabis, and there's always a debate there. Mm-hmm. Which one do we want to use? Would you rather have a fentanyl-laced marijuana that you get off the street, or would you rather have it from a dispensary? That's the debate, and we're going to have the same debate with psilocybin as well.
Yeah, one thing I just want to kind of add to that is I think that a lot of the onus of change that's coming forward is really on the providers, the organizations, those that delivering the care to really embark on aggressive education campaigns, because that I don't think we do enough of, right? I think we are quite, I don't want to speak for all of us, but I think generally can be quite hesitant and tepid when introducing the concepts of these new therapies to our patients. We're concerned about how we'll get labeled. We're concerned about will they, buy into this. And I think reclaiming or reorienting ourselves to really be educators to our patients, to our colleagues, to our communities is really going to accelerate this transition, because I think we all agree that what we have been doing may have worked in the past, may not have, but it's really not necessarily working right now.
Man, and on that, like being kind of in that public space where you receive that criticism, I've seen it really damage a lot of people's ego and moving forward. But I embrace it. There's people who are going to be really slow to adopt new modalities, and I think that there's some wisdom in that. I think even seeing the advent and the growth of mental health development, I mean that's a relatively newer field because we were dealing with things that were very literal. How do I set my leg? How do I fix this disease? And so that hesitation, I don't fight against it. I think we do need to make sure that the tools and the modalities that we're using are very effective and that they're proven. And so there's some wisdom to that. And then there's also always going to be those people who are really pushing the boundaries and maybe even claiming some things that aren't totally verified yet, but okay, they're on the right track. And I appreciate them moving that conversation forward.
I think that's part of the issue, though, is what is the data showing? And sometimes you get a mixed showing. And I think we have to be careful as we go forward. There are a lot of new things that come up in mental health. And I know I take a sort of a wait and see approach of, where's the data going to be? And if I'm starting to see positive data, then do I need to have a paradigm shift myself in being able to sort of take it on, particularly in the area of trauma, because we're constantly getting new data that sort of flips the coin a little bit and changes the way we look at various things in trauma.
I think the struggle with getting the data is that, in the field of psychology, a lot of our journals don't publish articles where there is no difference. There's a bias towards change, there's a bias towards difference, but I think understanding that this is not different from that is as important as understanding that this is different from that. And so the data is always skewed. So you never can really know, because all of the studies where nothing happened, everything came out the same, don't usually get into the journals.
That was exciting.
Yeah, they don't have the pop.
Dr. Keith, what about you? What kind of myths do you see in your practice?
Oh boy. Most of the work that I do has been, actually for almost my entire career, has been in the area of trauma. And trauma happens along a continuum of diagnoses, but it also happens in the field. It happens with disasters, it happens with war, it happens with situations with refugees, human trafficking. There are all kinds of social ills that set up trauma, not to mention the more mundane of domestic violence and divorce and death. And one of the areas that I have worked pretty extensively in the area of dissociative disorders, particularly what we now call dissociative identity disorder, formerly multiple personality disorder. And one of the myths was, well, if you see this, you'll see it once, maybe in your entire career. And it's so rare that it's basically non-existent. And that's just a lie. We have established in 62 countries about 1% of the entire population as being dissociative identity disorder. And it's interesting because they've done various studies that indicate just how real it is. The one that really stands out to me is, I think it was Ona Vanderhart did this with colleagues. And what they did was they were measuring the points of cognition. In other words, the point in the brain where the cognition recognizes a stimulus. And they found that the point in the brain was different for each alter that was tested. And this was about 10, 15 years ago, that just really established the reality of this. And part of the reason is that it wasn't until 1989, 2 books were written on diagnosis and treatment of dissociative disorders. They were the first 2. One was by Frank Putnam, who was working with NIMH, and the other was Colin Ross, who has the Ross Institute and was in Richardson, Texas. It's now in Austin. But those 2 books really established what we were looking for. Now, there is a cultural model that says, you know, of course you find it. It's in your culture, it's in your books, it's in your movies. So we took a team to China some years ago, and this was 96 to about 06. And we did a series of experimentations looking at differential diagnoses with schizophrenia. That's because they share the same symptoms, or some of the same symptoms of the positive things, the things that are added. They're called Schneiderian first-rank symptoms. And we trained a group of psychiatrists in the Shanghai Mental Health Hospital in Shanghai on how to look for, how to diagnose. We had an inter-rater reliability of 93.4, I think was what it finally came out. Very high inter-rater reliability. And it showed that that dissociation existed there in trauma. Now, what's important about that is it wasn't in their books, it wasn't in their movies, they didn't diagnose it, it was not even talked about because nobody knew about it. And yet we found it to be at the same level as every other country in the world.
Man, I totally agree. I think when it comes to trauma in particular, it's almost even bigger than a myth, because I find that when I work with other therapists and when I talk with other practitioners, they really struggle to have a solid definition of what trauma is. And so even kind of bigger than just a single myth, there's kind of this inability to really accurately define trauma. And so that's something that I've spent a lot of my career trying to make sure, hey, what is trauma? Because if the data shows that we are flip-flopping what trauma is and what it's not, that means our definition's incorrect. And so we need to have a definition that's culturally mindful and that follows the data. And so I think, like, really when we get down to it, it's a lot about identity. And in an experience, a physical, real-world experience where an identity is ripped away from somebody without consent, in that moment is trauma. Now, what that identity is for each person is going to be unique. And I think that's why we see kind of these differences in cultural variabilities. But really being able to accurately define trauma has to be something that we really strive for and something we keep pushing towards.
And the process that I'm talking here is mostly around sexual trauma prior to the age of 8.
Sure, yeah. When identity formation is so important, absolutely, absolutely.
I'm going to put my layman hat on a little bit, non-mental health. And there's so much fascination in the movies about multiple personality disorders. That's what most people know. Most people don't know what DID is, you know. So can you tell a little bit of the audience, is there certain stigmas about people with multiple or DID? Are they more violent? Are they more, is there a certain pattern of behavior? Because the movies seem to fascinate and make folks with DID to be very violent, very, characteristic in the sense where folks like elected officials that we have in the recent elections have been diagnosed. So can you tell us a little bit about the stigmas you see with folks with DID?
It's actually a shame that it is a diagnosable disorder because it's really more of a self-protective mechanism. It's a self-defense mechanism. It's a way of compartmentalizing yourself as a child. It's a wonderful mechanism to protect that core sense of self. And we used to think, and that's why the name changed, we used to think that they were separate personalities growing up alongside of each other, but they're not. It's a single personality that's fragmented, hence the name change. And it just floors me that, and to answer your question, you wouldn't know, in most cases, you would not know that a person is DID unless they told you. Typically, they hide it, very often ashamed of it. They feel very different, they feel broken, and they blame themselves for all of it when this was perpetrated upon them. So what do we look for? We look for how people carry themselves, how they speak. Are they looking down all the time? Are they withdrawn? Are they missing information? Do they hear voices in their head commenting on what they're doing? All kinds of symptoms around it that it is noticeable, and that we as clinicians, of course, can identify to be able to know that that's what's going on.
So, Dr. Hussain, you mentioned you were in a multidisciplinary practice where we've talked about that a little bit before, the mind and the body. What are some of the myths that you see when people try to disconnect those two? Really, they really are the same.
Sure, yeah, absolutely. And I think that itself is the myth itself, that they are disparate and that they are unrelated. And I think what I see as a major challenge is that even from a public health standpoint, even from the payer standpoint, reimbursement models, we treat them that way, right? You have distinct, in many states, you have carve-out states, you have distinct behavioral health payers and distinct physical health payers, right? And I think it's starting from the top, right? That we have bifurcated, and I understand the concept of wanting to ensure that mental health and behavioral health doesn't get lost within the greater sphere of medicine, but we've got to find a better way to really promote multidisciplinary care, because right now, unless you're, not taking insurance and not or charging patients cash, there's really no way to, not a very effective way to combine it in a very pragmatic way. And I think that's something that, for example, those patients who, mental health providers who provide, advanced therapies or advanced medications, whether it's Spravato or ketamine derivatives or different things, they have to bill the mental health payers for the observation, and they got to find a way to bill the physical health payers for the medication, but they'll both deny each other, right? So it's kind of like,
I feel that pain every day.
And so I think, again, going back to what I think as organizations, as providers, as those who are in the sphere, we've got to do a better job of speaking up about this. And I think whether it's, again, to our colleagues, our patients, to the public health powers to be, we've got to start to move the needle, because right now, all the innovative models and all the great things that we're talking about are wonderful and they're phenomenal. But unfortunately, as we were talking about amongst ourselves, you're really left treating and forced to really only focus on those who can pay out of pocket, as opposed to taking the vast majority of individuals impacted.
And then even with parity, having mental health parity with our medical insurance, it's just a name alone. It's still incredibly difficult for people to find care, let alone multidisciplinary care. Like, just give me one discipline and you can't get it. The insurance companies provide these lists that are out of date. They have clinicians who are not on the panel. They have people who have passed away. And it gets really demoralizing for a person who can't just pay out of pocket to even find someone to start this process with. And then we come to the part where it's really the innovative things are really only available for people who have a lot of money.
Yeah. You're talking also, you actually started this in talking about access. And I gave some testimony to the California legislature at one point, because they were looking at changing the law structure around treating children, and did. In other words, if a child was going into a center, it could not be any longer than 6 months, and they had to be returned to their families as quickly as possible. Well, that's good unless you're working with, say, a family that's been involved in human trafficking, and the family's the last place you want to send them, and they need long-term care, not short-term care, but they don't have any provision for that.
There's nothing available.
Mm.
Yeah, that's especially a problem here in Vegas. There are not a lot of people who treat children for mental health, and it shows because juvenile facilities they're always really prevalent, but actual treatment facilities are harder to come by.
And then just expanding on that for a second, that how damaging the situation is right now with the lack of outpatient pediatric mental health services. That there was a recent study that came out that pointed to essentially what happens is when a child has because of the paucity of outpatient resources, end up in emergency departments quite often. Well, they end up in emergency departments and then they're boarding there for 3 to 4 days because the inpatient facilities are lacking. And a recent study came out that children or adolescents who end up in an emergency department or get hospitalized for mental health services end up having a 70% higher rate of suicide. 70% because they ended up in one facility versus having appropriate outpatient resources potentially could have mitigated that significantly. So when we talk about crisis, when we talk about the next pandemic, the epidemic, we're living it right now.
Yeah, and outpatient resources also includes, prior to having to see a clinician, support for the family, support in schools is really helpful.
Well, I think that's really where we've seen such an improvement, because when you pay attention to the precursor indicators like dreams and other things about your mental health, you can kind of intervene on some things before they get to the point where, well, we're really kind of against a wall now. And so by being able to look into these things, and I think community and relationships has a huge part to do. You know, when we're looking at the people who come and use our service, it's always relationships are the first step into that. I had a dream about my partner cheating on me. I had a dream about my ex. I had a dream about that crush that I like, you know, that I saw. And so they're like, I want to know what this means. And so what we do is when we dig into that, we find like, there's a relationship component. There's a difficulty with the relationship I have with myself. And I think there's a lot to be said about identity and DID there. But even more, because of that difficulty with that relationship with myself, there's a larger difficulty with me connecting with the community and those people around me. And so you can see that breakdown kind of happening in those precursor events kind of makes this these symptoms become really exacerbated and turn into these large problems that we see.
But doesn't that presume, though, that you're in a city that has resources? You know,
Or in a city at all, because rural people have startlingly few resources.
Correct.
Well, that's what I think what we're talking about is like the community has such an impact. Your relationships have such an impact on your mental health. So if it's rural, that's a whole separate set of problems and obstacles. If it's in a city, in a community where things are so busy, it's difficult to even find places to have friends and create relationships in a whole different way, as opposed to rural, that creates its own set of problems and difficulties. And so being able to recognize those things and intervene there, I think that's a huge myth, is that these things are huge. If we start back with the relationship, catch them there, that's awesome.
Well, one of the things we're working in Maryland, I'm on the subcommittee for behavioral health for the state of Maryland, and we are desperately trying to bring pediatric and adult family health and family medicine providers into the behavioral health space. We're actually giving grants away to get them more engaged. Think about, you know, when you take your child in to see the pediatrician, they check weight, blood pressure, eyes, you know, full overview of systems. How often do they do a mental health evaluation?
Yeah, they're trying to do that a little bit more in the VA. It's not working that great, but I applaud the effort where they're having the primary care mental health integration, where there is a person who is like the liaison between the two. But, you know, when we go back to the myth that Dr. Singh was talking about, which is about medication, I think that as a whole, we do not emphasize enough how much relationships and connection are related to mental wellness, and that therefore people are like, oh yeah, no, I don't have any friends and I hate everybody at work and I don't talk to my family, but I'm pretty sure this pill is going to help my depression. And it's like, I doubt that.
and then, you know, going off of that, I think what we fundamentally also, you know, I think it's great, in speaking as a physician, gone to medical school, we really need to look at our educational curriculum for medical providers in general, right?
Yeah.
Where I think it's so, you know, it's great to talk about involving primary care docs, emergency medicine physicians, and everything else, But I really look back to myself and, am I armed with the proper tools? The tools I have is SSRIs, right? That's how I'm ingrained, or Haldol, or something really acute in the acute care setting. And I think the education of our colleagues, of our providers, going back to really basic levels of medical education across the spectrum of providers, I think is really, really important.
But it's always been basically set up from the very beginning that medication needs to be coupled with counseling.
Sure.
So that you get both, one, to monitor, of course, the effect of the medication, but more importantly, to integrate the concepts along with the use of the medication so that the client is on a trajectory of getting well.
Yeah, but the commercials are for the drugs.
That's
You're supposed
deal.
to ask your doctor if this medication is right for you.
That's
Not
what they
if-
say.
Not if therapy and improved relationships are right for you. No, just the pills.
Very correct. And at the end of the day, I mean, just to put my kind of disclaimer on this, I think what you alluded to is absolutely correct, that we've just tipped the scales way too far on one end of that spectrum, right? And I think medications absolutely are an important part of mental health treatment. I'm not in any way advocating to do away with that. It's just our over-reliance on these is, I think, is damaging.
Yeah.
And what we've got coming up, I mean, toward the future, is a lot of technique and interventions that have nothing to do with either. From EMDR to brain spotting to virtual reality techniques to the magnetic imaging. We've got a lot of things that don't really involve a lot either way.
So I guess we'll open it up to the audience for questions.
I was going to say, no questions? It makes it easy for us. So.
They're going to get us.
Oh. We can hear you.
Is the mic on?
It's not. Someone's coming. She's coming.
Oh, yeah. I think she's coming.
Hello?
Yep.
There
we
we
hear
go.
you.
Got it.
Thanks. Hey, everyone. How are you guys doing?
How are you?
Thank you for coming up and talking about mental health. It's very important. I just wanted to know from any of you guys, do you guys actually do like any mental health aid training? In my area, Washington, D.C., that's where I work now. And I've been in that area for a long time. I actually grew up in that area. And I think that has been the key to some of our success and just helping our community and gathering our community and making sure that our community is involved by giving that mental health aid training. And those are just for people that are lay people. It could be really anybody that goes to those classes. So I was just wondering, what's your feedback on that? And do you guys offer that to your communities?
Well, within our facility, we have a multi-tiered of specialties. We have our psychiatrists, we have our MDs, we have our, obviously our clinical staff, administrators. We enroll all of our non-therapy staff in mental health first aid through NAMI at Montgomery County. Yep. And so Montgomery County, Maryland has done a really good job with mental health first aid. And it's really good for the parents. It's really good for, anybody who's really not a mental health specialist, it is a really good tool. I am not sure how far it's expanded across the country. We're in 6 states. Really, Montgomery County is probably the foothold of the mental health first aid training. And I think it really could expand further, but I'm just not sure.
We do have something like that here in Las Vegas also that trains people who are not mental health professionals to be of assistance in the case of like a national emergency or a disaster or anything like that. And then there are people who train to like go with the police to a scene and actually sit with a person and try to help them as whatever's going on is going on around them.
I'm also the executive director of Green Cross Academy for Traumatology, and they have certification courses actually for those that are non-professional in the area of compassion fatigue, in the area of assisting as a field traumatology specialist. Anybody who can take basic training that comes under the heading of psychological first aid can offer assistance and help in a traumatic situation. And those are the skills that we also teach paraprofessionals, police, firefighters, EMTs, teachers, pastors of churches, chaplains. So I think it's just a matter of really looking for it. Most health departments have what's called CERT teams. This is the citizens response teams for disaster situations. So is it coming across the community? Yeah, it's starting, it's building. Could it be better? Absolutely.
I think just one step above that, also that I've seen to be quite successful are what are called, every state uses different terminologies as well, and that's part of different acronyms. But what we recognize across is that there are not enough providers for the amount of caseload and patients that are out there. And so, do we try to entice more psychologists, LCSWs, physicians, or do we try to create new classifications, easier classifications of those that can at least be involved in screening? So in the state of Pennsylvania, we have what are called BHCs, behavioral health consultants, which I found to be incredibly promising, where they could be trained a much lower intensity of education and easier to be able to get, but very effective in being able to screen a large group of individuals by deploying a much more robust team of BHCs.
Yeah.
Man, and I would say that that's been the huge push of our company is getting this mental health content and getting rid of that myth saying that you have to have a professional. Of course, you should consult a professional and do that, but some of these things can start with yourself. And so putting that in the hand of the patient, in the hand of the user to start that relationship with themselves and say, oh, wow, there are these indicators that are going on. I can see this going on in my life. And then talking with someone who's available 24/7 to be able to say, hey, what steps can you take now that you can do on your own to start to heal these things? Because it's totally within your grasp. And I think a lot of that comes from people having this antagonistic relationship with themselves. And so when we break down that stigma and say, hey, your mind is not your enemy, it's not against you, it's just misunderstood. Here's the tools to help yourself. I think that's a myth we have to overcome.
Let's go to the next question.
There's something that happened during the pandemic that I think was just huge. And that's the walls came down between the states, and we got to talk to or counsel people in whatever state they were calling from. And the walls went up almost immediately when things opened up again. There's what's going on right now in mental health is a counselor compact between states. And this is the first giant step toward parity across the board and being able to counsel in other states as long as by recognizing each other's licensing.
Yeah, great panel. There's a common theme throughout all of these panels is that what people need, is community, right? Connection, and to unload their trauma. And I feel like hearing a lot of panelists, they feel like they're bullied by mainstream science, right? That what you're doing isn't quantitative, qualitative enough. Well, as someone who comes from that, side of things, I would encourage you to keep doing it because mainstream science is biased. Every organization that proves something is biased.
Yep.
And they're slow to change. And that's been true in the history of science. So what you're doing, what the fitness people are doing, believe it or not, you guys are cutting edge.
Thank you.
One more question. We got 1 minute. Okay.
Reiterate what David said. Great panel. Really appreciate getting to see you guys here today. My question, the title was around myths. And I think we've seen a lot of really good information come out of social media, a lot of high profile people coming out about their mental illness, about things like that. And I think that's really helped raise awareness and raise acceptance of mental illness. But how do you think it's affect myths around mental illness? Have we created new myths? Have we been able to dispel the old myths? How has social media kind of helped with this?
I'll jump in on that one because that's kind of my whole platform with all the social media stuff.
We all look right at you, so.
Yeah, that's fine. That's fine. No, I'm all about it. So with any, I'm quoting comic books here, but with great power comes great responsibility, right? So it's like social media is just a fantastic tool to connect human beings with one another. But you connect human beings, you're connecting all of the human beings. You're connecting the wonderful resources and the helpful people, and the people who just kind of want to do some nasty things online. So there's a real power in being able to start, I think, a conversation. And so looking to social media as the answer and the place to get your diagnosis for yourself or to get your treatment for yourself, we need to create a better conversation around that and using applications and platforms, doctors who can give that advice. But what I really value social media for is finding that community, finding that connection, and then being able to increase the conversation and the dialogue around these things so that way people can start to help themselves.
Yeah. There are things we talk about on mental health with our social media that never would have been spoken aloud before. And so I do think that celebrities coming forward helps to break some myths. It does kind of solidify some other ones, which are that's rich people business. That's not something that either can affect me, or if it does affect me, I can't get help because I don't have that kind of money. And so one of the things that I do on social media is let people know about all the ways that you can get some discounted rates, some free therapy, some help and support that doesn't cost an arm and a leg. But I think that social media and celebrities coming forward really has actually been very helpful.
That's a great question. Thank you.
Because the communication has got to include the professionals as well as part of that community.
Am I on now? Here we go. Thank you so much, guys, for sharing all of your knowledge and great expertise. All right, guys, we are getting ready to do our ceremony and recognition session. First, I'd like to call up to the stage Christopher Saborin, CEO of Flow Patterns. Christopher, please come on up. Here he is. He's going to be our Vanna White. Next, I would like to call up to the stage. Christopher is going to be presenting our certificate of appreciation to our gold sponsor. Please give a warm welcome back to Justin Salomon, CEO of Outcome MD, to receive a certificate. Such a lovely one. And we have our photographer right there. Perfect. Justin, would you like to say a few words? Only if you want to. Okay. All right. Thank you so much, guys. Round of applause. Our gold sponsor, Justin Salomon, CEO of Outcome MD. Don't forget to check out their booth. Thank you so much all for your information this morning, for your knowledge, for your combined time and questions. We really do appreciate it. It's been a fantastic morning. And thank you, of course, for all of the collaboration. With that, it's time for our recognition session. As any industry grows, it's important to take a moment and congratulate those who have made it what it is, hence all of you. Health 2.0 Conference appreciates the exceptional contributions made by the thought leaders in the healthcare industry. And today, we are going to honor all of these change makers in our exclusive recognition session. So this is how it's going to work. We are going to call up your name. You will prance and strut up here rather quickly if you can. Thank you for helping us stay on time. You're going to take a picture with this nice gentleman, Christopher. We're going to have our photographer right here. And you're more than welcome to say a couple of quick words. Give a shout out to friends, family, support, all that good stuff. Without further ado, let's do this. Our first award for the Health 2.0 Outstanding Leadership goes to Akil Tower, MD, please come on up. Next award goes to, also for outstanding leadership, Alexander Coons. Alexander. Okay. Oh, nope. Next award for outstanding leadership goes to Anmol Gotra. Anmol, are you in? Here he comes. All right. Third time's a charm.
Just two quick things. First of all, I want to give a quick shout out to my family for always putting up with my shenanigans. And secondly, there's a lot of innovators in here, and I just want to stress the fact that we want to build for our clinicians and the patients that they serve. So always keep the clinicians and patients in mind. Thank you.
Thank you. Beautifully said. Our next award for outstanding leadership goes to Carly Applegate from Carly Jolynn Applegate. Lovely. Would you like to say a few words?
I want to thank my husband and my baby sister who came all the way from Wyoming and Montana to be here today, and all my work family and clinicians in Wyoming. Thank you.
Big shout out to all of our family and friends on the live stream. Hello, hello. Thank you for being here. Our next award for outstanding leadership goes to Deepak Arora. Deepak, please come on up.
Just wanted to say one thing. This award is for my belated daughter, Mahi. It's because of her I'm here today. Thank you.
Our next award is for outstanding organization. This goes to Doug Sparks of Precision Value-Based Management. Please come on up, Doug. We'd also like to invite the entire team to take the stage. Come on up, guys. Great job on matching. I dig it. It's going to make for a beautiful picture. Would you like to say a few words, Doug? Anybody? A few words? Yeah.
I just want to take a second to thank everybody that put on this conference. I started coming 5 years ago, and it was the Smart Health Conference. It's a unique opportunity, and I like really what Jatin and the team did. They wanted to create a conference where everybody here could collaborate with each other, not like the other conferences where they're trying to poach your talent and they're not sharing any secrets. Everybody in this room is a candidate to work with each other. I'll always support that mission. I'll be back every year. Thank you very much, the organization.
Thank you. Moving right along here, our next award for outstanding leadership goes to Itis Lima from Itis Lima MSc. Our next award for outstanding leadership goes to Filza Naveed. Filza, please come on up. No Filza, we will continue on. Our next award for outstanding leadership is for Hiromi Ozawa Miller from Dr. Hiromi Ozawa Miller, DPT, CSCS, NCPT. Please come on up. Someone's going to have to tell me what all of those mean, because now I want to know. Congratulations. Would you like to say a few words?
I just want to thank my husband for all the support that you have given me, and also all the team members working right now in Monterey, California. Thank you.
Congratulations. Our next award for outstanding leadership goes to Isha Aurora. Isha.
Thank you to Health 2.0 Conference for the recognition. And I started 10 years ago in regulatory compliance when no one knew what that word meant. So I'm really proud of the work we've done over the last 10 years to educate life science companies. And I look forward to continuing moving the needle forward with everyone. So thank you.
Congratulations. Our next award for outstanding leadership goes to Jeffrey Lucas. Jeffrey. Guys, our team will definitely be in touch with you in the coming weeks to, of course, get you copies of your wonderful picture and to support you in any other way we can. So definitely keep that in mind. You'll get your picture so you can share it.
Want to thank Health 2.0. This has been an amazing conference so far. This is my first time. We have an exciting project we're working on. I have one of my colleagues, one of my trusted colleagues, David Sklar here, our Chief Medical Officer for Vitally Care. And I've reached out to a lot of you hoping to share with you what we're doing for our feedback, because we think we're bringing a platform for the future of care that I think involves a lot of the conversations that I've been hearing. And by being here, we are learning by listening and look forward to the rest of the conference. Thanks.
And moving right along here, our next award for outstanding organization goes to Jim Onik from Epic Lasers. Please come on up, Jim.
Just a quick thank you to Health 2.0. This is, I think, my third or fourth event here, so a great conference. And a shout out to my company, who's an integral part of this Epic Lasers organization, especially to Kelly and Donna, who I think are listening. So thanks.
Congratulations. Our next award for outstanding organization. Hey, we know him. Let's please welcome back to the stage, Justin Salomon, Outcome MD. You're going to have some new additions in the office, Justin.
Thank you. And if anyone wants outcome tracking easily embedded into your existing softwares and technologies, let us know. It's pretty easy to do and incredibly impactful. Thank you.
Thank you. Our next award for outstanding leadership goes to Katie Cole from Katie Cole DO. Whoop, whoop.
Well, first, I would love to thank my team at Hope for Healthcare for their dedication, passion, and commitment to the past few years of service. I want to thank our healthcare well-being community for their amazing support and all the amazing work that everyone is doing to try to heal our national healthcare system and move healthcare forward. in the future. And I also want to give a huge gratitude and thank you to Health 2.0 for gathering us here this week as a community to really learn from each other and share our wisdom. Thank you so much.
Thank you. Our next award for outstanding leadership goes to Kelsey Butler from Kelsey Butler MSRDN. Here she comes. Guys, friendly reminder, if you haven't done your interview yet, our team of roving reporters would love to learn about you and your brand and your mission, so please be sure to stop by. You can find them across from registration in the corner. And of course, we'll give you that copy of that footage as well in the coming weeks.
Just want to say thank you for the honor, and thanks to my mom for coming and always supporting me in my education and career and all my passions. So thanks.
Couple more awards here before we break to lunch. Our next award for outstanding leadership goes to Mark Pugh. Mark. You are standing up ready to go. Nice. We should all get an award for going up those stairs, huh? Especially the ladies with the high heels.
Thank you to Health 2.0 and this great conference and this award. Thank you to my wife, my family who've been very supportive. Thank you to the workers' compensation industry, which you've probably never heard said before, for finally understanding that a biopsychosocial claims advocacy model actually works. And I'm currently the founding partner and provost of Work Comp College, and there we are launching a workers' recovery professional certification focusing on whole person management. So this is just the beginning. Thank you very much.
Thank you. Our next award for outstanding organization goes to Marlise White from Soma Life. Marlise. Oh, yes. Okay, sure.
Thank you very much for having me here at this convention. Soma Life has been around since 1998, and today is the 7th anniversary of the passing of my husband, the person that formulated our products. He would be very proud of me here to be able to accept this award. And his big thing was always to say he wanted people to die old, as young as possible, and that's why he created our products. Thank you very much.
Thank you. Our next award for outstanding leadership goes to Patrick Gee, DPT and CMP. Please come on up. Patrick, there he is.
I'd really like to thank Health 2.0 for this award. I really appreciate it. I'd like to thank my family for all their support and my teams in the San Francisco Bay Area for really making a difference in patients' lives. Thank you.
Our next award for outstanding leadership goes to Scott Martin. Scott. It's funny, there was a little collaborative delay there. It's like we all knew somehow Scott wasn't here. Wherever you are, Scott, congratulations. Moving right along, our next award for outstanding organization goes to Steve Yaskin from Health Gorilla. Steve. You guys are all psychic. How'd you know that? Going 2 for 2. Little delay there too. Okay, third time's a charm. Our next award for outstanding leadership goes to Suba Ramaya. Suba. All right. It's always the third one. Yes.
First of all, thank you so much, Health 2.0, and all the people involved here to put together this amazing conference. I've been in the industry for 30 years. I've been recognized for other things, but being recognized among the global peers is a really humbling and very, very rewarding experience. I want to thank behind every leader, there's always a person, and I want to thank my wife, who's standing right there, and without her, I wouldn't be here, and also my family members and physicians and doctors, 57 of them watching globally. So, hi guys, thank you for support, and really appreciate it. Thank you.
Beautifully said. Thank you. Our next award for outstanding leadership goes to Timothy Washburn. Timothy, please come on up. Our next award, also for outstanding leadership, goes to, hey, we know her, Winnie Chan Wang. Please come back up, Winnie.
First, I want to thank my family, especially my father, who is a surgeon for 55 years, always inspiring me to serve in the healthcare industry. Secondly, I want to thank all of you for being my teachers, because whether you practice Western medicine, Chinese medicine, or other kinds of medicine, without you, I don't know how to hack my body, so thank you. And lastly, I want to thank humanity, because 100 years ago, women in my culture are not allowed to practice medicine. 100 years ago, people of color do not stand on the same stage. And they don't get recognized or receive an award or given an opportunity to speak. And 100 years ago, there's no internet, so we wouldn't be able to have this health conference and network with each other. So thank you so much, humanity. Thank you for all of you who want a better future.
Thank you for that touching speech. And with that, our last award for outstanding leadership, last but definitely not least, please throw your hands together for Itis Lima, MSc. Itis.
Thank you very much. I am truly humbled to be here today. I have goosebumps already. A great speaker right before me, and I won't shed happiness tears, but I just first off would like to thank my incredible family who's here in the back. I am a first-generation Cuban American, and we all risked our lives at sea to be here today. So as a professional in healthcare, my life would have been completely different had I stayed in Cuba and not made it to the land of the free. I'm so thrilled and just like words could not say how much both my parents have inspired me. My dad's a mechanical engineer and my mom is a veterinarian tech, and I believe I'm right side brained and left side brained because of them. And although they don't practice that today, they have their own small businesses separately. They inspired me all throughout high school to become an entrepreneur. And so Curiva and myself wouldn't exist without them first. Secondly, with my significant other, who is just the bread and butter and my true soulmate, Landon. He couldn't be here with us today, but he's my other half and his family too. So they're truly the elixir and the juice that keeps my gears running to just become a more transformative leader in this space. And last but not least, too, I would like to thank my incredible team back in the Midwest. We're in between Goshen, Indiana, and Chicago, and all of our advisors are on the East Coast. So we want to enhance economic development in the Midwest and just engage and propelled that young generation and the future of healthcare, artificial intelligence, and new innovative products together. So thank you very much.
Congratulations. You good? Wonderful. Great. And that, my friends, is the end of our first award ceremony for the day. Congratulations to all of our award recipients. Thank you, Christopher, for being our helper. We sure do appreciate you. And guys, it is time for lunch. Everybody's favorite L word, right? Enjoy. We'll see you right back here at 1:30 sharp. Bon appetit.
Check 1 2.
Ina, Item.
That you like to highlight or?
It refers to people who don't have access within 2 hours of their. Hi, there we go. Just checking you.
Say something. Something, something. And you want to write.
Hello.
Are you here? Christopher, are you here? Christopher, flow patterns. Hi, guys. Good afternoon. I hope everybody had a wonderful lunch. We are going to go ahead and get started as I know more people are making their way back in, finishing their drinks, all that great stuff. We want to keep everybody on schedule for their awards and networking, all that great stuff. So without further ado, let's start our next panel. This next panel discussion, Healthcare Disrupted, How AI and Digital Health Are Transforming Tertiary Care. Please correct me if I said that word wrong. I'm going to bring up our moderator to lead the proceedings. Can I please have Dr. Wendy Ringo come to the stage, Chief of Medical Affairs from Biometrics. Round of applause.
Good afternoon. Oh, I don't know which one is the one now. Good afternoon. Yes. Good afternoon, everyone. I would like to welcome our panelists up as we get started with this section of our discussion this afternoon. I know it's a hard act to follow after lunch, but we will definitely do our best. My name is Dr. Wendy Ringo, as she mentioned. I'm with Biometrics out of Royal Oak, Michigan. We are a digital healthcare organization, primarily interfacing on the primary health care side, CCM or CCM and remote physiologic management is what we particularly cater to at this time. We also work with nephrologists and cardiologists with some of the wearables and digital devices. So we are very adept in this space. So without further ado, I'd like to introduce my esteemed panel members here to help further this discussion about the disruption of healthcare as it relates to AI and digital health and how it has impacted tertiary healthcare. So without further ado, I'd like to start with the first esteemed panelist. And for the interest of time and also so that I won't mess up anybody's name, I will allow them to introduce themselves.
Excellent. Thank you so much. My name is Regina Atim. I am the founder and CEO of Clinicians Touch Healthcare Solutions. And at Clinicians Touch, we primarily work on human factors and health safety solutions for both industry and hospital systems alike.
Okay.
Thank you. My name is Subha Ramaya. Thanks for joining today. And my background is in technology, digital health, and in healthcare organizations in the past 30 years. My undergrad is engineering, graduate school, computer science, and I've been in the industry for about 30 years in 5 sectors, the last 15 years in the healthcare. My passion is driving better health outcome using digital health technology. I worked for Cigna and Anthem in the last 15 years. And the overall aspect of this topic, I believe, what we're here to talk about is how AI and digital health and technology drives the change in tertiary care. So I'm not a doctor. I don't play one on TV. I'm among the esteemed panelists of 2 other physicians. And thank you.
Hi, I'm Fabiola. Is my mic on?
I think so.
All right, then there we go. I'm Fabiola Buferdades. I am here all the way from Amsterdam, you guys. I am with NeuroReality. I'm the founder and chief innovation officer. NeuroReality is a VR-based telerehabilitation solution, and we primarily focus on acquired brain injuries, so anything from stroke to concussion to individuals who have had an accident. But during the pandemic, we saw a great amount of growth in other different user cases. So we combine a really powerful way to gamify and make this type of rehabilitation a lot more fun by harnessing neuroscientific principles and neuroplasticity, the ability of your brain to regenerate and grow past the point of having had an injury. And we utilize the combination The microphone keeps going off, doesn't it?
Go ahead.
We utilize a combination of neuroscientific principles as well as smart algorithms, supervised machine learning, and we're capable of remotely monitoring or utilizing the solution in healthcare facilities. So that's a little bit about ourselves, and then I think we'll get more into all that.
Thank you.
Well, thank you for sharing. With that being said, I know there are so many different directions we can go in when we start to talk about tertiary care. So how about if someone would do me the pleasure, if we're talking about tertiary, how about primary or secondary care? If we're talking about the disruption or how digital healthcare or AI is impacting on tertiary, can we first go back to define primary, secondary, tertiary?
So I would say that the AI and digital medicine has definitely disrupted the field and put more of the ownership of the healthcare on not only the patient, but also their caregiver. So it's allowed for them to interact a little bit more with one another and to really have more real-time results and real-time discussions about their health and to really help the end user to feel a little bit more ownership and a little bit more, I would say, understanding and have a lot more information really at their, for them to be able to just see, with the use of their phone, any sort of information that they may need from their physician. So the communication channels have definitely been opened more. And so I think there's a lot more to be done, but the information is definitely there.
Yeah, I think the definition, right, why we determine primary, secondary, and tertiary care. As I said, I'm not a doctor, but I have a family full of doctors, 58 of them. So primary care is when people, when we cough, we have an infection, we go see our doctor, medication is given, and then we are healed. And then in secondary care, where a complexity becomes a consultancy for a specialty like a deep chronic disease, heart condition, diabetes condition, or chronic diseases. So that becomes a secondary care. In tertiary care, it becomes very super specialty, like neuroscience, for one good example. Also in cancer treatment and other oncology and genetic-based diseases and so forth. I think that's the way we differentiate primary, secondary, and tertiary care in general. Tertiary care becomes very complex because it has to be coordinated with all the different primary and secondary physicians to coordinate a welcome. So I think that's the way I see it, tertiary care. Where the technology plays a major role is that all the primary physicians who are caring for the patient, for the condition, are disconnected everywhere. So the digital health and AI in the history helps to drive a data unification and learning about that patient from that perspective. So I think the concept of how AI and digital health drives the tertiary care is affordability and access. I think that's a stage we can further discuss.
I think as well, it also helps with continuity of care, which is something that's very important. And you often see patients that go through their treatment modalities, but as we've been discussing a lot at this conference in general, that doesn't necessarily lead to outcomes. Treatment is not outcomes. So tertiary care, as you said, it's such a broad definition. And tertiary care also includes a lot of individuals who don't have access to healthcare facilities close by. So some people will also define tertiary care as a facility that is approximately 2 hours away from where you would actually be receiving your care. For me, that was sort of a huge inspiration in creating NeuroReality and founding NeuroReality, because my grandmother, she passed away from a stroke, but this was completely unnecessary. She lived in Kamloops, which is in British Columbia, a rural area. And for her, the catchment area of the hospital that was served was about 25,000 kilometers squared. So, that way, if she needed any type of specialized care, she had to go all the way to Vancouver. And a 3-hour trip to Vancouver, a 3-hour trip back for someone that is suffering from a stroke. She had, of course, her first stroke and then subsequently, unfortunately, passed away from another large stroke. But if we had been able to give her this type of opportunity and have this type of tertiary care and the consistency during the whole process, let's say, of her trajectory into learning to deal with this new reality of her life, I think that that would have been fantastic, because digital health allows you to not only look at your patients while they're in the office, but also to monitor them and help with diagnostics when they're at home in the comfort of their own home.
I think that's the best point right there. Surely it does help for and make for better analytics overall. And as you mentioned, the monitoring even when they're at home. So if we're talking about wearables, if we're discussing, 5G devices, so that real-time information can be relayed and action can be taken in, again, real time. So key points to that end. But what I'm most interested in, if we're talking about how it's really disrupting or changing tertiary care. I know you guys represent various backgrounds. We have pharmacy here, we have tech, and we have innovation with tech here on the end. How would you say that AI and or digital health or digital monitoring is impacting your specific areas of healthcare?
Yes, great question. So I actually, I still believe that the continuity of care issue is something that is being definitely impacted by AI and digital medicine advances. And, an example is maternal mortality, for example, which we know is a huge issue currently and was worsened with the pandemic. If you have wearables and if you have digital monitoring solutions, that's something that I think could make a huge impact in maternal mortality. For example, monitoring the patient while they're at home, as you'd mentioned, after a condition, or while they're awaiting their delivery date, and postpartum as well, because we know that for maternal mortality, a lot of those fatalities occur after birth. So I think, that's one example of where, this care, this digital medicine and advances could be utilized to advance care.
Yeah, I think the point I was going to add to that is that in the past, the last 30, 40 years, if you see the technology evolved to where it's possible today that a physician, no matter where they are, could get the typical vitals on a continuous basis of the complex patient, no matter where they are. So for example, like I'm wearing a clinical device watch here. This is currently providing about 15 different vitals live continuously, so that the physician who's monitoring in the back can actually see the trend. So the data of how the historical vital signs have grown, are gone down, are better for the outcome, can be actually measured, right? So the idea behind that is this: the technology has driven us to today's point where these things are possible, where a vital sign, like I mentioned 15 different vital signs, those are even not available in the ICU, but with a watch and a patch, the doctors can actually get a historical data. So that data feeding in, and then you had earlier sessions, so 2 or 3 sessions there, we talked about data, interoperability, and then the data history, and longitudinal patient record, right? So all these data is coming in, and with the advancement in technology, now the AI can actually see a 2 to 3, 4-year trend of all the vital signs. And then that's, I think, is the change which the digital health provides for tertiary care.
So I'll elaborate on the data part of that. I know that people are very concerned, medical data and the storage thereof, but at NeuroReality, we're capable of collecting about 10,000 data points that lead us to understand the disease state of our patients, and we specifically focus on cognitive deficits, which are generally left untreated, and in oncology all the way to I mean, even dialysis, kidney dialysis, but we work primarily, with brain injury patients. And in that way, we can consistently monitor what is happening with our patients. We get that data. We're capable of passing that data on to the clinicians who then, as you mentioned, are capable of providing, because everyone is different. So we need personalized care. We need unique care. Even within a brain injury or a stroke, for example, every person is heterogeneous. So we are utilizing all of these different types of digital health solutions and AI in order to understand our patients better and provide more directed care. Because when you go to a physician or primary or secondary care, you're usually getting just a snapshot of what's happening with your patient. You're not necessarily getting the full picture. And I think that this has been further exacerbated by the pandemic, where we saw that a lot of what they would call non-essential procedures were very essential. And if you are able to utilize digital care and AI to connect with that ability to have continuity with your patient files, with combining this with your primary and secondary care, and that everyone has a holistic approach to this, then we see that there's a lot of possibilities. And I think especially in telehealth, that's really, really where we're noticing these huge things. We collect with our data a lot of normative data from the general population. Excuse me. And with that, what we can do is, with thousands and thousands of healthy individuals, looking at their demographics, we can compare those to individuals and learn more about their disease state and where it is, as I said, that we can focus on instead of doing a lot of procedures. Doctors are taught, this is the procedure that you offer, this is how it goes. So they might feel that doctors can be a little bit dogmatic. They're amazing, but they were taught to administer care in a specific way for a very long time. So now we're disrupting this industry by bringing in all of these digital solutions and utilizing supervised machine learning and all sorts of things that are involved in AI that are capable of pushing forward our agenda, which is essentially better patient outcomes and better healthcare outcomes.
Thank you for that. So that does lead me to this question then. We've done...
It's a tech conference. We always have difficulties at tech conferences, don't we?
Okay, great. So what would we say, having said all of that, surely does help with the efficiency and the data coagulation and the analytics and operational benefits, but what are some of the challenges you think, either of you, that we are facing with some of our tertiary care models as it pertains to AI and digital?
So I would say that at Clinicians Touch, part of what we've been doing is human factors usability testing on a lot of these digital solutions. And a lot of the issues that we found have been related to the interoperability and the transferability of the data, and having that data be available in real time to the provider, and have that provider be able to process that data and also then, respond. And many times, if this is not a part of their work process, it's something that may be available, but if it's, at what point is it actionable, right? So I think within what I do in human factors, we try to test to see how usable a lot of this information actually is, and how we can make it more usable for all the end users and empower everybody that's involved within that healthcare continuum, so all the way down to the patient. So if the patient is being monitored and they see something that is consistent, perhaps if they have a blood pressure that is out of sync for, say, 3 to 4 or 5 days, right? Then they perhaps could then put in a call for their physician and say, hey, I know you're getting these labs, but they may be going to their computer system and may not be alerting the physician, like, hey, this is a high alert now, and you need to take a look at this. So it's just creating a system that allows for it to be smart, right? So that's the AI functionality to say, hey, we've noticed this trend and now it's gotten to this alarm state and you need to pay attention to this and you need to take action. So I think that's right now the constraints that we're seeing in our testing, but hopefully as we go through the testing and going back and forth and working with all our engineers, we can figure out a solution that can help us to get to that point where it's just not information overload.
I would love to jump in there. I think that what's really important that I took from the beginning of what you were talking about is we need to make sure that we fit into the patient journey.
Mm-hmm.
And that is very important because the patient journey is where we're going to be able to, let's say, convince these care practitioners that the solutions that we're providing, even though they're disruptive, are not taking away from their jobs. I think a lot of people have this notion that AI is going to take over, maybe in the future, but right now, the way that I see it is an assistive technology where the golden standard is still the clinician. However, with this, we're then able to fit into the patient journey and make sure that all of this information is given to them in real time. At NeuroReality, we have a back end to the product that we created, which is a really great way for not only the patients, but the clinicians to be able to see how they are progressing. And then that takes me back even to my grandmother, where if we had been monitoring her remotely, we would have gotten those alarm signs. And that's a big challenge, is implementing all of these things and having them be accepted. I think that right now people are very interested in this type of actionability in healthcare. However, it's not necessarily that easy to penetrate the market yet. It will become easier, I believe, especially as the pandemic highlighted, but still, I think the most important thing for creators like us is to talk with the patients, talk with clinicians, talk with all of the different caregivers that you're working with, and make sure that the solutions that you're creating are wanted, are necessary, and are actually fitting in with the care continuum that they would provide. Because otherwise, they're not going to adopt our solutions necessarily.
Yeah, and I think I totally agree with you, because the point here is, one is to collect the data, the other one is to make it available to the responsible physicians and the caregivers, and the other one is to feed back to the patient on how they're doing. So in a simple nutshell, when we say digital health, how does it impact health? I would put it in a simple common word term, is that a doctor in my pocket, a nurse in my purse, a therapist in my jacket, a pharmacist in my fingertips, a clinic in my GPS, a lab in my lab, and a hospital at home. If you think about it, this is the concept of digital health. It covers the whole gamut of the entire continuum of healthcare. So that's an easy way to understand how digital health impacts every aspect of it. And I want to point out one example of compliance, right? So if you take tertiary care, let's say a cancer patient and other folks who are taking very expensive drugs, so drugs could cost you as much as $80,000 a month. So compliance is that, how many of you guys know that among the medicines prescribed, how much of them are being picked up from the pharmacy, and then how much of them being consumed by the patient, and then the feedback to the clinician that they are actually consuming the medication as they're done. So the digital health helps to do the compliance aspect of it as well, because typically 30% of the medications prescribed are never picked up, and those who are picked up, 30% are not consumed. So if you think about that concept, the whole area of the doctor in my pocket, nurse in my purse, brings back that digital health. So digital health helps to drive that collection of all those things into a holistic part back to the care team. So I think digital health helps to drive that change. And then from your standpoint,
is the usability of devices and technology and so forth is the human factors part, right?
No, absolutely. And I'm glad you brought up the aspect of medication compliance, because I think that's the core of a lot of the difficulties of, the sequelae of effects that occur with patients. And we've struggled in pharmacy to figure out, how do we ensure that patients take their medications? And I previously did some testing on an application that was testing actually ingestibles, so testing to see, when the patient has taken the medication. And it's not perfect, but I think it's a start. But as you mentioned, digital medicine definitely allows for the communication, at least even with the pharmacist, for example, and their patient. If they're connected, the pharmacist or their other caregiver can notice that maybe their labs are off. And if it's something, they can ask the patient, are you taking your medications? And patients are very honest with their pharmacist, more so than they are with other healthcare providers. So usually they'll tell them why. And then the pharmacist could then take that information and maybe notate their chart. But this all, requires the interoperability with the EHR, for example, so that the doctor can see those notes. So this is definitely futuristic, but it's not something that can't be done right away. And it's something that, if it was done, you could identify maybe not only that the patient's not taking their medication, but perhaps why, because they will normally tell you why. They may say, I don't like how it makes me feel, or it gives me constipation, or I'm having these other effects. And if they're speaking about it honestly, perhaps we can then intervene and either add something on if there's no alternative, or exchange that medication for something that works a little bit better to then, ensure that compliance. So absolutely, I appreciate that you brought that up. And again, it shows how disruptive digital medicine and AI can be.
You have about 2,000 cancer drugs on the market. And when a doctor prescribes you a drug in oncology, they just go ahead and they pull from whatever that list is. And perhaps the patient, as you said, is not feeling good about that medication. And while you're already going through and suffering and dealing with a lot of challenges, you're not a doctor yourself. You don't know exactly what to do, and your family as well wants to help, but they don't know what to do. So AI is now making it possible to identify, again, individualization, giving patients autonomy, and then saying, this would be the particularly best medication for you. The way that we do it is completely different. We utilize reward. So with the VR-based software, we've created a prescription game, which is really quite disruptive and new. And we'll get a little alert, the clinicians will, and we'll then remind the patients, hey, you haven't been participating in your program, why? And what we do to incentivize these patients to do so is by making sure that they feel rewarded by what they're doing. I don't know who doesn't like fun and games. So what we did was we combined all of these principles in order to make sure that even while playing a game, we're gathering all of the vitals that we need and the information that we need. It's being analyzed by AI. We treat individuals at a different level. We calibrate to their particular level. So in the beginning, as I said, not everyone is the same. So we'll calibrate it to their level. And then in this neurorehabilitation game that we've created, you are capable, it's called Koji's Quest. And you have a digital companion who is then taking you on the journey with you, making it not so necessary for your clinician to be present with you. And the more you play, the more elements of the game become open, and people really enjoy that. So I think I was really inspired. I was born in the 80s, so I was really inspired by 90s kid video games like Tetris and Pokemon and things that really have withstood the test of time. So what we did was we took a lot of these paradigms and gamified them, and then give people rewards in order to make sure that they're actually complying, because then when you come back to play the game again, you know that you're going to get gems or stars or these little coins that you're going to be able to utilize within the game. And that helps as well with the continuity of care, because in this sense, we're triggering the dopaminergic system, which is our reward system internally, and neurobiologically, we are wired to seek rewards. So if you're providing that type of care, then something small like a virtual assistant in our game, Koji, your little doggy that follows you around and shows you how to take the actions if you're not with your clinician and what to do, you can customize him. You can customize the world, the virtual world. So there's a lot of different things that can really be done in order to make sure that we're achieving these types of outcomes.
Is there something you wanted to add to it?
Yes, I was just going to add that that sounds wonderful, and it's one of the principles that we really push in terms of engaging all of the parties that are involved. And it sounds like your solution is attempting to engage the patient in their own care, and that is something that we test a lot of in human factors when we work with our different clients. It's just we see clients are all trying to figure out a way to engage their end users and empower them to be a part of their solution. So gamifying it or making it a part of their everyday, life is definitely, I think, a good way to promote that and keep them engaged and keep them participating in their own health. So thank you.
Of course, it creates autonomy for these individuals, and everyone wants to feel autonomous after they've suffered from something so drastic as a medical condition that has changed their life.
Absolutely. And you mentioned even, with stroke. So I could definitely see something where, in addition to whatever application you're adding, that perhaps you could add something that could be stimulatory, maybe to help them to regain some of that function that maybe they had lost, that they can do on their own without necessarily having to go into therapy, or, something that they could manage and do as they feel they need to, right, at home. And I can definitely, see utility also in the mental health sector as well, where, you stimulate the participant to engage in their own health and tell you how they're feeling, how, if the medication is working this way or that way, and monitoring that. And then when they do get, in front of their doctor, they have very specific things to then talk about, and they hopefully would feel that this entire time that the information has been gathered, the doctor has had all of their information at their fingertips, and for the physician, hopefully that gives them the ability to understand what's happening with their patient since they last saw them. If they haven't seen them for 3 months, perhaps they can look at some of the data, some of the documentation that the patients themselves have documented, and then, prior to seeing that patient, read over all of that information and hopefully then come to a meaningful and more accurate conclusion on what's actually happening with their patient.
Well, I'd like to ask, with the time that we have remaining, what does the future look like from the perspectives of each of you as it pertains to AI and digital healthcare?
Maybe I'll just start and then please join in.
I think that honestly, I'm like, the future of medicine is here.
Yeah.
It's very unfortunate that on the news we get a lot of entertainment, but we don't actually get information unless we partake in these types of conferences or we're experts in our field. So I think that's quite a shame. But if we're making sure that this sort of, we talked yesterday a little bit about also people don't know necessarily that these options are available for them. So I think that if you are promoting these better healthcare outcomes and you're showing that you're capable of producing them, then more people will be, and more clinicians, not just patients, will be able to harness all of this information and utilize it. And I'll pass it
Sure.
to you for more.
I think where we are heading is that the digital health tools and technologies and emerging technologies which are coming out, they are adding value to the patient and the physician and the whole 5P ecosystem. So what I mean by that is that in a healthcare ecosystem, there's the patient with the first P, providers, second P, payers who pay for the third P, and then the pharma is the fourth P, and the fifth P is the partners, all the devices, the labs, the imaging. So if you think about all these 5P ecosystems, they are actually today siloed, and their systems are optimized to best do that service they provide. However, the patient is stuck in the middle. So what digital health is doing now is breaking those walls of those 5Ps, becoming consolidated, trying to bring them all down so that the data from all these various areas are now available to the doctors who are caring for them in primary, secondary, and tertiary, as well as all the care coordinators, such as the therapists and the pharmacists and the other folks who are coming home for elderly care to give therapy. It gives them all the complete, I would say, comprehensive, historical, longitudinal patient record, if I want to put it in a nicer way. So history tells an elderly patient who's at home, multiple chronic vitals has to be monitored, whether for a specific condition or for the other conditions which may exist. So I think that what digital health is doing is now bringing those old new emerging technologies and making it available to the physicians and all the 5P stakeholders. I think we're just scratching the surface. In the VR you mentioned, VR therapy for physical therapy, VR and AR physical therapy now. Today, you could wear a VR headset, and as you do the therapy, the physical therapist could actually be with you virtually in the VR, in the Web 3.0 world, where they can actually see the range of movement accurately. Usually, the physical therapists measure you with a little, physical device, but in the wearable world with the VR headset and the handset, as they do the therapy, physical therapy for the back or whatever condition, those data is fully available. So I think that's what is going to change, I would say, the full 360 view of the patient.
I would love to add to that. I think that as well, so we focus not only on, of course, it's very important to have physical rehabilitation, but that I feel is pretty well dealt with. We focus really on cognitive complaints, which affect people's activities of daily life, their quality of life, feeling like they are capable of doing things that they were once capable of doing, but are now no longer. It's about 420 million individuals that are living with the consequences of a brain injury and have cognitive problems. So if we're capable of treating these individuals now with digital health, then we're saving resources. We're creating the opportunity for things that weren't formerly possible. And if you look at what's happening now with these individuals, about 1 in 10 of them are receiving some type of cognitive care, leading to a deficit of $400 billion in our economy. So this trickles down. So it's not only the high care costs, but also the inability for these individuals to return to their daily lives and be productive members of society. So what we're doing with these types of interventions, this digital care, utilizing AI, utilizing data, is we're actually being able to utilize our resources in a much more friendly and comprehensive manner to treat perhaps ailments that aren't even being treated. About 1 in 10 individuals actually receive the proper treatment that they need after experiencing a brain injury.
Yeah,
Absolutely. And to add to that, so definitely remote monitoring is the future, and that is now, and that's something that's now currently being utilized in underserved populations, for example, or remote areas where they don't have access to
some of the healthcare workers that would have that expertise. So digital medicine and AI and different tools can definitely facilitate and allow the providers to remotely manage patients. And I think the future is that we can all be managed remotely if we have chronic conditions, asthma, diabetes, or any other chronic condition, cancer, that many times you should hopefully be able to be monitored at home until you absolutely need to be in the hospital system. And I think one of the reasons that I got involved in human factors was to reduce error. And as we know, medical errors are the third leading cause of death in this country. So wouldn't it be great to be able to remotely manage most people and empower the patient to be able to be a part of their own care so that they're less vulnerable to being in a hospital system or a hospital setting where they then may be at risk for medical or medication error. So I think the future is now, and remote care is where we're going to go with VR and with digital medicine.
Yeah, I would add two more things. Software as an MD, you will hear the terms coming up, SOMD. Basically what that is that with all the historical information available through the consolidation of the 5 Ps, the AI now is able to pick, including the genome data, including the genetics, and including the social determinants of the health, because 80% of one's health is not on medicine within doctors. 80% of the health is your genetics and what you do, social determinant of the health. The 20% is where it comes from treatment and post-acute and pharma and others. So if you think about it, the adding the component, what is in the future is software MD, software as a solution. Once we have all the data, that can actually triage and help the patients, and then digital therapeutics. Because once you have the genotypes and gene data, genetic data into the healthcare baseline, you can see certain triggers which could cause that, and then proactively help somebody to get worse or even get that disease to intervene that, right? Yeah. That's the future, basically. Software as a solution, and then digital therapeutics, remote patient monitoring to summarize it, and then the 5P consolidation, and then the digital health driving the change. I think that's
Absolutely, and I think you're not really taking the power away from the physicians in any way, because this is all really just clinical decision support, but at the end of the day, the clinician is the one that has to pull all that information together and make those decisions. But what it does is it just frees them up to be able to do that important work, so that they're well rested, they're able to maybe help more patients, and also utilize their skill set at the highest level that their training allows, so that they're not dealing with some of the things that a machine, for example, can compile and put together for them.
Absolutely. If you take our software, so we are a SaaS company as well, right?
Yep.
And if you take our software and you think about the way that patients are being treated in this whole heterogeneous population, when we collect healthy data from individuals of all different demographics and all different things, such as you were mentioning, different profiles of genetics and epidemiology and all of these things that might be incredibly important but might not be taken into account, then you can also start creating, and that's where I really see the future is going, AI diagnostic tools, because there's a lot of human error, as you were mentioning. And there's human error in the programming of AI as well, of course, but when we collect data from thousands and thousands of individuals, we can be somewhat certain with these data analytics and machine learning properties that we're actually understanding how far from the norm is a patient deviating, and then focus on treating those specific areas. So one patient may have a lot of problems with their visuospatial skills and aren't able to navigate around, to cook a meal even, or to dress themselves. And a lot of other people may have trouble with their memory, so they might not remember their appointments. But we don't know that unless we have these comprehensive AI models that are taking all that data, like I said, 10,000 data points a minute, and concatenating that to a place that we can compare it to the normative data of healthy individuals and hope to get them back to that healthy state too.
I think we're just about wrapping up on the time frame. So
Yes,
wondering if there's any questions from the.
Did we, might we have any questions?
Any questions from the audience?
I think the audience is shy.
Moderated from the chair.
We're just going to follow up on another session. I was asked to join this as a panelist because a couple of the folks couldn't make it here. But the next session, we're going to talk mainly about digital health, telehealth, and how that drives the value-based care and the primary care section. So actually, that'll be a very good, nice segue into the next section. So I'll be moderating that. So
Thank you so much. It was wonderful being a part of this session and looking forward to your next session.
Thank you very much, guys.
Oh, there's a question, I believe. Please.
I wanted to ask you a question if any of you have had experience working with predictive models to sort of sharpen the knife, if you will.
Oh, yes, absolutely. We've tested some of those predictive models and as you mentioned, and they're quite helpful and accurate. And like I mentioned, it's clinical decision support. So it gathers all of the data and it gives you a model of, well, this scenario could happen, or this percentage of this scenario could then happen. And then the clinician then takes that information and makes the decision of which way they might want to go in terms of treatment, which treatment they want to choose. So in cancer treatment, for example, the predictive models are extremely helpful.
Yeah, in some of the predictive models, it's also helpful to incorporate social determinants data.
Yes.
Absolutely. And in the study that the Parkland Center Clinical Innovation did on readmission for congestive heart failure that was published, if you look at that study carefully, the biggest contributor to the outcome that they had in the social determinants media was very simple: number of address changes in the last year. We've tested that model in both preterm birth and asthma, and it also holds there, so it seems to cross multiple innovations. If you're dealing with Medicaid gaps in Medicaid enrollment, increases bad results by about 50%. And then the last one is looking in the managed care models about who picks a PCP and who doesn't. Yeah. If they are auto-assigned, they have much higher rates of adverse outcomes.
I would love
Thank
to.
you. Thank you. Hold on. Thank you so much for that. We are at time, so thank you guys so much for your time and your attention. And if you'd like to ask us any individual questions, please, we'll be around. Thank you.
Thank you so much. All right.
Now let's just stay on the stage.
All right, guys, thank you so much for all of that information. Uh-oh. He said, we're going to move right along into our next panel. Telemedicine has long been suggested as a cost-efficient way to provide medical care for people with limited access to health professionals. But the benefits may lie in the significant savings it brings thanks to low overhead costs. Let's dive deep into the evolution of telehealth and what's in store for the industry in our next panel discussion. This topic is the evolution of telehealth, moving beyond FaceTime with the doctor. To ensure that we make the most of this session, we have Timothy Washburn, CEO and founder of TSW Consulting and MLLC, as the session's moderator. Please join me in welcoming to the stage Timothy. Oh, okay, small change. Okay, Suba will be moderating it. We'll take it away then. Let me step down.
Oh, okay, thank you. Continuing on that same topic of how digital health drives healthcare outcomes, I think we're going to focus on this session. I would like to introduce the panel. Come on in. I wanted to, give me 1 second here. So I want to give a background about myself, which I gave in the previous session. My name is Sub. I am a healthcare technology evangelist, a futurist. For 30 years, I've been in technology field and healthcare technology, working for the top 5 insurance companies in the US, Cigna, Anthem, and others. And my passion is my heart is technology, my mind is business, and my soul is food. That's the best way I describe myself. So with that, I am going to bring on the table. We already have here Tim joined our panel. Alan, please join the panel. And I will have them introduce their background and their company as they come on in. And finally, here we have Anthony. Come on in the stage. Thank you. And I think we want to give a little focus on what this session is about. So we're going to focus on how telehealth has evolved in the last 100 years, or 200 years, as you would call it. Telephones didn't exist before. How that is actually driving the change in the primary care and the value-based care world. And with that said, I think it's good to kind of like get a stage of what this telehealth how telehealth drives the primary care change and value-based care change to the end. In the first and foremost, I want to have each one of the candidates introduce themselves, please.
Hi, my name is Tim Washburn. I'm a registered nurse. I am actually an active registered nurse. I've been in the field for 30 years. I also own my own company.
I think a mic.
My mic not on? Oh, there we go. He said he'd turn on, so I'll try that again. My name's Tim Washburn. I'm a registered nurse, currently doing case management, been in nursing for 30 years, done a lot of different things, run clinics, started my own business for network consulting, health technology management, and partner with another group that's really focused on value-based management, and I really appreciate being here, so thank you.
Thanks. My name's Alan Preston, and I've been in the healthcare arena for quite some time as well, over 30 plus years. I started off running HMOs, and then I also did a little stint running a physician practice, which we grew to a number of different markets. We ended up being one of the larger ones in San Antonio, Texas. And then from there, I ended up doing my own company where we did clinical drug trials all over the United States. And now I'm back in the managed care side, running an accountable care organization in Houston. We manage about 100,000 members. And just by way of academic background, I'm an epidemiologist and biostatistician, doctor of science from Tulane University, which our moderator also went to, so FYI.
Nice. Well, thanks for having me, Sidhu. I appreciate it. It's wonderful to be a part of here. I guess I'm the odd man out. I'm not on the healthcare side. I mean, since we started DECO about 6 years, that's my kind of first foray into healthcare. Prior to that, I've purely been in technology. My graduate degrees in computational learning theory, which is like a kind of discrete subset of artificial intelligence, and had the opportunity to partner in order to build this organization that basically DECO brings technology together with physical medicine on site. So really looking forward to this panel.
Wonderful. Maybe about your company, you want to mention about your company as well, what you guys do?
Sure, yeah. I mean, DECO, we're a little bit about 6.5 years old. We're probably the nation's largest fully mobile medical provider. What does that mean? That means that we bring healthcare to people where they need it, when they need it. So all the healthcare that happens outside of a fixed four walls of a traditional healthcare institution, that's what we do. That's what we really do, whether it's in the home or a homeless shelter, whether it's at your employer's office or it's in the back of one of our mobile urgent and primary care clinics. We bring care where it's most accessible at an affordable price for everybody at all socioeconomic statuses. It's really where we focus. We went public on the NASDAQ about a year ago. We just had about our 1-year anniversary there. We've got about, a little less than 5,000 employees, and we operate in about 27 states, the US, Canada, and the UK.
Great. I think we want to just set the stage about telehealth. I think every one of us know what telehealth is. I think the recent 3 years, we've already also experienced. While the telehealth is a term evolved around the 1970s with the telephonic world, American Telemedicine Association was formed. The key was that using telephones to help prisoners. Dr. Jay Sanders is the founder of American Telemedicine Association. I think he put the context very nicely. What is telehealth? I mean, people keep asking, okay, if I see the doctor over my phone, is that telehealth, right? So on the context of it, the best way to describe the telehealth, why that is going to change the primary care is this. Dr. Jay Sanders puts it, typically in the olden days, in the 1800s, right, doctors, each family had a family doctor. They knew everything about the family. They came home. They gave a house visit. There was a house call doctor. I think in the 30s, the healthcare organizations evolved where private, public, and national health insurance came about. That the care was always when you go to the doctor. Technology was the best in the doctor's office. Technology was there in the hospital. So everybody went to the doctor's office, they went to the hospital because that's where the best technology was. As the 30-year evolution of emerging technologies, like the technology at a consumer end or a patient end, today is much more sophisticated or equal as the one you can get in the hospital. So the idea behind this is that when you want to measure a patient's vital signs, we go to the doctor. Good example he gives is the blood pressure, right? So we go to the doctor's office and where anxiety comes in, you're stressed out, doctor measures you and your blood pressure is high and they start treating you. Typically when you're at home, you're perfectly fine. Another example is a kid who has an asthma condition. They go to the doctor's office, they test the pulmonary function, the doctor's office. That's not where the kid lives. The kid lives at home. So the whole idea of the telehealth, what it does is that it brings in the patients where they are, brings them in the environment where they are, and that doctors and physicians are able to examine them and consult with them in the environment where they live. So I think that's a good context to understand that, right? So with that, I want to kind of get into the meat of the topic. Why suddenly so much of adaptation of telehealth has come in? The last 30 years had major impact. Evolution of technology, and then healthcare reform, and then the pandemic. I could call these a trifecta. The trifecta has really forced us to come to this kind of stage where we are at. So pandemic and telehealth adaptation has brought us to where we are today. Now we go back to, as an ecosystem, I mentioned in the previous session, if you were sitting in here, a patient says, doctor in my pocket, nurse in my purse, therapist in my jacket, pharmacist in my fingertips, and the clinic in my GPS. Now, that brings in the comprehensive aspect of the telehealth. Now, first question I want to present to you three are, how have you seen the telehealth impact the urgent care and hospitalization?
Well, I lost my speaker again. I don't know, maybe I'm sitting on it. We'll try this, I'll lean forward. So I think the first thing we have to recognize is the culture has changed. So the pandemic forced something that was already started. How many here want to go to the doctor's office sitting next to the 5 other sick people and wait for 2 hours? Anybody? You're sure that's included? That's included, and if you want it. So I think the culture has changed. I think the pandemic has really forced an understanding that doing the right care at the right place has to be understood through the cultural context of what people actually want. People don't engage in healthcare just because they're sick, although that happens too much. You as an HMO director, you deal with that all the time. How do you engage folks in a way that is actually interesting and relevant? You're not going to do that in the traditional ways alone. Telehealth, I just saw a survey come out and they said doctors are saying they're going to cut back on telehealth, and it was a big surprise. We think that's because they don't understand telehealth. This is a really good topic. Telehealth is about adding value from the patient's perspective. Urgent cares, people go there because they can go in and get seen. At the end of the day, urgent cares we work with now have scheduled slots because they recognize that's what people want. So I think telehealth, urgent care, even emergent care, this is a patient choice. I think payers, healthcare providers, we kind of have to catch up because they're going to vote with their feet, and they already do. So that's the biggest change I've seen, the biggest impact I've seen in those settings.
Yeah, and I think it's a question oftentimes, is it a complementary benefit or a substitutive benefit?
Mm-hmm.
And it's emergent. So right now I think it is what I would consider to be more complementary in that it does a couple things. One is it allows the patient, if you will, for sort of lower level types of episodic kind of care to be managed in many cases more effectively than having to wait a week or 2 or a month in order to get a slot at the doctor to be seen for something that could be managed rather simple and quickly. I think the challenge, and I think one of the ways that the industry is sort of trying to manage the challenge is, if you're in the provider community, of course, the question always is, well, how do I get reimbursed for a telehealth medicine consult versus a in-house medicine consult? And so value-based care is one of those components where physicians oftentimes now, particularly in the primary care setting, are able to achieve more dollars on the back end to the extent they do the right thing. Now, what do I mean by the right thing? They achieve certain results, and some of those results are measured by what we call HEDIS indicators in the value-based care, such as high blood pressure, some of the things that you were talking about, type 2 diabetes. So a lot of these things can be monitored at home and can be effectively managed in a telehealth setting, which helps, one, the patient achieve a good result and frees up the doctor's time to be able to do the more complex care management inside their office. So I think that that's one of the things that's happening, is that you have to give the providers an economic incentive to want to move toward this continuum where it makes sense for them as well.
Yeah, I'd go a step further and maybe challenge the notion that telehealth 2.0 by itself, the telehealth by itself is as disruptive maybe as people tend to believe. I think that it comes up short, and that's why a lot of doctors are trying to draw back on it, because so often when you have a telehealth consult, it ends up resulting in a physical visit anyways, right? You need labs, you need prescription, you need additional diagnostics. And so as the result of that, you just ask yourself, well, why didn't I just go in anyways? Why even have the telehealth visit? One of the key things that we focus on, and what I think is going to be a big differentiator, is the combination of the two, the ability to bring in a lower level provider on site without having to steal the time of that PCP or that subspecialist or the ER doc, without having to steal their time to physically go on site, but having them the ability to telehealth in, but with somebody physically present that can be the arms, the ears, the eyes of that clinician. I think that when you bring the two together, you have a truly disruptive and differentiating healthcare model, which not only creates more accessibility, but will improve better patient outcomes. But the fact that telehealth by itself is going to really dramatically improve the way that we work in our healthcare society, I think is a bit overstated.
I think it's a great point. One of the key point is this: telehealth enables physicians to be able to do affordability and accessibility of the patients, vice versa, right? It allows them remote patients. Some people have to travel 200 miles to see the specialist doctor, right? And some people have to travel 50 miles just to get a primary care. So I think that drives and it changes, it helps them to have that accessibility and the affordability of that, of the healthcare experts. Adding to that though, the first point I mentioned was that in the past, there was no data for the doctors. As you said, you have to go back to the doctor's office to get the vital signs anyway. So as I sit in here, I'm telling you, the watch and the patch I'm wearing is measuring more vital signs than what ICU could provide. Literally, the physicians today, as the technology drives this world, can actually get the vital sign. Now with the, everyone is familiar with the Uber Eats, what the pandemic did to food industry, right? So now literally buying food at home is just common thing, right? Similarly, technology enables that. So very valid point. Today, as we see it, that is where it is. But I think the future, as we merge the digital health tools in the 5P world, I think that's going to change the concept. So I'm going to go to the next question I had in there. So do you guys see that the private and public health insurers, payers who adopted paying for telemedicine visits, is it going to stay? Is it going to move? Is it going to change?
Well, I think can you turn it on again? You guys hear me? Swear to God, I'm not sitting on it intentionally.
Yeah.
I'm really not nervous. This is so you can hear me. So, I hope it doesn't change, but let's be honest. What do we know about healthcare? It changes. It's going to change. To me, we talk about telehealth or brick and mortar health. We talk about public or private. Really, there's a fundamental thing we have to start with. Access, as a patient wants to access healthcare. And by the way, that is not very often how the doctor thinks healthcare should be accessed, or a payer. Turns out we're all different. There's roughly 300 million different opinions. And if you don't believe that, just look at the two-party system. I'm kidding, I'm not going to get into politics. But the other piece is engagement. So even if I have access in a way that I think makes sense, it can take one little kind of bad experience to turn me off from telehealth. I had a bad experience with a nurse on the phone. I'm never doing that again. I waited in my doctor's office for 2 hours. I'm never doing that again. So access and engagement will drive utilization. That absolutely will drive, in the age of consumerism. Everybody in this room votes with their feet on everything in their life. The phone I use, the food I eat, the hotel I stay at, the plane I get on, shoes I wear, and here's the new one: where, when, and how I get healthcare. Because it turns out, if I have resources, I have choices, and if I don't have resources, I still have choices. I think that's going to drive that decision and that change more than anything.
Great. Going to the...
I just wanted to add to that, because you talked about third-party payers. And what I would say is that one of the challenges, we talk about telehealth as if it's monolithic, like there's one company. There are a lot of different companies out there that provide telehealth services, like Teladoc is a good example. United Healthcare has been trying to make a quasi-bid to purchase Teladoc as an example. So that's one platform. There are thousands of different platforms. So one of the challenges when we hear the word telehealth, we think of it as, oh, okay, it's just a patient calling a doctor and they're just consulting back and forth. Not the case. It's far more sophisticated than that. And so one of the challenges is that some third-party payers may use, let's go with Teladoc. But the doctor may not be participating with that particular platform, or the consumer may not want to interact with that particular platform. And so, because it's not necessarily their doctor, yes, they're getting some consult with some party that is in the medical related field, but they don't know that. And oftentimes, on the telemedicine side, on the teledocs, they may not have access to the physician's EHR that had the 15 visits that occurred prior to that one consult. So there are some challenges that have to be sort of addressed and have to be worked through. And it's not a panacea by any stretch of the imagination, but it is indeed a good step. And you talked about, like, rural health is a great example. Sometimes some people are just so far away that telehealth can make a huge difference for a patient getting needed drugs, as an example. It may take them quite a long time to get to a physician or get the appointment made. Sometimes it's a 30-day wait for some physicians and specialists and what have you. So it is important, but it's challenging.
On that note, though, it's critical to understand from a payer perspective the reimbursement. So I don't think there's going to be any change in regards to whether or not it's included. Telehealth will always be included as a benefit for all plans, purely because of the return on investment is always so high given the cost is so low. But today, because we're operating under an emergency order, you're getting full reimbursement for a telehealth visit. When that emergency order changes and you're no longer getting full reimbursement for a telehealth visit, the game is going to change quite significantly. If you as a doc no longer can get $90, but you're going to get $25 for your telehealth visit, how many docs are going to be doing telehealth visit, and how many of them are going to be good?
Right.
Very true. The other question is, there's a lot of discussion about not enough space in the hospital, and we've seen that in the pandemic. How do you see the telehealth impacts that type of challenge which may come across in the future?
Well, I mean, it's fairly straightforward. If I don't need to go to the hospital, I'm guessing most folks here, unless you work at the hospital, nothing against hospitals, worked in a lot of them, don't go to a hospital to visit unless, well, you have to. I think what you're going to see is telehealth and the ability to have different levels of care being delivered remotely by different levels of providers. The behavioral health panel earlier talked about having resources that weren't full-blown psychiatrists but could add value and become sort of that initial or secondary step before you get there. Telehealth is going to be the same thing. It already is. It already is. Really, telehealth is to hospitals like urgent cares are to hospital. What's the difference? Well, in an urgent care, I can walk in, I'm going to have a very high copay. May or may not get great care, but that's true of any situation. But I can do the telehealth from my own home. So I think it's going to be that preliminary step, and I think the companies that will really distinguish themselves will go beyond the concept of, I do episodic telecare, I do an episodic visit, to really come alongside practices and clinics and be that physician or clinic extender, especially in the value-based space, where there is absolutely reimbursement for specific types of services that frankly doctors often don't do, not because they don't see the value, they don't have time. At the end of the day, we work with a hospital in Florida. We looked at their primary care visits over a year. When we looked at the documentation, 64% of the time, there really wasn't a great justification for that visit. But in other ways, 64% of the time, the patient could have accessed telehealth. And here's the kicker. What we hear from the docs is, I don't have time to see one more patient. Well, what if we did that lower level of care outside of the office to allow time for the more complex care? Hospitals are just another example of that situation, in my mind.
Yeah, and I think when we talk about telehealth, again, we have this sort of myopic view of it. And really, I think what we're really talking about, if you broaden the view, it's almost like this object here. Believe it or not, you can actually call somebody on this. I kid you not. It's an odd thing. You may only do it 1% of the time, but you can actually call someone on this box. And I think telehealth is going to be a little bit like that. If you think about the Da Vinci as an example, where you can do robotic surgery, there are people that could do robotic surgery if there's a Da Vinci, say, in a small little community. Let's say I live in Texas, and someone is in Houston performing the surgery, and the patient is 300 miles away. So, is that telehealth? Well, that is actually applying the technology of remote sort of health, and that's what telehealth is. It is remote health, and so some of the wearables that you talked about, the Da Vinci doing robotic surgery remotely, the telehealth is going to be that is a sort of umbrage word, if you will, that's going to cover quite a variety of things. I mean, nowadays you had talked about actually when it came out in the 70s, we actually dialed a phone. Heaven forbid. I don't think people nowadays, I saw a meme where kids were trying to figure out how to do a rotary dial. They couldn't figure it out. So it's evolving, and it will evolve. But again, the question is it substitutive or complementary? I think it's in the complementary stage.
Yeah. I mean, for sure in the complementary stage. I mean, looking at it as an extension, I do think that on some of the points there in regards to, why is it that we are so episodic? Why are we so treat and release? But why don't we look at patients in a continuum of their life cycle? And sure, what you mentioned earlier about not having a doctor who goes into the home that knows the family, that takes a holistic view of care is one component of it. But the evolution of why that changed is purely because the ratio of doctor to patient is so now out of whack. And so even if you do come up with an incredible amount of technology and even change the incentive structure on a value-based care perspective such that people are not being paid episodically, but they're being paid in outcome-driven approaches, even then, I still think that you have a just mathematical disparity between the ratio of higher-level independent licensed clinicians and patients. The average PCPs at, let's say, 3,000 to 4,000 patients that they're saying. Well, how much time can you spend? You have 3,000 to 4,000 patients that you're managing. That's incredible. Now, if you had the ability to delegate that to somebody, say a lower level provider, and that lower level provider was in the house and had the relationship with the patient, and they were simply only escalating to the doctor in the event that it warranted that higher level clinician, that I think is a model by which the math of the ratio of the number of people to the number of clinicians starts to make sense.
Very valid point, because I don't know how many of you, we have about 800,000 physicians practicing with the NPIs today. I would say about 1 million if you want. There's 200,000 folks who are retired. But if you think about it, 1 million doctors for about 200 million US, 250 million population, including families and children, the ratio is coming down. So that your point is very, very valid. With that said, if you think about what telehealth can do, is that data, Alan mentioned, is the physicians now have a historical view of the patient. So the amount of time it might take for them to say, before they even see a telehealth visit patient, they can have a historical view of the data and actually quickly help the patient when they have a telehealth visit, right? So I think the point I was trying to make there is that the ratio you mentioned from a patient to doctor, I think that is going to stay. I don't think that magically we're going to have 50 million doctors, right, in the next 4 or 5 years. So I think technology enables this various levels of triaging, as you mentioned, so that the escalated piece goes to the doctor. So there is a early warning sign, right, with all the vitals. Early warning sign goes over 3, then a triage nurse can actually work with the patient remotely and stage that situation and hand it out to the patient. So that helps. In geriatric care, that's really bad because we have about, if I'm not mistaken, about 2,000 to 5,000 providers. I mean, that's the rough number of geriatric care. But our geriatric population since 2011 has been increasing 10,000 people a day. I mean, 10,000 people are retiring every single day since 2010, the baby boomers. So our population is being shifted to the right as well, where these folks are at home, elderly folks. And so the point I was trying to drive back is triaging. Technology helps to triage these things, and then the resources are able to manage the same number of people, right? So how does remote patient monitoring change the telehealth equation? That's the next question.
Well, when you're blind and cold and in the dark, meaning you don't know what's happening, pretty simple outcome, right? All bad. I think RPM and similar technology helps provide that extra set of eyes. What I will say is I am a skeptical technologist. I'm a nurse, I'm a practicing nurse. I know there's doctors in this room who are a bit skeptical sometimes too. I think the balance between leveraging technology, not to create data overload. I'm sure every doctor here would like to know every normal blood pressure reading on every one of their patients every day, right? That'd be exciting. Of course it wouldn't be exciting. So I think there's a difference between understanding data for the sake of insight and having data for the sake of checking a box. So, I think RPM will add data if it's well done and you're tracking everything somewhere, right, for audit reasons, right, but for care reasons, only surfacing what needs to be, and being able to tailor that based on the patient and their profile. Turns out, again, not all patients are different. Everybody on this panel is different, so are all you. That's going to be the key to making RPM good as it is now, but really great when you combine it with the ability to create the insight and leverage the right resource to manage based on where that patient is through intelligent AI programs.
Yeah, and I think that it's a lot of this, of course, is how do you apply? What's the application? Because as you say, if you just inundate doctors with a bunch of more data points, forget about it. That's just not going to work. But if you give them the data points when it hits a critical value, and they can act on the critical values, and the patient also can act on the critical values. So that way, it's not so wholeheartedly dependent upon one and not the other, because they both have to be interacting with the remote patient monitoring, whatever it might be. And so the idea behind it, obviously, is that let's say it's a blood sugar level or something like nowadays. You can go. Medtronic has, even for type 2 diabetics, a glucose insulin pump that helps manage the type 2 diabetics so that their hemoglobin A1C ends up being below 7 and manages that quite well. But again, I think that the key is that we have to make sure that somewhere in this mix, that if it hits a critical value, that the patient needs to be aware what that means, and number two, what's the actionable item that they need to do in order to manage their own health care. We sometimes think like they're somehow out of the picture when it comes to managing healthcare. They just go to the doctor manages it, and they go back home. No, they have to be highly engaged themselves. And I think the fear for providers is they don't mind getting data, but they don't want to just be inundated with data unless there is some critical component upon which they can act on. But then what happens if it happens at 3 o'clock at night? What do they do then? So there are some tricky little areas that they have to kind of navigate through in order to figure that out, so that they don't become held liable by the attorney saying, hey, you should have been up at 3 o'clock in the morning, and then managing that patient's critical value thing that pinged, oh, by the way, it was a false positive. Oh, well, too bad, too sad. You know, so there's a lot of those kind of things that have to be worked through.
Yeah, I mean, really, really good points. The reality is that RPM by itself is of very little value, right? RPM needs to be paired with management, right? Usually chronic care management, you know, CCM, PCM, and now that's happening because Medicare introduced reimbursement for these, you know, these codes about 2 years ago, a little under 2 years ago. There's now reimbursement for those. So you're seeing a large investment going into this area. And I can just tell you how at DocGo we do it right now. You know, it is we're installing the device with the patient, with one of our clinicians in their, let's say, home or senior living center, maybe even homeless shelter, and we're installing these devices with them. And just for everybody who's maybe not super initiated into the RPM space, you know, majority of RPM is usually, you know, blood pressure, glucose, weight, pulse oximetry. You know, that's usually what it all boils down to. And that data comes to our clinicians in real time, 24/7, always monitoring it. And you're kind of looking at it from the perspective, okay, we have like primary preventative care where maybe you're doing something like titrating meds. And then you have it from the perspective of like urgent care, we're trying to look, is there some sort of decompensation where we need to send one of our nurses immediately on scene, one of our critical care nurses on scene to do a treat on scene, or potentially, you know, DocGo also runs a transport company, so we will transport them in one of our ambulances. But when you pair the two together, the RPM with the management, with that chronic care management, you can then start to really make a big change. I'll give you a perfect example. Let's take a patient with chronic kidney disease, or even worse, like, you know, stage 4, stage 5 chronic kidney disease, and stage renal disease. They have the likelihood of going to the emergency room twice a year, every single year. Well, they're dialyzed almost every other day, right? That's usually how dialysis works. On the days when they're not being dialyzed, they have a very high likelihood of decompensating. And so when we monitor them for weight, glucose, because nearly all patients with chronic kidney disease are diabetic, and their blood pressure, we can determine whether or not they're having fluid retention. Fluid retention is the key indicator that they're going to have acute kidney failure, and that's the majority of the reason why they get entered into the emergency room. And so by monitoring them, we can know right away, like, hey, we need to send somebody on site right away. We need to do some sort of emergency dialysis, emergency home dialysis, or we just simply call them and say, you cannot have 1 ounce of fluid for the rest of the day. The whole rest of the day, you can't drink 1 ounce of fluid, because if you do, the likelihood of you going into acute kidney failure is so high. That has very meaningful, measurable impact in reducing the rates of hospital readmissions for that kidney disease population.
Yeah, I think that actually adds more value on the type of care we talked about, right? My paper visit, so doctors, PPVR, paper visit. Whenever you are sick, you're a patient, you cough, you go to the doctor. You get your insurance to pay for it, verify, doctor prescribe medication, you go. The case you're mentioning is that they are at home in their livelihood, remotely being monitored for their vital signs, and one of those things trigger, and then the alert is given to the patient saying that, you know, this is a behavioral change for you, right? So to help them, you know, to put it mildly, we are the CEO of our own data, our own health. So by giving the data to the patient, it really helps to have them change the behavioral change.
But it does go to the point of technology. This is probably the area where technology is the most important, because there is so much data. There's such an incredible amount of data that's coming in that if you don't properly leverage AI in order to filter out the signal from the noise, then all of a sudden you're inundated and you become numb. You know, and obviously no provider, no you know, PCP, no subspecialist is going to want all of that data put into their EHR. So the ability for AI to really determine what is the baseline and what is an elevation above that baseline, that's one of the rare, very concrete material use cases of AI that can have immediate benefits.
Yeah, I think that brings down to a very good point. I'm looking at the time as well. What's the next big step in telehealth innovation? I think we all see the technology evolving. We're consumers consuming things every day. I mean, who would have thought, like, you know, 7 years ago, if somebody told you you could watch 2 million movies wherever you are in high definition quality, you wouldn't have believed that, right? The technology is driving that change. So what are your thoughts on the next step in the telehealth innovation? Which area? What?
Well, I think it's going to continue down the path it is. I think the next really big thing is going to be that A, we're more consistent with the use of telehealth. We'll probably have some standardization around protocols. And I think the really big evolution is going to be around how do we have those different level of staffing, licensed, non-licensed health coaches, those resources. How do we develop the right model so that we have an efficient and effective way of meeting care needs, but making sure that we have the care needs met. So having enough bodies, but having the right bodies based on the needs of the patients. To me, the next big step is going to be more advancements and more clarification around those things and how those non-doctors, or maybe non-mid-levels, nurses, social workers, clinical pharmacists, how do those folks participate in telehealth to do what you mentioned, which is, can I have somebody be the first catcher of this, who then escalates as needed, and can we make that a protocol? One other thing I'll say is, doctors love appropriately managing their patients the way they feel they need to be managed, which means every doctor is going to have their own protocol to some extent, which is perfectly appropriate. You're the doctor. The buck does stop with you. So I think managing that protocol development, managing those resources, and then really getting doctors comfortable where they don't look at telehealth as taking over, but like you said, this is just something I add so that I don't have 64% of my patients show up and I didn't add any value, and then I don't have time for the complex patients. That's where I see the next big innovation.
Yeah, and I think there are probably two broad areas. One is the chronic episodic care, where you had mentioned it was a great example of how the technology can enhance the patient's compliance, if you will, in terms of managing that disease state. And they can do it in such a way that, if you will, doesn't tap the resources of that local physician, but taps another resource that can actually provide them the even quicker, faster, better type of compliant pathway, if you will. And then the other, of course, is you always got to follow the money. And what do I mean by that? As CMS decides how they're going to reimburse for X, Y, and Z, follow the money. So value-based care, whether we like it, don't like it, really doesn't matter. CMS decides that the fee-for-service type of mechanism as a sole payment mechanism is going to sort of sunset over time, and that it'll be sort of supplemented with value-based care. Then the other part of telemedicine will be, well, how do the doctors get paid for outcomes, not just for the process? And it's the outcome part where telemedicine, I think, will end up playing a larger role because, you know, to your point, if there are 1 million physicians and we need 1.3 million primary care physicians, that's going to be a problem in trying to satisfy that demand. So I think this is where telemedicine can help the patients and looking at and monitoring and reaching out and engaging the patient to make sure that all those HEDIS measures, if you will, that are required under the value-based care system get addressed and measured and what have you. And so I think that's what we're going to see the other application continue to evolve.
It's a good statement you made, follow the money. I think that's, generally speaking, when you want to look at where the future is going to go, you have to follow the money, right? And the money right now is moving towards more capitation, is moving towards more at risk, is moving to value-based care or some form thereof. You know, when we've looked at the programs that we have, when we're able to do interventions, on-site interventions, whether that's a telehealth intervention, that's a physical on-site intervention, the rates of reduction in your escalations of care, hospitalizations, ER admissions is significant. You know, we have one that we've done with multiple hospitals in Los Angeles where we're able to reduce the rates of readmission by over 60% just by being able to do this treat on scene approach. It's what's called kind of transitional care, transitions of care. And so if we know for sure with high confidence that the ability to intervene immediately at the time of an escalation will dramatically reduce the cost of care, then we know that that's the future. That's simply the cost. That is the future. Now, it's a question of how do you get to the point where you have enough data and you have a logistics backbone that you can intervene. So now it really becomes down to the question of how do I get the data? Well, that's, you know, a combination of diagnostics. That is, for certain types of patients, they're being monitored in real time. They're being monitored on a regular basis. That's people who have the ability to report and self-report. Like as an example, when we do our PM and we are monitoring patients, we are also surveying them. So it's not just as simple as, oh, well, I was able to get your vitals and I see that you have an escalation in your vitals. I then send a survey that says, oh, well, what did you eat today? How many bowel movements did you have today? You know, have you walked today? Have you been outside? How much water have you intaken? And so when you combine that together, you know that you have the ability to dramatically reduce care. So the future really is going to be that intersection between taking a virtual approach with sufficient amount of awareness of the patient now, diagnostic information, interactions with the patient, and then baking that on top of a foundation where you can do an immediate intervention to prevent the escalation of care. And that's an extraordinarily powerful thing to think about, because if so much of healthcare is built around after the escalation has happened, and now all of a sudden healthcare moves to a point where the escalation is happening dramatically less, how does that shape the entire healthcare ecosystem? What does that do to hospitals? What does that do to providers and subspecialists? What does that do to hospitalist agencies? Massive amounts of the healthcare system that are built on the patient always getting sick.
Yeah, I think other emerging, behavioral changes in technology is going to drive adaptation of telehealth. This is my personal opinion, because I think if you think about it, labs, if you think about it, always we went to the lab for blood work, urine work, and other work. Imaging, we went to the labs. But with the advance of the technology, with the pandemic, showed how self-test could actually be deployed globally, right? So if you think about those kind of capabilities, so patients will have a capability to actually do the test at home and then have a telehealth visit, maybe be more meaningful. So the future, I think what I, to put it, the other underlying concept of digital health, as they mature and add more data and more value and insight about the patient's history, genetic, behavioral, social determinant of health, and all those things consolidate, I think having that value, physicians will be able to say, hey, I can see the person's data just as if he's here on my office, right? So that is what the believing in that emerging technology and the consolidation of the data, because as you mentioned, data could be scattered everywhere in the 5 Ps. So I think that the future is that as these things consolidate, the 5 Ps become 3 Ps, right? The patient, the payer, provider, pharma, and partners. As they get consolidated, it's happening already in the industry. So big companies are all merging in those 5 areas. As they merge, the data and the information will consolidate as well, and then follow the money. So where the cost is, I think that's where the value is. I think future of the telehealth market is we're just scratching the surface as we speak here. Right. So we want, in the interest of time, we want to open up some questions from the audience.
A couple people coming up here.
Oh, 2.
Keep on
Don't
going.
be shy.
Come on up.
Thank you. Can you hear me?
Yeah, we can hear you.
Yeah, my name is Dr. Lisa, and I'm just so happy to hear everything you guys have to share about value-based care and where we are heading when it comes to just the shortages in physicians. It's projected that by 2034 we'll be at 134,000 shortages in physicians. And all of you touched on something that it just really hit home really strongly. And I think that we are missing this great opportunity of using doctors that cannot get into residency. Right now, Arizona is requesting doctors that have taken step 1 and step 2 to work under physicians to be able to provide care to these rural areas. So I recently just started a program where I get these doctors and I train them in advanced value-based care services, 7 of them, and they're just going with computers that are audit ready, and they're helping physicians, and the difference is tremendous. I get calls saying, wow, we had this person doing an RPM, but your clinicians or the people that are working for your company, they just do extraordinarily well. So we have a knowledge base out there that we are ignoring. They do Uber. They're driving Uber. They're working in gas station because they don't even know that there's something like this. So I like what you guys are saying, and I hope that we start just keeping our eyes open and making use of these clinicians. Because as you said, the doctors cannot be there reading all of this data, blood pressure up. They are the middle people that can go in and help these doctors to be able to provide the cost-effective quality care we need in the healthcare now. Thank you.
Yeah, I mean, sorry.
I was
going to say ultimately, it's really quite simple. In the absence of capacity, we all fail, whether I'm a provider, whether I'm a patient, whether I'm whatever I am. Capacity is the biggest problem. This isn't about replacement. This is about intelligent assistance based on things that work, delivered in a way that makes sense. By the way, I live in a city of 102,000. I cannot find what I would define as a good doctor in my own city. I'm not rural, but I will tell you I live in a provider desert, even though I live in the city. So it's not just rural where we have this issue. It's everywhere.
Great. Another question?
Hello, Tony Giddles from Orlando, Florida. You all have incredible expertise. Your careers have brought you into the healthcare system. One of my question has to do with the families, the family caregivers, and how can we incorporate more education and training to family caregivers? I took care of my mother for 14 years, sat in a hospital hours on end with no training, no contact, no information, no resources when we left. My vision is to change the healthcare system and how we interact with family caregivers. Just any thoughts or any way I can be of service to what you are doing?
What I would say on that front is that, and we talked a little bit about it in one of the other sessions, is that the social determinants of health. Obviously, when someone is transitioning from a procedure or an operation back to the home, the support that they receive or don't makes a humongous difference in the outcomes. So anything that you can do to embrace the support of the family in nurturing that patient when they make those transitions is critically important. And then again, companies like what you do, I think, are also, in the absence of that, I think provide a tremendous opportunity for patients that just don't have that family support. So, there are ways to get the support that even go beyond just the family, if you will. But that is a very important aspect of good quality care.
Yeah, one more question.
Actually, I'm so sorry. We are out of time, guys.
Okay.
Yes, thank you so much. Please, round of applause for our panel.
Thank you.
Be sure to find them during our network cocktail hour today at 5:20. You can continue on with the questions. Now, changing the gears a bit, let's move forward with a fireside chat on the topic, the world of clinical trials, up for some big changes, ? In light of the pandemic, the importance of speeding up clinical trials became clear. Expect the adoption of hybrid and decentralized trial design to dominate in the coming years. By means of this session, the subject matter experts, Garrett Temple, founder and CEO of Novogene, Carly Applegate, founder, Evelyn Elaine, and Alexander Kuhn, CEO of OP2 Labs, will talk about the changing landscape of clinical research and trials. Let's give them a warm welcome to the stage. Come on up, guys.
They're coming.
Guys, while we're waiting for one more mic, friendly reminder to let your family, friends, and colleagues know that our final award session is coming up here and they can watch you from wherever they are via the worldwide crazy web. Just have them go to YouTube and type in the Health 2.0 conference. They can click on the live stream. Also, we want to be a part of all of your pictures, whatever you're posting, whether it's selfies in the bathroom, pictures in front of our Health 2.0 conference. We'd love for you to hashtag those. #health, the number 2, CONF. And with that, we will have our panel start, or our fireside chat start. Thank you very much.
All right. Well, first of all, I'd just like to say it's great to have this opportunity to talk to you about this subject, clinical trials. A little about myself. The reason I'm interested in talking about clinical trials is my company recently created a device that we are going to start doing clinical trials on. And how about yourselves? What's your relation to that area? What do you do, and how does that have to do with clinical trials?
My organization, Evelyn Elaine, we are entering into clinical trials. We're waiting on our thumbs up from the NIA. For me and my perspective, looking at the participation and advocacy of the entire family involved in the clinical trials, including the caregivers.
Yeah, so for us, we actually manufacture and distribute nutraceutical products internationally. So,
Interesting.
Yeah, so clinical trials are a very important part of product claims. So we do a lot of testing on products and clinical trials for different medical use.
Very interesting. Now, one thing that was mentioned regarding clinical trials and the current state of how it works is vaccines. I mean, obviously the COVID vaccine had to go through its own series of clinical trials to make sure it worked. But there's also more experimental emerging ones. Just a few I can think of off the top of my head. HIV vaccine, the so-called fentanyl vaccine that's being developed. What do you think is going to happen with these experimental vaccines? What do you think the clinical trials for them would look like?
Personally, I think, novel therapeutics like mRNA are really going to drive a whole different approach to clinical trials and prioritization of therapeutics for very specific use cases. Some of the things that we can kind of expect is really decentralization of clinical trials, the introduction of technology, which I think will really start with more machine learning. And I know a lot of what we talked about during this conference is AI, but there is a big difference between machine learning and AI.
Right,
Not one and the
right.
same. And I think what we're going to see is the improvement on the collection of data sets and the type of data we collect in clinical trials, because that data can then be integrated into machine learning to make predictive decisions and outcomes.
What do you think, Carly?
I think that we're going to see, at least for probably the next couple of years, increased scrutinization when things do come out at an increased speed. I think there was a lot of love lost in the clinical trial process over the last couple of years by just the general public, just with miscommunications through the FDA and the CDC. And so I think we're going to see a lot more scrutiny for the next couple of years. And then after that, I really do see it just kind of booming. I do agree that we're going to see a lot of clinical trials initiated more in the private sector. Just trying to be that next big thing. But I do think that we're gonna see a lot of skeptics for at least a couple more years, just because of what we've all been through, and the Facebook MDs and the talking heads and stuff like that. So I think at least the next 2 years is going to be a little rough.
Yeah, and while we're on the subject of experimental technologies, emerging technologies, and how it relates to clinical trials, there are things being worked on right now like cell culture farming and microfluidic systems where you can simulate organs on a microchip. What do you think that will mean for the future of clinical trials? I personally think that if this technology is further developed and further deployed, it could mean big changes. We could possibly see an end to animal testing for clinical trials, and we could see big changes also for the use of human test subjects in clinical trials as well. What do you think?
Yeah, I think it's a great example because there are other things that are being worked on too besides that. They've already proved the use case for 3D printing human organs, right? So we can actually emulate natural human tissue. So I think that's really gonna, and as the saying goes, mice lie. And the practical reality is that a lot of the testing on animals doesn't necessarily translate to human. And so we'll see things like, using actual human organs that are 3D printed, what you're talking about. And also with the advent of technology, things like augmented reality and VR, we can do clinical trials, clinical testing and trials on things like genome testing and genome sequencing, where we can actually be collaborating on a worldwide forum through the use of augmented reality and VR and actually perform that testing in front of a bunch of industry experts.
I'd really like to see that happen soon. That sounds like it will definitely change a lot. What about you, Carly? What do you think?
Well, I'm not an expert in cell technology or.
Neither am I. I just find it very interesting.
But one of the, for my scope, one of the biggest breakthroughs just happened in October with the FDA formally acknowledging caregivers as part of the clinical trial process. Eventually, whether it's 3D printing organs or AI or computer simulations, these clinical trials will have to hit a human being at some point.
Right.
In time.
Eventually, there is going to be the need for a human test subject in clinical trials.
Yeah. And I mean, we've talked about the clinicians, we've talked about AI, we've talked about telehealth, but actually acknowledging that there are human beings behind the clinical research subject that can help efficiency, can help with outcomes, even just making sure that somebody shows up to those tests and gets there safely is such a big deal. And so again, for the FDA to actually acknowledge the caregiver as something more than a chauffeur, I think is huge long-term too.
Yeah, I think that's actually a very interesting point that you bring up with the changes in policy the FDA has made to allow caregivers to partake in clinical trials. I think it's definitely going to change things a lot in terms of the human element of testing in these clinical trials. But can you elaborate a little more on that? Like how it makes you feel and what you think the implications will be going into the future?
Well, I mean, our non-professional caregivers, those wives and husbands and kids, that's our largest healthcare workforce that we have. They just don't happen to be paid, right? It's 53 million of them. And so even if there's, 1/10 that are participating in a clinical study at any stage, that's going to be, you're going to have fewer people drop out of the clinical trial process. You're going to have greater compliance, which means that the end product is going to be better. It's going to be more accurate. It's going to be more precise. You're going to have better documentation about side effects or any type of adverse reactions. You're just going to have better data because it's no longer going to be just patient dependent. It's not going to be just lab dependent, but there's going to be a perspective.
And what do you think, Alexander? How do you feel about the changes in FDA policy that opens up clinical trials for caregivers to be a part of?
Well, I always look at things from a business process perspective, and the practical reality is when you look at the clinical trials on new drug approvals this past year, we approved 20 new drugs, right? But you compare that to 2021 and 2020, where respectively we had 50 and 53 drug approvals. So, the problem is even with changes in regulations, it's really the speed and velocity at which we can actually approve drugs. And I think some of that's contingent upon the fact that we haven't really leveraged the ability of technology to automate certain things and or define standardized data sets for the type of data we want to collect on a clinical trial.
Right.
And other things that come into fact are much like you were talking about, some of the cell capabilities in cloning organs. Practical reality is if you're not able to achieve certain outcomes in your preclinical trials, then you're probably not going to go to a clinical trial.
Yeah.
So I think the reality is that really the speed is going to take a lot of different things: standardizing data, the use of technologies, decentralization, so that we can speed the process up, and also leverage expertise on an international basis versus trying to find a pool of individuals here just in one country.
Yeah.
Definitely a lot to think about.
Well, and to add to that too, the expansion of what qualifies as a clinical trial too.
Right,
I think is going to have, again, I'm optimistic myself, but, there's not just the biology, but now if a clinical trial or if a trial can affect psychosocial, mental health, it's going to fall under that clinical trial spectrum, which again, I think will help. I definitely think will help reduce the amount of snake oil that hits the products or hits the market sometimes. But I think that in combination will, again, be a huge game changer.
Yeah, I mean, it's everything. I think it's regulations do one thing, and really what it's just a regulation is really a standard set of guidelines that are really designed to be very generic, right? And the practical reality is we do a lot of clinical testing on our products, but if I want to achieve an outcome to test for one thing, that's very easy to do, but it doesn't necessarily mean it's a conclusive test. And so I think a lot of it's real, part of the problem is that regulations, need to really start considering communities and groups that help define standardization on how we perform clinical testing and the minimum data sets we need to collect to achieve a particular outcome.
Okay, so given what we've talked about so far with new and emerging technologies and technologies that already exist that are just waiting to be more widely adopted, we've talked about data set standardization, AI and machine learning, cell culture farming, growing organs in petri dishes, or even organs on chips through microfluidic systems. Do you see any of these things really being applied within the next few years? And if so, how quickly do you think it'll be adopted? Where do you think it's going to be used? How do you think it's going to really change things?
Goodness. I think that some of these things have to, they'll have to prove themselves before they can be a standard of practice.
Right.
I think for the cell fluidity and even the 3D printing, we know we can do it, but we don't know how necessarily that's going to work long term.
Right, there's still a lot that needs to be figured out.
Yeah, and I think that there's still going to be some efficacy that needs to be built behind some of these practices, and some of them are still theoretical before we see it actually hit the market. So, I mean, I'd venture to guess that we're going to work at the speed of the FDA, and it's going to be several years before we actually see practical applications, outside of, university-based research.
Yeah, I mean, I agree with that. It's going to take many years to actually develop that technology in a way that it's widely adopted. But even though COVID was one of these things that was very disruptive to our society, the great thing about COVID is that there were many medical facilities that weren't even really leveraging technology, and it really forced the adoption of technology. Mm-hmm. And by forcing the adoption of technology, we have now created an environment where people are willing to look at that technology. In terms of, are we using it now? Absolutely. I mean, I'm a big investor in technology companies, and one of the larger and growth sectors right now is healthcare. Everything from telemedicine to mostly machine learning, and there's some AI research going on out there. There are companies now that have leveraged augmented and virtual reality. And one company in particular, actually, that's what they do genome testing on, right? So they can actually, everybody around the world can get on a VR headset, but augmented reality is they can actually leverage a real world environment to actually do things like gene splicing or measurement between genomes. So, it's happening, but it's going to definitely take many years before we actually start to see that being used in a clinical setting.
I agree. I mean, the technology is there one form or another. If it's actually mature enough to put to use is a whole nother question, and that's really what we're going to be seeing going into the future, I think. But kind of related to that, do you think some of this experimental technology that could be used in clinical trials will maybe not completely do away with, but at least fix some of the problems of unintended consequences of new drugs, vaccines, therapy procedures, because you know how every drug they say there are side effects. Do you think it's possible to, if not remove the problems caused by potential side effects, at least mitigate them through new methods that could be used in clinical trials like the ones we discussed?
Oh, I mean, that would require you taking the human element out of it entirely. You know,
Which is a whole nother problem.
right, but you know, everything's on a bell curve. You know,
Right.
literally everything, and clinical trials are the same. And you want a good 90% right in the middle. But you'll always have those margins. You're always going to have somebody who doesn't react well. You're always going to have somebody with, some variant that reacts to either the medications or the haptens in the medications. I don't think that there's any potential omnipresent view to, be able to look and say, no one's going to have a reaction from this.
No, of course not. That's unrealistic to
I
think there's
think-
not going to be any kind of reactions.
Yeah.
I mean, everybody's different. Everybody's prone to some kind of side effect.
Yeah, I think, really leveraging data sets and being able to see, if there's certain commonalities or causations when they're looking at clinical trials. But again, unless you take the humans out of the medicine entirely, I don't think there's any way to really predict everything.
Yeah, I mean, I would agree with that. Unless you could really 3D print a human that represents like every genetic trait or marker out there, you're not going to be able to test for everything. But however, I mean, I think things like machine learning. So what is machine learning? It's technology and algorithms that identify patterns to make decisions. And then what it does is it learns through data and experience to improve itself.
Right.
And so as that relates to clinical trials, the better data sets we have, the more informed that machine learning is, that it can actually predict outcomes to some extent. And so I think, we do have to improve the type and quality of data that we are collecting to leverage that technology to inform us of potential complications with clinical trials and testing.
So assuming we are able to collect the right data and a large enough amount, what you're saying is we'd be able to make more accurate, better informed predictions about who may experience some adverse reaction to a drug or vaccine or whatever they may be given as part of a clinical trial. Is that correct?
Yeah, of course, because as a human, I mean, we're not thinking about all the other things that are out there, genetic traits, genetic markers, what part of the country you came from, what type of food you eat, what other types of drugs you're taking at the time during a clinical trial. But, that's where I think things like technology can improve the process through which we are testing things in a clinical trial, because it can take in large amounts of data and make predictive outcomes based on that data.
Right.
I also think that it can help in the precursor to the clinical trial as far as finding more appropriate and qualified candidates for whatever clinical trial, right? You can add in all of those data points from age, disease, genome, altitude, region, everything like that, and be able to be more precise when clinicians or researchers are looking for clinical subjects. I think that's going to be probably more applicable on the front end, at least until technology catches up with all of the data in the back end.
Yeah, and on that point, everything you brought up about data points that could be collected, geographic origin, age, ethnicity, nationality, pre-existing genetic conditions, you really start to get into the area of personalized medicine in addition to just the clinical trials and being able to predict outcomes and adverse reactions that could happen. Do you really see a sort of convergence point between the emerging areas of personalized medicine and where clinical trials could be headed based on what we've been talking about?
I mean, in theory, yes. In practical application, no. Just because that would require 100% compliance, right? And there's always somebody who could exercise a little bit more, drink a little bit more water, you know, eat a little
Right,
bit
we're
more
not all
healthy.
entirely the same.
Yeah, I mean, if you look at most of our disease processes that we have, at least here in the US, some of those take a lot of hard work and dedication to get and maintain. I mean, it's some of it is a lifestyle choice. And so, yeah, in theory it would be nice, but again, you know, there's still free will, there's still bad choices, there's still a myriad of things.
Right, people are still free agents, free actors who do what they want ultimately in the end.
Yeah, and I mean, somebody's health can't supersede their free will.
No.
So.
Yeah, and I don't think it's really at some point, do you have to improve the quality of those participating in a clinical trial? Not necessarily. And that's really a technology problem in my mind. I mean, you know, what we're starting to see things now are a pill that you can swallow that can do internal diagnostics on a patient, right? We have devices now that you can hook up to your finger that can do genome testing or blood sequencing, right? So to me, it's a technology issue. Have we gotten to the point where we can uniquely identify characteristic traits of an individual who's involved in that testing? No, because really most clinical trials are about structured data sets, right? I'm defining whatever my outcome is, but at the same time, a certain amount of data I'm collecting. But you know, the great thing about technology is I don't have to work with a structured data set. I could work with unstructured data sets.
Right.
I can incorporate IoT, LOT devices that are collecting biological metrics real time to give me all the data I need so that if I have a interaction from somebody on a clinical trial, it may be able to identify unique traits that are attributed to that individual.
Definitely. And really going on with that, since you know genetics does not equal personality, everybody's different. If we were to collect data on potential patients or people to be potentially involved in a clinical trial, what do you think that data collection would look like, and who would be the right sort of candidates to be part of that data set?
I mean, we already collect that data. Every billing claim goes with that data. I think, again, it would just, you know, with assistive technologies, it would actually help, you know, add some precision on locating the patients for clinical trials. You know, clinical trials are hard to access. If you don't know what you're looking for, you don't know what you don't know. And so it may actually
There are a lot of unknown unknowns, yes.
Well, I mean, again, we're talking about, you know, we're talking about people who aren't in this space. We're talking about families. We're talking about kids. We're talking about welders and teachers. So I think that, again, you know, having specific data points that could help researchers find that patient or those individuals, I think that will, again, help with the efficacy long run.
So it can solve the problem of sort of the known unknowns with the data and figuring out how that relates to the efficacy of trials and what can be done?
Not quite. It's more like it's you know, again, finding that right subject for that trial, you know, and making sure that that subject meets what the researchers are needing. And again, we already produce that data with every billing claim, because every claim goes out with CPTs and ICD-10s and, you know, everything. So, you know, using technology to access that data to pinpoint subjects, I think is going to be the most useful.
Okay, I got it.
Yeah, I mean, it's to your point about is the data collected? Absolutely, but I think to some extent too that data is very decentralized. So in a lot of cases, it's not accessible. And the question of whether or not we're collecting all the data necessary to make decisions on predetermined outcomes, I don't think so, right? Because you know, if you administer somebody a drug, you're looking for an adverse reaction, not any reaction. So if you could do things like incorporate biometric devices where now there's a fluctuation in blood pressure or an increase in body temperature that could be an indication of some type of reaction, that's stuff we don't collect in clinical trials, right? Because it's not, you know, it's typically some adverse reaction, somebody reports something, hey, I'm having this, but it's a noticeable thing that we see. But I think, the use of technology can greatly improve our ability to be able to identify reactions in certain types of individuals and be able to isolate, whether that there are certain genetic traits or markers or family history problems that led to that interaction.
I actually think we'll see a lot more remote patient monitoring in that space.
Absolutely.
To be able
I agree.
to be able to capture fluctuations, changes in condition.
Yep.
Again, being able to just identify things real time, I think will make a huge difference long term too.
Oh, absolutely. If you're able to monitor things in real time and record what happens as it happens, that's definitely going to change everything in terms of how the clinical trials are going to happen and what the aftermath is going to be, what it's going to look like once the trials conclude.
I think will help in the speed too.
Definitely.
You can take months and months of research and really condense it down if you're using real time, because you're getting all of that all the time. So I do think will help with I don't want to use speed, but the
you can get what's effectively the highlights.
Yeah, maybe a more effective clinical trial, because I always remind my patients, my clients, we don't want speed, we want accuracy.
Right.
And certainly that's the case with clinical trials, where you want the best accuracy, you want the best outcomes, not necessarily speed. And I think that's sometimes in contention with the commercialization, because people want to get that out as fast as possible, and I understand that, but you don't want to do it too fast.
Right, there's always a rush to bring something to market, but there's also problems if you rush too much. You go too fast, there's going to be issues. There's going to be things you didn't catch during the initial clinical trials that now, once your drug or vaccine is on the market and people are taking it, people are using it, they start having adverse reactions. And why didn't we see this before? Because it was rushed, right?
Well, and sometimes it's not even the adverse reactions. You don't get the opportunity to educate the community, prepare the community. And again, I think we saw this during COVID. And, however you feel about the vaccine and the clinical trials, from start to finish, the vaccine was a modern miracle. I mean,
absolutely.
The time it took, how quickly it was done, just the joint efforts and how many organizations came together to do it. It's a modern miracle, but there was not enough time to prepare the public. There was not enough time to prepare the practitioners to answer questions. There wasn't enough time to, let that sink in. And again, that's what happens. It's one of the disadvantages of doing something too quickly.
Right.
Because you can't educate the practitioners, you can't educate the clinicians, you can't, have thinking sessions like this, so you can be like, oh, what if they ask this question? What if they ask that? How are we going to answer it? And that's important. When people are asking for informed consent and their practitioner can't quite answer the question. And again, that's one of the downsides of doing something too quickly, because you just don't have time to prepare the people who are going to actually implement it.
Definitely.
Want to go to Q&A?
Yeah, we've got some time.
Yeah, why don't we go to Q&A now?
Any questions, the
audience?
Let's hear what the audience has to say.
Hi, thank you first. I really appreciate this. On the idea of potential wearable technology for collecting data, how far away do you think we are from having that? I mean, when you look at the research right now on wearable technology, there's pretty huge discrepancies between a smartwatch and the, whatever else, rings or whatnot. How long do you think it'll be before they're accurate enough that we can use that for individuals?
We already have the technology out there, but I think the struggle with the market is trying to find the particular use case. And I think that's where they're really struggling, because, a lot of these companies that are developing and very innovative out there, they're looking for funding. They're a company and they have to survive. And so they're trying to identify a particular market use case, which may not be the use case that everybody else is looking for. all these technologies exist, everything from micro robotics to nanotechnology to things that can do very advanced diagnostics on a human being, even do gene coding. I mean, it's pretty advanced, but the struggle is there's like a very decentralized approach. Everybody's trying to do one thing and nobody's looking at the, healthcare industry as a whole.
Also, there's been in geriatrics, we've had fall alarms for 20 years now, wearable fall alarms. But it's that centralization, and where does that information go? And so it's also, again, goes back to practicality. Does everybody need to wear a biometric device? Everybody's got a Fitbit, everybody's got a smartwatch, but do patients need that? And if they do, when? What's the setting? What's the appropriateness? There has to be kind of some parameters. Otherwise, you just have data going nowhere.
I mean, I think the struggle that you're seeing, and it was identified in earlier sessions, is that the problem is you have an organization that's developing emerging technology to solve a particular problem. They want to own the data. They don't want to sell it. So it's the Google, Facebook model. So, the problem is there's a lot of other companies developing technology, but nobody wants to share the data. They want to keep the data. And so I feel like, instead of working as a consortium or a group that's advising on one another how to improve healthcare as a whole, what we really have right now are a lot of different silos trying to solve different problems and trying to figure out how to make money off the data I'm collecting. So,
shifting gears a little bit. One of the dilemmas is minority participation. Tuskegee Airmen, the trials with Latinos in Nicaragua and abuse have created an understandable reluctance in minority participation. Yet, as we look to the future and some of the data you've talked about, we've got to overcome that bridge. I'd wondered what wisdom you all might have about that. And then the second question is one that I used to face all the time in my career in managed care, which is the question of managing to label versus managing to clinical evidence. Do you think any of the emerging technologies can help us there?
I guess I'll take the first question here. In terms of, absolutely, the diversity of those participating in clinical trials are absolutely important because that's where you're really identifying the effect of a drug on a particular population, whether that's a genetic marker, a trait, a region they live in. I don't know how to solve that problem, but I do think the decentralizing of clinical trials will help, and to some extent, making those things through the use of technology more accessible could facilitate more participation. But to be more specific here, I'm not really sure how we could solve the problem overnight.
I think that, once trust is lost, it's hard to really earn back. And I think seeing a more diversified healthcare workforce, research workforce, I think that will help. But it's one of those things that pharmaceuticals, research groups, universities, all of us just have to earn some trust back. And that's going to take time, and that's going to take genuine action and sincerity. That's about as much wisdom as I can give you. Is we just got to earn it back.
The only thing I can really say is, given the ability to collect data and work with data, yes, we can probably simulate what a clinical trial might look like on minority populations given data that's already been collected, but simulation's really no substitution for the actual thing, and I think that really will remain a problem as long as that trust isn't there, to echo what Carly said.
Yeah, and it's a great question you're asking, and I think part of the problem is maybe we just need to ask the question, why are these people not participating? Is it a distrust in pharmaceuticals? I don't know the answer, right? But I think it's about data, right? And the first thing we should probably do is ask those people themselves why they're unwilling to participate in clinical trials. And your second question, sorry?
Second question was the question whether you have any particular wisdom on the idea of managing to label versus managing to the clinical evidence. You know, as an example, a lot of the diabetes drugs which deal with type 2 diabetes are not indicated below the age of 18. I used to authorize them all the time because I couldn't find a reason not to authorize them.
I mean, I'm not a practitioner, so I think it's just, I think that that's going to be something that, you know, is going to be where the practitioners really need to push back a little bit. And I don't know, take your sovereignty back instead of just focusing on, you know, what the DEA says you cannot do. I think that's the challenge.
Yeah, I mean, I do think a lot of what you're saying and stating, I mean, obviously it's very true, is that it's a negative outcome of how we conduct clinical trials now. And the practical reality is we're trying to work at pace and velocity so that we can get that drug out into the market. And the clinical trials themselves are really ill-defined, right? We're not collecting the right evidence and data to say that we're developing something that can treat this and it's not treating here. We're just generalizing. So I'm a firm believer in things like technology, machine learning, and AI, because it's really about being able to collect vast amounts of data and make predictive outcomes so that we can do actual targeted, real prescription versus just generalizing and pushing something out there in the population.
Agreed.
Well, this is kind of a follow-up to the gentleman's question, dealing with having enough quality participants in terms of both racial and cultural diversity. And that's a huge challenge. And I was hoping to hear some creative measures here on incentives, approaches, because without that, the drug trials are going to be stifled. We won't be able to get full body participation among our population. And our segmented groups that are participating, it limits the effectiveness of that drug by drug trials. So I challenge you, come up with some creative means to stimulate, incentivize, or increase that level of participation among minorities and cultural groups.
Yeah, 100% agree.
When you run into
Absolutely.
Incentivization, though, you do run into some moral ambiguity, right? Like, you want people to participate, you want people from diverse backgrounds, but if there is, you know, especially monetary incentives, you can draw the wrong crowd, I guess, you know, or you can run into areas in which people, you know, like economically disadvantaged people are going to be tested on more. And that's scary. I mean, that's definitely not where I think any of us want to see the clinical trial process go. The incentivization needs to be something, I don't know, more defined with a long-term goal, like, you know, maybe your Medicare premiums are paid for the rest of your life or something like that, you know, versus what we naturally think of as incentivization, which is, you know, direct payment for services or energy.
Right, because if you're just writing them a check saying, hey, will you participate in this trial? We will pay you for this. That raises all kinds of questions of why are the people participating in the trial? Are they doing it because they genuinely think that they're going to help with developing some new treatment, getting it out there and making sure it works, or are they just in it for the money? And also it raises the problem of the people saying, we will compensate you for involvement in this trial. Why are they doing it?
Yeah, I mean, incentives are always a great way to do things, but you know, when you talk about incentives, you're really talking about a developed country, because are you going to be able to go to a tribe in Africa or Latin America, a small city, and provide an incentive there that's going to get them to participate? Or maybe you give them an incentive and then all of a sudden one of their folks in the town die, right? Then what happens is a distrust. I think it's a tough problem, but what you're really speaking to at the end of the day is the need to have diversity in clinical trials. And how do you do that, right? Incentives is a way, but I don't know if incentives would necessarily work in underdeveloped countries, right? Maybe they would, right?
I just like to follow up on the Dennis's questions. I mean, well, I'm here not to ask a question, but share an opinion. I mean, the incentivization, yeah, there's ethical quandaries to it, but that's the lesser of two evils, right? And I think, I guess what you're talking about is very important in terms of the clinical trials and diversity. I would challenge you to figure out how you can get the city and state to create positive incentives to get companies to collect data. And at the federal level, they can cause negative incentives because Congress controls NIH's budget. Right? The solution, I don't think it's going to come from scientists or biotechs. It comes from people who vote in politicians and vote them back in again.
Yeah. Thank you. Appreciate it. Yeah. Very true.
Yeah.
Any more questions?
All right, guys, round of applause for our experts here. Such a great thought-provoking chat. Thank you so much for that. We have one more panel discussion for you all, and then we'll go into our recognition session. And of course, we have another networking cocktail hour for you this afternoon, because why not? We're in Vegas, right? I got a couple smiles out of you. I saw you in the back. Okay, next up, we have a panel on the topic healthcare interoperability, barriers and solutions. Today's healthcare systems place a high priority on enhancing interoperability. Standardizing terminology and normalizing data to those standards are two fundamental issues in improving interoperability. Our next panel of experts will underline real barriers to healthcare and what can be done to overcome them. Join me as I welcome the moderator of the session, who will take this discussion at length and introduce us to our panelists. Please give a grand welcome to Stephen Lane, practicing family physician and clinical informaticist at Health Gorilla. Stephen? I see a hand raised. Oh, you're getting mic'd up. Okay, wonderful. Wonderful, wonderful. Well, in that case, I will use this time to remind everybody that Health 2.0 conference is going to Dubai, May 1st to the 3rd, 2023. We would love to see you there. We're looking for sponsors, exhibitors, delegates. If you just want to come say hi, hang out, right? It's Dubai. Please let us know. Come see me during the break or right after I get off stage, and I give you all that information and connect you to the right person. We are also coming back to Las Vegas next summer, July. We'll be at the Caesars Palace, so let us know. All right, take it away. Thank you.
But I'll speak up until the mic comes on, then I'll blow your eardrums out. My name is Dr. Stephen Lane. As she said, I'm a practicing doctor and a clinical informaticist, and I live and breathe in the world of interoperability, so it's a great honor to moderate a panel of folks who have a really interesting and diverse perspective, or set of perspectives, on the topic of health data sharing and interoperability. So why don't you all come on up, and we will start the process. Is the mic on yet? Over here or just over there? Still on? Good. Yeah. Oh, now I can hear it. Perfect. Excellent. All right. We got all the chairs?
Musical chairs.
Good deal. All right. So health data interoperability is, as I say, a very important topic, certainly in my world. Let me start by introducing myself a little bit to you, and then we'll jump in. As I said, I'm a practicing primary care physician for 35 years and been a clinical informaticist for over 25 years, and really focused in the data interoperability space for the past 15 years. I still practice medicine. I exchange data all the time on my patients, and have had the opportunity to work with pretty much all of the major forces shaping health data interoperability today. I have the pleasure of serving on the Office of the National Coordinator's Health IT Advisory Council for the past 5 years. I'm on the board of the Sequoia Project, which is an organization that's very much involved in supporting nationwide interoperability and serves as the recognized coordinating entity for the new nationwide trusted exchange framework that is being stood up in the coming year. I'm also the chair of the Care Quality Steering Committee. Care Quality is another entity, nationwide framework for supporting health data interoperability, and I've done a bunch of other stuff in the space as well. So what's interesting, I think, about this panel is we were not asked to celebrate the successes of interoperability, but talk about challenges, potential solutions. I want to point out to people, while it's sort of urban folklore and very popular to stand up and say, oh, health data doesn't move, you know, interoperability isn't happening. The truth is that tens of millions of interoperability transactions are occurring every single day across this country. We have numerous very successful nationwide networks that are moving health data interoperability, mostly between providers, but also there's a lot of access to data by individuals / patients, payers. There's various types of interoperability that are going on. The idea of this new trusted exchange framework and common agreement is to really provide a single on-ramp so that all these many types of interoperability can come together and be easier to access, more consistent, more secure, et cetera. So a lot is happening in interoperability, and there are a lot of challenges today. So we've got a wonderful group here on the panel who have, as I say, unique perspectives, and we're going to talk about some of the challenges and some potential solutions. So I'm going to let you each introduce yourself, just going down the line, and start with just an introduction. If you want to throw in one of your top challenges along the way, that would be wonderful.
All right, sounds good. Well, thank you, Stephen. I can kick us off. My name is Mahek Mohan, Senior Product Lead at Genentech. Oh, louder. All right, I'll start over. My name is Mahek Mohan, Senior Product Lead at Genentech for our data interoperability and AI initiatives. Some things that are interesting within the team that I lead and the projects we work on are thinking about interoperability in the sense of data flowing from our clinical trial sites and produced and ready for filing. So those are some of our external initiatives. And then internally, how we think about structuring our data. And I think in the last panel discussion right before us, that topic came up of structured data versus unstructured data, and how we really leverage insights internally with that information. So 2 different initiatives with different stakeholders that are very, very important for our team to kind of crack the nut on. I come from a molecular and cell biology background, working in various Nobel laureate labs on gene editing, and most recently now am the Roche Genentech representative on Transcelerate, which is the largest biopharma consortium. So to kick us off with a challenge that I see in interoperability, it really does surround how we think about the flow of clinical trial data from our clinical trial sites. So I'm taking the pharma perspective here of how do we enable that flow of data to come over faster, more effectively, and with fewer transcription errors. And what we're seeing on the clinical trial site side is a real variety in data standards and infrastructure, which can cause limitations in how we think about a solution that really pulls that data in for us. And so it's not a one-size-fits-all problem, but it really is how do we customize to meet our clinical trial sites where they're at. I'll pause there and pass it over to you.
My name, you guys hear me?
No, I don't think you're on.
Just keep talking, let it balance, okay. My name is Charles Hale, and I am the president and founder of Hale Consulting Solutions. We are a consulting firm that specializes in cybersecurity in the healthcare field. So we're coming at this from a technology point of view and how to secure data across the organizations and across the exchange of data between organizations. My organization works with the provider community. We also work with the payer community and with the government regulatory community. So that kind of gives us a little bit of a 360 perspective on this issue and the different kind of challenges that are being faced by organizations that have very different agendas within the healthcare space. As far as some of the things that the organization does, we're looking at compliance, of course, HIPAA compliance, high trust certification, things that you can show that we have made a reasonable effort in this space to be secure. But going beyond that, a checklist saying we're compliant doesn't mean that you are not vulnerable. So we're really looking at this from a risk perspective of what kind of risk does your organization have as it's exchanging data, both within the exchange with other organizations and within your own organization, so that you can really secure your data to the best of your ability and make sure that you are safe and that you are securing the private and personal information of your patients and members. Challenges. So one of the biggest challenges we see to interoperability, there are many, but coming from a cybersecurity perspective, is how do you do this in a secure space? And not only within your organization, everybody feels like the data is secure and does the best job they can to secure the information in their organization, but we see a lot of supply chain attacks. Well, it still happens all the time, but a lot more attacks are occurring on somebody we do business with. And they're getting our data because we give it to them so they can do call services, so they can do population health. And so we're really looking at how do we secure across a whole chain of trust here so that from point A to point Z, the data is secure and that patients and regulators and everybody have trust that the data can flow freely and securely. And I will pass it on to Tanwir.
Thank you, Thank you, Charles. I'm Tanwir Hassan. I'm the founder and CEO of ICON. It stands for All Inclusive Healthcare Omni Network. So we have been working with multiple healthcare facilities in New York for almost last 6-7 years. And from our experience, what I want to say about healthcare interoperability that rather than swamping the process, it's more important that if we look into the purpose, why we are doing it. So all the technical barriers, technical, cultural, organizational, then economical barriers of interoperability, I think what we personally focus that it's more important to understand why we are doing it. What is the purpose of this interoperability, and how can we help the physicians and also the patients? In terms of patients, it's very important that how we can enhance the patient engagement. And in this process, I think one of the biggest challenge when we are doing it, we are trying to help the doctors, providers to deliver the healthcare properly to the patients. At the same time, it's very important that one of the major intent to do this is to help the patients, whether this is helping the patients or not. So from that perspective, I think rather than swamped in the process, it's more important for us to focus on the purpose also. So that's what I would say.
Thank you. I'm Jeff Lucas. My career started a long time ago in IBM and ended up in a healthcare role in Texas. And it's back when the only thing we really could sell were mainframes. It was, paper charting, but I saw this big opportunity and then ended up in roles at Oracle, started their healthcare in the mid-90s, and then went over to a company called Science Application International, who many people do not know. They built the military's healthcare system, the most comprehensive, globally deployed clinical system on the planet in the 80s. And so when I got recruited to SAIC, it was to do the commercial healthcare. We had Kaiser, and at that time, Kaiser still have 12 regions, but they had 12 disparate data centers that they wanted to integrate into one clinical data set, and our company won that project. That's where I started seeing the challenge of data coming from disparate systems. That was the interoperable challenge, and I thought this data needs to also be delivered down the line through care coordination. And then over the years have had enough experiences to see and develop a vision around how interoperability can serve the care needs of any care patient, throughout their care continuum with a disparate set of care providers. So we're really sharing that patient's aggregated health profile beyond the medical record, social determinants of health, we've heard all that. We're building an environment now where all that can be possible in a secured personal health electronic resource exchange, which we call SPHERE, and also having everybody in that care continuum be involved in that care through authorization by the patient. And then a tool that we've designed to build an aggregated set of care plans into one actionable lifestyle care plan that considers diet, rest, exercise, attitude, lifestyle, medications, and specialists. And those are all the components that we've heard everybody talk about. We're trying to bring this into one seamlessly integrated cloud-based environment that can be actionable and capture data that is reportable to any entity that wants to get insight into their patient, whether that's a family member seeing a trend that's happening before the provider or in combination with the provider. So we're really doing real-time care with real whole person-centered data. I think the barriers, which used to be technical, they're not technical anymore. With standards, I think we're able to achieve, and Health Gorilla and organizations like that are really paving the way to bring that into now the bigger challenge, which is buy-in from the organizations that may or may not want to share their data. You've got the big mega vendors, the Epic Cares, which have an attitude of global domination. They don't want to share. They don't have an option. With 21st Century Cures Act, we now, a patient can get authorization to have that data. Now, what we're trying to build is an environment where the patient is at the center of authorizing and knowing where that data is being used. And so I think that the future really is, it's wide open. I think over the next few years with folks like yourselves in the audience here, endeavoring, telemedicine, mental health, all the things we want to accomplish, I think they're going to be accomplished. And I think it's the buy-in, it's the trust we build in the way we do things. And so I think there's I'm excited about all the things we're going to see as an industry that need to happen. Thank you.
Wonderful, wonderful introduction. So we've got, as I say, a diverse panel. We've got clinical trials, we've got security, we've got patient engagement, we've got care coordination, just to sort of label you guys a little bit there. But very different perspectives on the challenges of interoperability. So I wanted to just, I'm going to go totally off script, I hope you don't mind.
So will we.
I wanted to sort of build on what you were saying. You were talking about purposes of use, the reason for exchange. And again, I don't know who all's in the audience, but there are some very specific purposes of query and purposes of use of data. And the purpose for which you query doesn't necessarily have to be the purpose for which you use the data. Data can be repurposed, but there are very specific purposes for which you can query. And treatment, payment, and healthcare operations are the three big ones. Those are the ones that were covered under HIPAA many, many years ago. Those are the ones that people really, HIPAA allows you to exchange the data, and in turn, the 21st Century Cures Act, as was mentioned with the information sharing requirements, really requires you to share the data for those purposes. There are, of course, other purposes. Research is one in particular, which is not part of treatment, payment, or healthcare operations. So I guess let's start with these purposes because, of course, patients get it when you're exchanging data for treatment. I mean, that was pretty weird 15 years ago when we started this. There was this whole period of opt-in and everything. But now, like, the world has moved on. Treatment is easy. Payment, a little harder because providers and payers don't always like to share data. And healthcare operations is kind of confusing. That's where care coordination comes in under healthcare operations. If it's being done by a provider, if it's being done by a payer, it's actually a different category. So talk a little bit about purposes of use. I'd like each of you to sort of, I'm going to go the other direction because yours is the one that's outside of HIPAA, so we'll end up there. But talk about the purposes of use. I mean, care coordination is a tricky thing. You're talking about user communities, caregivers, family members, community-based social services. Payers often get involved in care coordination, providers themselves. It's a challenge. How do you see us overcoming those challenges specifically related to data sharing?
Yeah, and I think, if you look at the purposes, you've got to decide what stakeholder you're talking about. If it's an insurance company, the purpose is let's lower the cost of care, right? So that I optimize my premium for the patient. And so, in that regard, they want to have the data there because that's going to help make decisions that are going to be, eliminating that lab that you think you need, but that data is going to be there. From a provider standpoint, it may be to give me a better insight to my patient as he arrives. And I think that's one of the things that I've heard a lot from some of the provider leaders out there. They'll tell you healthcare is broken. What's the problem is people are burning out because they're getting patients. They have no idea what really is behind this problem, right? And so they're challenged with all that, and you throw COVID on top of that, and you talk about the family and the patient. And it's the benefits there are that I want quality of life. I want, I've got a diseased family member that's been a problem managing their chronic disease, and I have no ability to help. And if you give me the ability to help them, I know they're okay. I feel better, quality of life, our whole overall, family cost of care, lower out-of-pocket costs, et cetera. So I think it depends on, what stakeholder you're addressing.
When I talk about patient engagement, it's actually a very broad term. And one thing always comes to me that in terms of patient engagement, one of the most important thing is health-seeking behavior, right? So when we are integrating multiple systems, multiple platforms, we can have 10,000 platforms, but if the patients are not using it, if they don't understand the importance of it, then we cannot get the benefit, right? So if we think all this interoperability problem as an onion model, what I always talk about, so it's kind of like if we have a cross-section of the onion, we'll see that deeper inside, the core problem is health-seeking behavior from patient perspective. So when we look at from the patient's perspective, it's how patients are reacting to the physician's advice or how they're reacting to the platforms. Suppose there are multiple platforms right now. ZocDoc is helping for making schedules and other platforms like that. But it's how can we engage these patients with these platforms so that the doctors can help communicate with the patients more. So during COVID, we understand that telehealth did a revolution. So now we understand the importance of telehealth, how the doctors can be more accessible to the patients, how in terms of any emergency or anything, the patients can reach out to the doctors. But still now, I think if we address health-seeking behavior, and for that, it's very important to address another communication method, what we call the behavioral change communication, the BCC campaigning for the patients. And that's the best way if it comes from their provider. Either primary care physician would be the best, because now in value-based care model, we see that primary care physicians are the center of the care, and they are kind of capturing all the health events, all the data, and from there, if the patients are completing their referral loops, eventually all the informations are coming to the primary care physician. So that once the patient is moving from one primary care physician to the another primary care physician, if we have a better way of transferring the data from one PCP to another PCP, it helps the patient significantly. Because if we look at the data, it's almost like 28 million people are actually migrating from one state to another. And if we look at the domestic flights in the United States, that's more than 600 million flights per year. So in that case, one of the biggest problem, even I personally faces several times, that when you are moving from one state to another, and if you are encountering any health event, you are at a loss, you don't know what to do. Because we are talking about, so that's why when I started that, rather than swamped in the process, we really need to understand the purpose. And for me, it's very important that the health-seeking behavior, right now what we have personally is a kind of sickness-seeking behavior. So all this healthcare interoperability, if that can be done properly with the BCC campaign for the patients to enhance the behavioral change communication, health-seeking behavior, so the trickle effect will be that this sickness-seeking behavior can change into health-seeking behavior. And I think then we can actually see the result. Because if we want to see a persistent result, we need a system. And for the system, we need a tool. So right now, we have a lot of experts here who are actually dealing with the technical barriers, what Jeffrey just mentioned, that we already overcome those situations now. And it's now, it's more about the cultural barriers. It's more about the health-seeking behavior. So yeah, that's what I'd say regarding this.
So I'm going to pivot us a little bit for Charles' response here. Get ready. So a little bit of HIPAA 101 real quick. So HIPAA covered entities are payers, providers, and health data clearing houses. They're not healthcare apps. So whether we're talking about a care coordination app for family caregivers, whether we're talking about a patient engagement app, if those apps actually are connected to a provider organization through a HIPAA business associate agreement, then the app is covered by HIPAA. But a lot of apps out there aren't selling themselves as business associates, they're selling themselves as apps, which means that they are not covered by the HIPAA privacy or security rule, but rather they're covered by FTC. So Charles, you're in privacy and security. We're talking about a lot of creative solutions here, some of which fall outside of HIPAA. So what happens to privacy and security when the data is out of HIPAA? Well, and how does that impact this discussion?
Yeah, and that's a great question, and one that goes beyond healthcare, honestly, that we have a very diverse and inconsistent set of privacy and security rules here in the United States. It's not an area that we've been real strong in. And yeah, HIPAA doesn't cover a lot of things because Google didn't exist in 1996. Facebook didn't exist in 1996. We didn't have cell phone apps, in 1996. So they didn't know this was going to be a coming problem. And that does create a significant challenge for us, going back to my idea of trust, is that people don't want to risk that their data is going to get out there and suddenly they're going to start getting pop-up ads from Google saying, your doctor says you need to exercise more. Nike's having a sale on tennis shoes, well, maybe some people do, I don't. So that's one of the risks with it. And that really goes back to that chain of trust of establishing when you're trading this data, knowing that it's a reputable organization that you're trading it with. They've met certain criteria as far as certification and purpose of use, as you said, that it's a clearly defined purpose of use. We are giving you and we are sharing this data for the purpose of research, for the purpose of healthcare treatment, for the purpose of cost controls or population health, or for the purpose of advertising. That's a valid purpose, but it has to be stated and it has to be known to the individual data owners, the patients and users, that this is what their data is being used for.
Are you familiar with the Karen Code of Conduct?
Yes.
You want to talk a little bit about that?
Go ahead. Yes.
Okay, that's fine. So Karen, C-A-R-I-N, you can look it up, is an organization that has sort of brought together a whole bunch of the health app developers and said, hey, the only way we can really solve this problem is to self-police our industry. So let's come together and let's define what it means to be an ethical, secure, private app when you're living outside of HIPAA and in this FTC regulated space. So check it out, the Karen Code of Conduct. I'm actually going to be working with Karen starting next week, I think, on a secondary code of conduct for the middle layer, for organizations like ours at Health Gorilla that aren't actually a patient-facing app, but are more supporting the exchange between those apps and providers, researchers, payers, and others. So it's a challenging space because we don't have really clear federal legislation. We don't have comprehensive privacy rules that really are set for this part of the 21st century. Even if we get them right now, they're not going to be right in 20 more years, but at least we know HIPAA's out of date, right?
Yeah, well, and it's made more complicated by some of the states are now taking the lead saying, okay, these are the privacy rules in California, and these are the privacy rules in Wisconsin, and these are the privacy rules in Rhode Island. We don't have geological boundaries on where our data is going and where these apps are being used. So suddenly you're having to go, okay, we have to comply with all of them? How's this going to work exactly?
Right.
So we were talking about purposes of use and the fact that research falls outside of treatment, payment, and healthcare operations, but there's a purpose of query beyond those, which is individual access services or patient requests for their own data. And there's not a clear line between a patient requesting their own data and a patient giving permission to another entity, an app, to request data on their behalf. So one of the things we're looking forward to in this new TEFCA framework, the Trusted Exchange Framework that's coming, is that one of the first priorities besides treatment-related queries is queries, individual access services, IAS queries as they're called. And we believe, at least where I hang out, that is going to really facilitate research. So talk about research, talk about being outside of TPO, as we call it, and the potential for leveraging IAS, Individual Access Services, under TEFCA to support what you're doing.
Yeah, absolutely. It's a really interesting point, right? Because so zooming out, when you're a patient and you're going to a hospital for your normal checkup, your information is included in your electronic health record. Now, if you're also enrolled in a clinical trial, then some of that same data is going to come over to us within our electronic data capture systems. Historically, that data is not one-to-one. So even if we might be capturing weight in one way in the electronic health record, it might look totally different in the electronic data capture system on our side. So we've come a long way, and as Jeffrey mentioned, technology is really not the problem here, where we started off with paper and we finally moved into electronic systems. But right now on the site side, a clinical data coordinator, a human, is sitting there manually swivel chairing between one system and another, duplicating that data entry. And so what we started to see was that is causing significant delays in time to access of data for us, as well as quality of access. And this is where we see the query rate come in, where transcription errors run high. And ultimately, for our clinical scientists, that's not helpful for making faster decisions for our dose escalation, for instance, in early phase trials. So there are questions that we want to be answering. We want to answer those quickly and adapt quickly so that those clinical trials are most effective for our patients. So the product that we're building is kind of what I like to nickname the Rosetta Stone of healthcare, because for research speak and hospital speak, there wasn't really that translation, right? Those languages didn't really communicate. And now we're finding a way to leverage technology that already exists, application programming interfaces, mapping algorithms, cloud services, putting them all together in a unique way to automate that flow of clinical trial data. And that's really the big nut that pharma's been trying to crack for 15 some years. And there are a couple of reasons as to why that's possible now. And technology not being the issue, but the FDA, for instance, in 2018 came out with a guidance for how we think about using electronic health record data and increasing that accessibility of information for us to use that in clinical trials. And so that opened up a whole new world for us to think about new questions we might want to ask. And back to Tanwar, your point on what questions do we want to be addressing with this data? I mean, longitudinal data is big. Thinking about your work, Jeffrey, with real-world data, patient longitudinal data in, let's say, Flatiron databases, a company that Roche acquired a few years ago, that kind of information can really help us learn even more about patients. I mean, super responders, maybe specific genetic types of patients. How do we increase accessibility? And so there's so many questions that are now open for us to answer and explore with the access of this data in a much faster way that we were never able to see before. So it's a totally new environment. And then I do want to address the patient access to their own personal data. And so, of course, the way pharma works is, we're very cognizant of informed consent forms, for instance, so patients know what data are we actually pulling over. We don't want all of your data. We just want the very specific amount that is relevant to the clinical trial. So that's very, very important. And then thinking about the product that we're building, we obviously can't know which patients are, or who they are, right? We can't know their protected health information. So their PHI is information that we would never get on the pharma side. So how do we think about keys and abilities to pseudo-anonymized data, thinking about subject identifiers, for instance, so that we're not actually uncovering who this patient is and breaching that level of privacy, and also trust, to your point, right, in clinical trials, that's really, really important. So lots of questions to answer there, and then I think the last point I'll make is just around the health investigators at the clinical trial site. So our patients enroll in a clinical trial, and it's really important that the investigators can get an understanding of how the trial is going, how their patients are doing, so that they can then adapt and think about what other types of care might that patient need outside of the clinical trial. So it's this really bilateral way of thinking about the flow of data, and all of, as you mentioned, the stakeholders are really different and equally as important in thinking about how we solve these problems and address these questions.
That's great. So you mentioned SDOH at one point, Jeffrey, and I don't know if everybody here knows that acronym. It actually stands for a number of different things depending on whom you're talking to. I like to say social drivers of health. Some people say social and behavioral drivers or determinants of health. But SDOH is sort of all that other data that really hugely impacts our health. They say that no more than 20 or 30% of your health is actually a result of your health care, that much of it is related to who you are, where you live, your behaviors, et cetera. So SDOH data is all that other data that is increasingly important to providing healthcare, to planning healthcare, but has not been exchanged or even collected in a standardized way in the past. So there's a lot of efforts going on to standardize what are the contents of SDOH data, what are the technical standards, how to exchange that data. But talk about this from a care coordination standpoint. How are you collecting and using that data, and what do you see as the challenges with that?
Yeah, well, and I know like the Gravity Project, which is very keen on trying to put their arms around what is social determinants of health. There's been a lot of debate, but it is, fundamentally it's about that patient's lifestyle, where they're, your income, your education, your zip code, and as an example of zip code, where you live might be a food desert. And you're a diabetic and you're supposed to be on a care plan that your doctor wants you to be on to get healthy food. You don't have healthy food. And maybe you don't have, people, in your immediate care circles. You might be alone. And so these are indicators that are now being captured, and we're certainly going to be including those in our sphere model, because those are going to be data points that can be used to really isolate, get insight into, oh, this patient needs to have ready meals or ready wheels, and so it can help determine the needs. Well, first of all, the issues that have to be addressed. So I think they're going to be more and more involved in, and certainly this is where industry is putting their arms around it, seeing how important it is. And I've even heard that social determinants of health are more important than your genomic data. That's quite a statement, right? So it is very important. Everybody's eyes are open to it now. We've got to have, in some way, have that be part of that whole person that we're looking at.
I think the line is that your zip code is a larger determinant of your health than your genetic code.
Right.
Easy to remember.
Yeah.
So Tanner, you're working in patient engagement. You've got apps where you want to engage patients. That, of course, provides the opportunity for patient-generated health data, for you to send a questionnaire, a survey, or get some information back. Some of that data, is purely clinical. Some of it may be social. Some of it may be behavioral. A lot of information there. How are you integrating that sort of patient-generated data and SDOH in your domain?
So when we talk about social determinants of health, so all those topics Jeffrey mentioned. So one very important thing about it, that when we are pulling data, it has to be like there has to be some constants and there has to be some variables. So phenotyping and genotyping is always constants for us, right? But the social determinants of health, they are the variables. So when we are talking to different physicians, specialists, so I think the social determinant of health, when we are picking those variables, it's there is some variables to pick up those variables also. So based on that, I think it's a little bit more subjective to the specialist. It's more subjective to that caregiver. It can be, because when we are talking to the behavioral health counselors, so their social determinants of health sometimes is different. And when we are talking to the cardiologists, their social, definitely all the components of social determinants of health are important, right? But you don't want to be swamped with all the information. Maybe that's not helpful. So we need to have very targeted variables with the specific constants so that we can get the right output what we are expecting. So that's how we are trying to generate, but there needs to be a lot of research and meta-analysis to find out those right variables for right specialists.
Right.
So Charles, continuing on this theme of the SDOH, today SDOH information is being collected in a lot of different settings. In the clinical care setting, in community-based settings, potentially by apps, et cetera. I've been involved in a number of efforts to try to get the data that's being collected out in the community by caregivers, social care organizations, getting that back to providers. But in that setting, they don't have all of the big iron privacy, security, apps, HIPAA that we have on the provider side. Talk a little bit about the challenges and opportunities with securing and assuring the privacy of SDOH data as it's flowing in and out of health systems.
Well, I think one of the big challenges is just being inclusive of this group in the discussion, because I think that they are left out a lot, that they're not getting the education they need, certainly not about security or in general how the data is being used. So making them aware, the number one biggest vulnerability we have in security is people. You know, you can implement all the systems in the world, and when John Q, you know, puts his user ID and password on a Post-it note and puts it on the side of his monitor, it's all for nothing. So it's really working with these groups to help they understand, and then working with the innovators to develop the apps to make it easy for them to implement or to get that data across in a secure manner. So it's really, it comes down to convenience and education. So making it easy for them and making them aware of what it's being used for and how to do it securely.
Makes sense. So Mahek, I want to twist it a little bit for you, because of course in clinical trials, part of what you're doing is having patients report back. You know, so again, this notion of patient-generated data, some of which probably is SDOH related, a lot of it is really clinical. How are the researchers who are collecting that data from the patients then sharing that data back with other members of the care team beyond the research team?
Yeah, so I want to take a standards approach to this answer, because I think it's interesting to see the way our community is changing in terms of how we collect health data. So you may or may not be familiar with FHIR, the Fast Healthcare Interoperability Standards, and that are resources, and that is I think, budding form of ability for us to really capture data in a way that may be a little bit more consistent with, you know, interoperability across our electronic health record systems, at our clinical trial sites, for instance. That adoption is starting to catch fire, no pun intended, but it's good to see that, I think, as we evolve in the landscape and clinical trial sites, you know, develop their infrastructure of actually being able to capture this kind of data, we're seeing standards take place that allow for that ability to disseminate that information a little bit more easily. Not all sites are there yet, and so we do see quite a spectrum of sites that are more willing to onboard now, and sites that maybe are still on paper. And so that concept of FHIR resources, let alone electronic resources, doesn't really exist yet. And so being flexible in ways to aggregate that data when it comes to us, and then being able to glean insights from it and then report back out is really, really important. But this concept of standards is one that's really exciting, because at this point, one would hope that adoption of FHIR resources might be more prevalent in the coming years.
And that's one of the things that I think is one of the challenges with standards too, and we're seeing it with FHIR already, we saw it with the other things, is there's a Da Vinci implementation of FHIR, there's a Blue Cross Blue Shield, yeah, just like DICOM, just like HL7, just like everything. So it's really getting to that point of maturity as an organization that we can say, okay, this is how we're all going to use this standard, rather than, you know, well, we've got a standard, but everybody uses it a little bit differently.
Right.
One of the benefits, the reported benefits of the new Trusted Exchange Framework, or TEFCA, is that it's setting very specific standards. So while the TEFCA framework for data exchange is going to be voluntary at first, it's going to be limited to treatment and these individual access services, it does specify a FHIR version. It has a very specific FHIR roadmap for how we're going to transition from where we are today to where we need to go. And again, it promises to be a single framework for nationwide exchange. So it's very, very exciting. I have noticed this hasn't been a super interactive audience, but I would love to give time if you guys have questions.
If I can
no, please go jump on. But if you have questions, start thinking about them, and please come on up.
You know, picking up on this introduction of FHIR in this conversation, which we probably should have started with FHIR. But you know, FHIR, and I'll throw out two: structured and unstructured data, right? So what in our platform, for example, we're realizing, because we have one of our key members that is, you know, helped establish the HIPAA policies 20 some odd years ago, Dr. Dixie Baker. And so she said every piece of data, yeah, every piece of data that we ingest, we're going to turn into a FHIR resource. So we're only going to, if we
Well,
get
those that you can.
yeah, well, even unstructured, a picture of a meal, and we can turn that into a data point, or I go to CVS, and we'll talk about CVS and where that whole market's going. But, you know, I go in, I haven't taken my blood pressure, it knows, it tells me, hey, I've got a cuff here, stick it in, take a picture, we take that, and we scrape those numbers, right? That'll be a FHIR resource. So everything we want to deal with, which would facilitate research, right? Because we're going to build this environment that we can also, you know, strip the patient data, have it in a whole data set that could feed you know, research organizations. But I just wanted to, you know, touch on that FHIR because it's key, right?
We could do a whole panel.
We could do a whole.
But look, we have Q&A, so let's do this. You want to introduce yourself and where you're from?
Sure. My name is Jessica Grunler. I'm from the Bay Area. I have been a nursing informaticist for 25 years. I've worked with Amy and all of the other organizations on interoperability. And my question from a strictly pessimistic view or realistic, depending on where you live, is when the largest hospital corporation in America still uses a DOS version of Meditech, how in the world are we going to get to interoperability in my grandchild's lifetime?
Well, so Meditech is certainly one of the largest EHR vendors in the hospital space. I will put in a little plug. Our company just signed a contract with Meditech last month to support their interoperability on FHIR in Canada,
Are they still
and
on
hopefully moving that into the U.S. So I mean, even Meditech, you know, they've got a new cloud-based solution. I mean, so it's true though. You can't force a hospital to their system. You can't force people into the 21st century. But I think the writing on the wall is very positive, even for Meditech hospitals.
I agree that it is positive, and one silver lining that we saw in the pharma space, at least during the pandemic actually, was the site data coordinators and site resources in general were strapped, and we saw a lot of resource attrition. We saw even further delays in access to data. Quality of data was dropping, and you know, right when the pandemic started, it was pause all non-molecule activities. You know, focus specifically on making sure the pipeline is moving through and clinical trials are continuing. But then we started to hear from clinical trial sites and data coordinators and investigators themselves, we need to bring back this initiative. It's really, really important that we find a better way of use of time for our data coordinators, a better use of time for our physicians. It's really important that pharma comes up with a solution, at least on the research side, to automate this flow of data because it's taking up way too much time and it's a resource burden that we can't support anymore. So that was a silver lining that we saw during the pandemic that I think I can imagine happening again, I think, in a way that coming out of the pandemic, we really take that lesson forward. And so there's a lot more incentive to build solutions to these kinds of problems now that we've seen how difficult it was to access data at a time like when the pandemic started. So that is, fingers crossed, a good sign for us moving forward. And that's one perspective.
Question?
In the SDOH area, I'm wondering if any of the panelists have had any experience with the data that's been collected in the Accountable Communities projects. We were able to use that data in Dallas and asthma work to correlate ER visits and admissions with social determinants of health data that was collected as part of the surveys that. And also on the side of, you know, we're talking about the challenges of integrating. I think United Health, and I'm not a big United fan in other respects, really deserves a shout out because they got the CPT code. So now in claims data, there is at least a way of counting. Before United did its work, there was no way of coding for food insecurity, screening and intervention. It did not exist in CPT. It now exists. And so at least we have the hope of being able to collect the data.
Really, really good points. And please catch me over the wine area out there. And I want to talk about some of this data that you're seeing in the community. I think one of the challenges with SDOH, you know, unlike clinical data, which has been being standardized by HL7 and others for decades, The social data is not so standardized. So different well-meaning folks have developed various standards. And as you've heard, the HL7 Gravity Project is really trying to pull all that together and come up with true international standards for what data to collect, how to collect it, how to transmit that and exchange it. Yeah, a lot of challenges, but yeah, a lot of people have done great work. Next question.
Sure. Hi, guys. So my question is about this collaboration and interoperability, and it's about budgeting and ensuring that we're meeting these sorts of minimum standards as time goes on. And so to the last person's question around how are we going, or two questions ago, how are we going to reach these goals when we're still operating on these DOS versions, right? So, I'm an engineer from the Silicon Valley who's now in integrative medicine. So I'm looking at this from a younger point of view going, well, my experience, and especially as we're collecting patient data through things like Fitbits and Apple Watches and all the fancy detect devices, there's a lot of innovation in Silicon Valley that's being driven towards these individualistic data gathering, right? There's a lot of money in that. But what about the underlying infrastructure of, as this previous woman mentioned, the DOS versions? It's also a related supply chain issue when most of the supply chain people are using Excel and VBA, or a lot of stuff in China is running on Windows 95. So how are we having talks? And so, but at the same time, when you buy a new iPhone, you're forced to upgrade and not use an auxiliary cord. You have to use wireless earbuds now. And so my question is, I'm looking at those disparities or those gaps in the conversation as we're forcing upgrades on individual personal consumer devices, Fitbits, watches, cell phones, et cetera. Why are we not matching and having the same standards at the hospital or infrastructural level in terms of software? And are we setting, for example, is there a conversation happening in Congress or about money, or can we start one and invite one about, do we, like we had set carbon emission standards or everybody has to go green by 2023? Are we doing everybody has to upgrade out of DOS by 2030 or something like this? Are we setting standards to keep up with what's happening on the personal consumer side? And I just wanted to bring up that topic because I haven't heard us discuss it anywhere.
Want to talk about ONC certification and how that advances year by year?
Well, I wasn't going to talk about ONC certification, but I did want to, I think it's a great question, and I wanted to look at it from a security point of view, because as a security specialist, legacy systems, legacy hardware, legacy software is the bane of my existence. There's more than a few of these gray hairs come from that. What's driving it from a security perspective is unfortunately the prevalence of security threat actors in the healthcare space. It's become a major target for security assessment or security attacks. And that being attacked successfully and having data breaches or compromises is a very, very expensive undertaking. So there's actually an ROI now to upgrading your hardware, upgrading your software, getting it to a secure version, which may benefit some of these other things as well as an ancillary. It's not a direct answer to your question, but it is kind of a silver lining of the unfortunate environment we find ourselves in a security environment. And then did you want to talk to ONC as well as what they're doing?
Yeah, so it ends up that the old systems in hospitals are really a drag on the hospital's bottom line in many ways, but one of them is that hospitals are strongly incentivized by CMS and ONC to utilize certified software. And the certification, while we're still talking about the 2015 certification specs, they do advance a little bit with each new ONC rule. And really part of that advancement as of this month is that all certified health IT must support the FHIR standard. They must be delivering that to their customers. And the FHIR standard is built in to all of the new CMS rules in particular for both payers and providers, and there are already FHIR standards for patients being able to access their data directly. So I hear the agitas around old systems not keeping up, but the reality is that they have to keep up or they're going to go out of business. I think we may have time for one more question real quick.
Thank you. It's a great panel, by the way. And my question is, and I asked this of Charles yesterday, so I'm told that hospitals are afraid to share data because they're afraid of malpractice lawsuits, right? You share data and then somebody finds out you're consistently making wrong decisions, right? So how do we get hospitals to share data with research?
So hospitals must share data. Providers, there's a federal law that says if HIPAA allows you to share the data and someone asks you for it, you must share the data. So, there is still this sense of, I'm protecting my market, I'm protecting my this or that. Within the information sharing requirements that came out of the 21st Century Cures Act, there are certain exceptions where a hospital, any covered entity, could say, well, I can't share the data because of this. And one of those is infeasibility. The notion that I can't share the data because I can't share the data. My system is down, or my system doesn't do that. And I think early on, as we get into this new world, there are going to be people claiming infeasibility. I haven't upgraded my system. But that's only going to hold water for so long. I think people are going to be forced. And we are at time.
Thank you.
Thank you, panel. You guys have been amazing. And thank you all for the great questions.
Great.
Thank you so much, guys, for sharing all of your unique perspectives on that. Okay, it is time for our exclusive VIP recognition session, aka award ceremony. The Health 2.0 conference applauds the invaluable contributions of each and every one of you from all over the world. By the way, big shout out to everybody here who's traveled internationally to be here. I've spoken with a few of you now. There was Amsterdam, Egypt, Amsterdam. Anybody here internationally flown in? Raise your hand. All right, they've all happened to step out. Well, shout out to them. Without further ado, let's get on to it. I would like to invite to the stage, please give a warm welcome. She's going to be our Vanna White, and she is, been with us for all these years. She's wonderful. Please welcome Jody Ruttenberg, Vice President of Online Sales for Resource 5. You'll get to take a picture with her. And of course, your lovely plaques. Okay, guys, it is time. I'm going to call your name up. Please make your way to the stage. You will get to take a lovely picture with Jody and your plaque. And if you'd like to say a couple of quick words, you definitely can. Cue the awards music. Da, 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 da. You don't want me to sing. It's not pretty. Our first award for outstanding leadership goes to Abraham Reeklin. Abraham, please come on up.
Hello, thank you so much. Thank you to Health 2.0 for this honor. It has been a remarkable day and a half, 2 days so far, and I have really enjoyed myself. I also want to thank my very lovely and capable wife, who's back at home with our children, managing things so I can be here. I want to thank one of my friends from Washington State who came with me to support me through this. Also, all of the staff and the contract therapists back at home in Oregon at my company who are putting up with me every single day and my poor executive functioning skills. And so I just have to thank them. They are the reason I'm here today, and I appreciate them to no end. Thank you so much.
Our next award for outstanding leadership goes to Amir Al Mosley. Amir, please come on up. And our next award for outstanding leadership goes to April D. Gould, MHA, MACM, BSN, and RN. April.
I just want to say thank you to Healthcare 2.0, thanking my family at home back in St. Louis, thanking my job, the VA, us working for our nation heroes and my nursing team that has allowed me to gain this Outstanding Leadership Award. Thank you, thank you, thank you.
Thank you. Our next award for outstanding leadership goes to Brian Clark, MBA, MA, MLS, ASCP. Please come to the stage.
Hi, thank you, everybody. First off, I'd like to thank my wife, Tanya, who joined me at the conference here. And then also, more so, just want to say thanks to my team, because we couldn't do anything that we do with leadership without our teammates. So to them, I'm standing here as a result of that. So thank you for the opportunity to be recognized, and it's very humbling. Thank you.
Perfectly said. Our next award for outstanding organization goes to Charles Hale of Hale Consulting Solutions, LLC.
Thank you so much. As cybersecurity continues to play an increasingly vital role in healthcare, it's an honor to be recognized for our work and accept this award on behalf of Hale Consulting Solutions. And I want to give a special thanks to my family and to Charles Hale, our founder, for all the work that we do. It's been a very busy and successful year for us, and I can't wait to see all the new opportunities that the new year has in store for us. Thanks so much.
Our next award, also for outstanding organization, goes to Christy Alexander, 5-Star Therapy.
Hi, thank you, everyone. I'd like to thank my family and my business partner, Lindsay Hatfield. About 10 years ago, we set out and thought it was going to be a 2-person team, and one by one, so many people had enough faith in us to continue to grow. So I want to thank Lindsay Hatfield and each of our therapists, nurses, and our office team. Thank you so much.
Oh, and there's your award. Our next award for outstanding leadership goes to Denise Leslie.
Thank you, Health 2.0, for such an amazing conference. Hasn't this been great, you guys? I thank my team because they share in the vision and they bring their talents to the table every single day. And I'd also like to thank all the healthcare professionals that refer patients to us for clinical massage therapy, allowing us to play our role in healthcare. Thank you.
Our next award for outstanding leadership goes to Dennis Dolniak. Dennis.
I want to thank Health 2.0 for acknowledging the leadership I've been able to provide in the dementia field and the ability to create Nana's Books Foundation. This is a nonprofit foundation where we are now delivering books to students in Title I schools. And that's just remarkable. And I thank my sons, Mark and Craig, who are helping me in honoring my wife, Nancy, who passed away from early onset Alzheimer's. So I'm looking for additional funding sources, hoping I can network with many of the healthcare providers here who also share in trying to find a solution to dementia.
Thank you. Thank you. Our next award for outstanding leadership goes to Ebony Dotson.
I would first like to say thanks to God for putting his super on my natural every single day, which allows me to do the work that I do. Also to my family, my friends, my colleagues back at Morehouse School of Medicine, and also my colleagues at the Atlanta University Center Data Science Initiative. Thank you, and also to Health 2.0 for this amazing honor. Thank you so much.
Our next award, continuing with outstanding leadership, goes to Eric Durack. Eric.
Well, first I'd like to thank my team and my advisors at my company, Medical Health and Fitness, which is actually pulling me out of retirement to start a new company. Go figure that. But I'd also like to thank Health 2.0 because this is really one of the first types of conferences that I've been in my entire career that has put so much emphasis on the integration of health, wellness, and healthcare. I think it's fabulous. I'm glad I'm here. Thanks.
Thank you, and for all of your support. Our next award for outstanding leadership goes to Garrett Shoemaker.
Hello, thank you. Yeah, I would just like to mainly thank my family and friends, but most importantly, my wife, Alia, who's here and looking forward to celebrating with you later, baby. Mainly, I want to thank my team. Literally, the only reason I'm able to do what I do and we're able to be as successful as we are is because of them. It's the only reason I'm here. So thank you to them.
Our next award for outstanding leadership goes to Hanuman Japani, PhD and MBA.
Hello, everyone. Very excited to be here. First of all, I want to thank Health 2.0 for organizing this great meeting. Also, I want to thank my family, mentors, friends. Throughout my journey, they really helped me in each and every way achieving my goals, particularly empowering clinicians and improving the quality of lives of patients. And now I have established my consulting firm, Samras International. I'm going to continue doing the same. Thank you very much. Appreciate it.
Moving right along here, our next award for outstanding leadership goes to Jessica Grunler. How about that, love? All right.
Hi, thank you. I'd like to thank Health 2.0 for acknowledging my healthcare leadership skills and providing this fabulous platform to collaborate with every distinguished guest here. I've not only been president at Health 2.0, I've been president at Law 2.0 because I do legal nurse consulting in addition to healthcare consulting, and snuck in marketing to learn a few things. And this is an amazing platform. I'd also like to thank the other part of Clinical Project Resource, my husband, John, who started out as my chief security officer and now is my chief strategy officer because he's included in every decision I make. Thank you. Very well done. Thank you.
Our next award for outstanding leadership goes to Jordan Hamlin, BCN.
Thank you so much. I'm so honored to be here. Everyone has seemed absolutely incredible with what you're doing, and it's actually collaborative, which I thought may not be possible. Thank you, Health 2.0, for putting this on. I'm really grateful. Thank you to my family who gave me a chance and opportunity in life. And thanks to my boyfriend and to my friends who are out there supporting me. I'm so grateful for everyone. Thank you.
Our next award for outstanding leadership, put your hands together for Justin Salomon, MD. Justin. Big round of applause. Of course, one of our gold sponsors, Outcome MD. Our next award for outstanding leadership goes to Lexis Surratt. Lexis. And guys, we know you just can't wait to get your hands on your photo, so our team will definitely be in touch with you here in the coming weeks to give you your copy.
Why not, right? Thank you very much. Outstanding leadership I learned from having 4 children, humbly. And I'm so grateful for this experience. I don't have the same background as all of you incredible people. I've learned so much from all of these conferences, and to accept this award is, incredible to me. So thank you to my team. Thank you to my kids for the humbling experience, and thank you, Health 2.0.
Our next award for outstanding leadership goes to Lisa Swanson. By the way, great job, guys. Keeping up with the applause. Very good. High five to each and every one of you.
Thank you very much, Health 2.0. I just want to say thank you to our outstanding team of staff and medical providers. We take care of some of the sickest patients in the home setting based upon our data analytics. So we're looking forward for the new year. So I'm very proud of this for them. Thank you.
Please put your hands together for our next Outstanding Leadership Award recipient, Mehek Mohan. Mehek. Once, twice, I'm keeping the award. Just kidding, maybe. Our next award for Outstanding Leadership goes to Mike Porcello. Mike. I get 2 awards, okay. Third time's a charm, right? We've noticed our trend. Our next award for Outstanding Leadership goes to Min Pomper. Min? Yay.
Thank you to 2.0 for recognizing the important place of supporting family caregivers in the patient journey. I am here today because I founded a company back in 2021, completely focused on creating the infrastructure, the resources, and the support mechanisms to help families and individuals plan and manage someone else's care. There's such an incredible and a pivotal piece of everything that we've talked about today. It's been quite a cognitive overload, taking in all this information and applying it in the context of family caregiving. So I hope in the future that family caregivers and this incredibly important piece of the care delivery system in terms of support has a bigger platform in the future to really share and be a part of some of these conversations that we've been hearing about today. So thank you so much, and thank you to my friends and family and my community of support for supporting me in this journey. Thank you.
Our next award for Outstanding Leadership goes to Mindy Millman DeCrasta. Mindy.
Thank you. I'd like to say thank you to 2.0. This has been just terrific, really great collaborative conference. I want to thank my husband who supports me and came out here with me. He puts up with me being on the phone 24/7 with what we do. Our company is called Mental Health Strategies and Solutions. We're always here to help all the doctors that help all the patients and people struggling with mental health because we're in a crisis. I share this with my 2 team members that are here, Nikki Gentile, Bridget DePasquale, and the rest of our team that's back there. We've got a virtual ship that's dedicated to helping doctors who then in turn get to help all the people struggling out there with mental health. Thank you so much. I forgot something. Most importantly, my company was founded because of my daughter. So I need to thank my daughter or my company wouldn't even be here. Thank you.
Very sweet. Our next award, this is for Outstanding Organization, goes to Nicole Dower from Success on the Spectrum. Nicole.
Thank you. It is my great honor to accept this award on behalf of Success on the Spectrum. Never knew that we would grow to be so big, but the company is now comprised of 21 locations across the United States. I am very pleased. The CEOs that run each of these locations are very capable of delivering better access to care and also quality care of autism therapy services for children. And I would like to say that we are the first franchise of our kind, and we are proud to be paving the pathway for future services for our children with autism. Thank you.
Our next award for outstanding leadership goes to Stephen Lane, MD, MPH. Stephen. I feel like we've seen you a lot today. That's a good thing.
I really want to thank Health 2.0 for the opportunity to moderate that panel we just had. What a great bunch of people. Also, I just want to invite any of you who want to talk health data interoperability to find me afterwards. As I said earlier, I live and breathe this stuff. I think data interoperability is central to everything that we're doing here, the home care, the hospital care, you know, everything. It in my mind, it's the only tool we have in our toolbox that helps address all 5 of the quintuple aim of improving healthcare across the country and around the world. So hopefully we'll continue the path forward with the help of this recognition from Health 2.0.
Our next award for outstanding leadership goes to Susan Wood, PhD. And moving to our next, our award for outstanding leadership goes to Tucker Owen Marchesso. Tucker.
Hello, check. I would like to accept this honor on behalf of my team, XY Gene, Eric Fennenbach, Patrick Guerin, Jeremy Klein, and our technology partner, Holon, and all of you. Thank you for being here. Each and every one of us is really trying to improve healthcare as a whole, and I think that that is an amazing opportunity for us to collaborate and be able to do something great. Thank you, Health 2.0, for making this happen.
And getting down to our last handful of awards. Next, for outstanding leadership, goes to Wendy Ringo. Wendy. That would be a really great Hollywood name, just in case. Great actress name, right? Yeah.
I would just like to say thank you to Healthcare 2.0 for this amazing opportunity. And I would also like to thank my team, Sciometrics, back at home in Royal Oak, Michigan. So thank you.
Our next award for outstanding leadership goes to Alexander Coons from OP2 Labs. It's a hustle from the back, isn't it? You did a great job.
First off, I just want to say thank you, Healthcare 2.0, for recognizing our organization in Dubai, and the Personal Leadership Award, which I find very difficult to accept, because I believe leadership is a reflection of a company's culture embodied by its employees and their families. So thank you, OPT Labs.
Our next award for outstanding leadership, please put your hands together for Jesse Lyon.
Thank you, thank you. Oh man, this is great. I just want to say thank you to my team at DreamApp and the wonderful things that we're doing, to our CEO, Dennis, to the CFO, Yar, to our designer, Andriy, and many of our designers who are in the Ukraine and struggling over there with all the things they're going through. Many of them meeting with us over Zoom in shelters, and while sirens are going off, heart goes out to them. I want to say thanks to my mom and dad, of course, and to my beautiful wife sitting in the front who's pregnant with our firstborn. Thank you so much.
Congrats. Our next award for outstanding leadership goes to Kevin Carey. Okay, moving on to our next. Please put your hands together, receiving the Outstanding Leadership Award for Timothy Washburn.
I just want to thank Health 2.0 and my great team, Doug Sparks, Ray Vano, JT Thompson, and Bradley Herzog, and my wife, who's actually part of my company's team now. Thank you for everything. This is awesome. Let's make it rock next year. Time to change it up. Thank you, everybody.
Our next award is for Outstanding Leadership, Anthony Capone, Doc Go.
Every day we have between 3,000 and 4,000 clinicians that hit the field, going to homeless shelters, people's homes, doing street medicine. This award is for them. They're the ones that really go out there and save lives every single day. Thank you.
Our next award for Outstanding Leadership goes to Stephen Lane, Health Gorilla. It is for the Company Organization Award. Congratulations. Double trouble. Look at you.
Yeah, so I just joined Health Gorilla a few months ago. I've been in the provider space for the last 35 years, and it's really been a great change. It's a wonderful company. The founders are remarkable people in Silicon Valley, and they're doing really important things. As I mentioned during the panel, looking to be one of the first qualified health information networks under the new Trusted Exchange Framework and Common Agreement. So working hard to improve the transmission of health data across the country.
And our last award to wrap up this session, please put your hands together for Outstanding Leadership for Dr. Regina Adem. And guys, right after this, we do have our networking cocktail hour. So we will meet you right back in the registration area.
Well, thank you all for being here. And thank you, Health 2.0, for hosting this and for having these events for us. I would love to thank my husband and my children for whom I do all of this, as well as all of my collaborators at Clinicians Touch Healthcare Solutions. Thank you all.
Wonderful. And one more huge round of applause for all of our award recipients. To all of you for being here, for your questions, perspectives, knowledge, even just your presence. We are so grateful for you all. That, my friends, is the end. Day 2 of the Health 2.0 conference. We are so excited to bring everything back. One more day for you tomorrow. More amazing speakers, panels, and well, a lot more networking and knowledge to learn. So with that, we will meet you again in the main lobby area across from registration for our network cocktail hour. Have a wonderful evening, guys. And remember, what happens in Vegas does not stay in Vegas. So watch out with your social networking. Have a great night. Be safe. I wish you were my...
One of your no-shows, stop by the table.
Sure.
Did you want to just get some pictures?
Yeah, we can see if they want to be added tomorrow, or we can see what's what. Are they, do you want to send them my way? You can just tell them to come my way. Thank you.
They had me on the thing for today in the evening, and I didn't get called. Oh, okay. I was just
Let's see. So what's your name?
Lance, right?
Oh, no, we do not have you. Okay, let me...
Yeah, I was like, whoops.
That was supposed to be for today, so sorry. Okay,
Yeah.
let's see if we have you in for tomorrow.
I speak on a panel in the morning.
Okay. Grants right. Oh, Lance. Oh, Lance. Okay, very good. There you are, Lance. Right. So you're in the afternoon tomorrow, 4:50.
You guys gonna make me drive back to LA late. That's okay.
Sugar, is that okay?
Yeah, it's fine. I mean, yeah, they said that's fine.
Okay.
Thank you very much.
Lance. Oh, he left. Okay. Well, he can come see one of us, or I'm sure I'll reach out to the team later today or tomorrow.